மாட்டணும். இப்போ ஓகேவாமா? ட்ரெஸ் மாத்தி அழுறிய. சரி வாமா வாமா. அழுவாதம்மா. சரி 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 சரிம்மா. யார் அடிச்சா? அழுவாதம்மா. சரி. போர் அடிக்குது. மா பாப்பா ஏத்துக்கிட்டம்மா. அழுறா மா. அம்மா கூப்பிட்டா காதை கேட்காது. சரி பாட்டியாவது கூப்பிடலாம். பாட்டி. அச்சோ பாட்டி வர தூங்குறாங்களே. பாப்பா வேற அழுறா. சரி சரிம்மா அழுவாத. வா வா வா. ஓ உச்சி ஒட்டியா? அதனாலதான் அழுவுறியா? சரி வாமா. பாயில படுத்துருமா. வந்துடுறேன். எங்க பாப்பா ட்ரெஸ்? இங்க இருக்கு. இது எடுத்து சீக்கிரம் போய் இந்த சூச்சு ட்ரெஸ் இப்படி கழட்டி இது இப்படி தூக்கி போட்டு இது இப்படி மாட்டணும். இப்போ ஓகேவாமா? ட்ரெஸ் மாத்தி அழுறிய. சரி வாமா வாமா. அழுவாதம்மா. சரி 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 சரிம்மா. யார் அடிச்சா? அழுவாதம்மா. சரி. போர் அடிக்குது. மா பாப்பா ஏத்துக்கிட்டம்மா. அழுறா மா. அம்மா கூப்பிட்டா காதை கேட்காது. சரி பாட்டியாவது கூப்பிடலாம். பாட்டி. அச்சோ பாட்டி வர தூங்குறாங்களே. பாப்பா வேற அழுறா. சரி சரிம்மா அழுவாத. வா வா வா. ஓ உச்சி ஒட்டியா? அதனாலதான் அழுவுறியா? சரி வாமா. பாயில படுத்துருமா. வந்துடுறேன். எங்க பாப்பா ட்ரெஸ்? இங்க இருக்கு. இது எடுத்து சீக்கிரம் போய் இந்த சூச்சு ட்ரெஸ் இப்படி கழட்டி இது இப்படி தூக்கி போட்டு இது இப்படி மாட்டணும். இப்போ ஓகேவாமா? ட்ரெஸ் மாத்தி அழுறிய. சரி வாமா வாமா. அழுவாதம்மா. சரி 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 சரிம்மா. யார் அடிச்சா? அழுவாதம்மா. சரி. போர் அடிக்குது. மா பாப்பா ஏத்துக்கிட்டம்மா. அழுறா மா. அம்மா கூப்பிட்டா காதை கேட்காது. சரி பாட்டியாவது கூப்பிடலாம். பாட்டி. அச்சோ பாட்டி வர தூங்குறாங்களே. பாப்பா வேற அழுறா. சரி சரிம்மா அழுவாத. வா வா வா. ஓ உச்சி ஒட்டியா? அதனாலதான் அழுவுறியா? இது இப்படி தூக்கி போட்டு இது இப்படி மாட்டணும். இப்போ ஓகேவாமா? ட்ரெஸ் மாத்தி அழுறிய. சரி வாமா வாமா. அழுவாதம்மா. சரி 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 சரிம்மா. யார் அடிச்சா? அழுவாதம்மா. சரி. போர் அடிக்குது. மா பாப்பா ஏத்துக்கிட்டம்மா. அழுறா மா. அம்மா கூப்பிட்டா காதை கேட்காது. சரி பாட்டியாவது கூப்பிடலாம். பாட்டி. அச்சோ பாட்டி வர தூங்குறாங்களே. பாப்பா வேற அழுறா. சரி சரிம்மா அழுவாத. வா வா வா. ஓ உச்சி ஒட்டியா? அதனாலதான் அழுவுறியா? சரி வாமா. பாயில படுத்துருமா. வந்துடுறேன். எங்க பாப்பா ட்ரெஸ்? இங்க இருக்கு. இது எடுத்து சீக்கிரம் போய் இந்த சூச்சு ட்ரெஸ் இப்படி கழட்டி இது இப்படி தூக்கி போட்டு இது இப்படி மாட்டணும். இப்போ ஓகேவாமா? ட்ரெஸ் மாத்தி அழுறிய. சரி வாமா வாமா. அழுவாதம்மா. சரி 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 சரிம்மா. யார் அடிச்சா? அழுவாதம்மா. சரி. போர் அடிக்குது. மா பாப்பா ஏத்துக்கிட்டம்மா. அழுறா மா. அம்மா கூப்பிட்டா காதை கேட்காது. சரி பாட்டியாவது கூப்பிடலாம். பாட்டி. அச்சோ பாட்டி வர தூங்குறாங்களே. பாப்பா வேற அழுறா. சரி சரிம்மா அழுவாத. வா வா வா. ஓ உச்சி ஒட்டியா? அதனாலதான் அழுவுறியா? சரி வாமா. பாயில படுத்துருமா. வந்துடுறேன். எங்க பாப்பா ட்ரெஸ்? இங்க இருக்கு. இது எடுத்து சீக்கிரம் போய் இந்த சூச்சு ட்ரெஸ் இப்படி கழட்டி இது இப்படி தூக்கி போட்டு இது இப்படி மாட்டணும். இப்போ ஓகேவாமா? ட்ரெஸ் மாத்தி அழுறிய. சரி வாமா வாமா. அழுவாதம்மா. சரி 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 சரிம்மா. யார் அடிச்சா? அழுவாதம்மா. சரி. போர் அடிக்குது. மா பாப்பா ஏத்துக்கிட்டம்மா. அழுறா மா. அம்மா கூப்பிட்டா காதை கேட்காது. சரி பாட்டியாவது கூப்பிடலாம். பாட்டி. அச்சச்சோ, பாட்டி வேற தூங்குறாங்களே. பாப்பா வேற அழுவுறா. சரி சரிம்மா, அழுவாத. வா வா வா. ஓ, உச்சவட்டியா? அதனாலதான் அழுவுறியா? இது இப்படி தூக்கி போட்டு இது இப்படி மாட்டணும். இப்போ ஓகேவாமா? ட்ரெஸ் மாத்தி அழுவுறியே. சரி வாமா வாமா, அழுவாதம்மா. சரி 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 சரிம்மா. யார் அடிச்சா? அழுவாதம்மா. சரி. போர் அடிக்குது. மா, பாப்பா ஏஞ்சிக்கிட்டாமா, அழுறா. மா. அம்மா கூப்பிட்டா காதே கேட்காது. சரி பாட்டியாவது கூப்பிடலாம். பாட்டி. அச்சச்சோ, பாட்டி வேற தூங்குறாங்களே. பாப்பா வேற அழுவுறா. சரி சரிம்மா, அழுவாத. வா வா வா. ஓ, உச்ச
ஹலோ. ஹலோ. ஹலோ, மைக் செக். ஹலோ ஹலோ. ஹலோ ஹலோ ஹலோ.
இதுல ரெகுலர் ஃப்ளோரை போடுங்க, இந்த லோ ஃப்ளோரெல்லாம் வேண்டாம். ரைட், நார்மல் ஃப்ளோரா போடுங்க. But your view is fine, right?
My view is fine now, right now.
We can adjust it, that's okay. That's not a problem. Just adjust now. Yeah.
And it has got some little bit of autofocus also.
Yeah.
Show me the laptop screen, not the phone screen.
Now you adjust it.
So you want your hand in the middle?
Yeah, my fingers. No, this is what I want to see.
Okay.
Yeah, and make the field. Okay, this is good. Now make the field a little bigger so that little wider. If you that.
Yeah, I can go up and do it. This is fine, right?
Now, okay. Now you see, I am seeing a lot of space here.
Yeah.
I'm seeing less of space there. So can you just adjust? Yeah.
That's fine.
Perfect.
I can try to do it more if.
No. This is good. I think let's try to retain this.
Your view is comfortable.
Yeah. On the arterial line, another flush panni 200 centimeter line போட்டு keep one peripheral flush also. Get me one 7 glove. பரவாயில்ல எனக்கு பரவாயில்ல இட்ஸ் ஓகே இதுல V1 ஆவது வருமா இல்ல எது எல்லாமே அங்கதான் போகும் ஓகே வேண்டாம் அது வேண்டாம் what you do is it's okay if somebody else from there tells that position is fine. I will go by anatomy mostly, no problem. அப்படியே பரவாயில்ல do it quickly man. அங்க எல்லாம் just recheck once again. Is it possible that one of you can have a monitor of whether this camera is continuing to be connected? Is it ketamine or Zamdex or propofol? கொஞ்சம் டேபிள் அந்த பக்கம் நகர்த்துங்க correct yeah okay ஒரே ஒரு LAO plain LAO ஒரு 45 ல கொடுங்க கொஞ்சம் டேபிள கீழே இறக்குங்க அப்படி இல்ல, சாரி, அதர் டைரக்ஷன். ஆ ஆ ரைட், இட்ஸ் ஓகே, இட்ஸ் ஓகே. ஆ இந்த 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 சீனரி டெலீட் பண்ணுங்க.
ஸ்டடி க்ளோஸ் பண்ணாதான் ரிமூவ் பண்ண முடியும் இந்த விஷயம் இல்லை.
திரும்ப ஆஃப் பண்ணிட்டு ஆன் பண்ணுமா இதை? That arterial line, why did it go? Okay. My camera also, like whatever I am seeing, are you able to see the same camera?
I have been looking at, yes.
Okay. So for example, now if I'm seeing the femoral venous sheath and femoral arterial, the short
Yeah,
cannula,
absolutely.
we are able to see this?
Yeah. So whatever your vision, we have been absolutely be clear.
So my fingers.
Yes.
Okay.
Whatever
Fine.
you have
So,
been seeing, it is extremely clear on the screen here.
Okay. So I'll tell you what has been obtained till now. So this is an young girl who had a combination of a large secondum atrial septal defect plus AV nodal block. So our plan was to do a ASD closure as well as a pacemaker implantation.
Okay, Shiva.
We spaced.
Shiva, formally, the case is going to be introduced,
Okay.
by one of your residents.
Then Ishita can now present. So that then I will wait for her presentation.
I think her presentation is ready. She's going to be speaking about the case in detail.
Yeah. Get me one more seven. Can you, Prabhu, show the RAO and LAO again? RAO?
Good morning, everyone. Sorry for the delay. This is for the people attending online. We are sorry that we started late. We were supposed to start at 8 o'clock, but because of some technical issues, we are starting now. The two presentations that were there in the talk, in the brochure, will be done later in between the cases. So you have not missed anything as of now. Now we will be starting with our first case. Our resident Dr. Ishita will be presenting the case now, and then we will go to lab and we will be starting the case live. Thank you.
Good morning, everyone. This is a case of a 9-year-old female weighing 21.5 kg. She is the first child of parents. Mother had SLE. Baby was
Prabhu, light இப்படி கொண்டு வா. கொஞ்சம் மேலே இருந்து வரட்டும். Aparna, I am not hearing the voice from there. Is the presentation over or is the presentation? Okay.
Can you
I
hear
don't
me,
have-
sir? I'm Dr.
I can
Pramod
hear you.
here. Can you hear me, sir? Shivkumar, sir?
I can hear you.
Yeah, sir. We are live. Actually, the case presentation is over. Now you can start, sir.
Now, what I was trying to tell before was that whenever it is a combination of ASD and a complete heart block, this is common in patients who have Holt-Oram syndrome, as Holt-Oram syndrome sometimes can manifest with a very clear clinical evidence of a hand abnormality. But sometimes a TBX5 mutation can just present as prolonged PR interval, varying degrees of AV nodal block or complete heart block in the setting of a secondary atrial septal defect and without any hand abnormalities also. So this is one such child who had a complete heart block. Now, if we put in the pacemaker leads may get a thrombus, and the thrombus may migrate paradoxically to the left side and cause a systemic embolism. So it is important to close the ASD. The timing between when to close the ASD and when to close the pacemaker. If we do it the pacemaker first and then do the ASD a little later, we are exposing the patient for a short period of time for a risk of systemic thromboembolism. If you do the ASD device first and then the pacemaker next, we have already put in a device that is going to be protecting from a systemic thromboembolism, and then we are doing the pacemaker implantation. In the past, I used to be very enthusiastic in combining both these procedures. Yesterday, I was mentioning a few of our friends. Whenever it is done, the ASD device closure takes about 45 minutes to 1 hour, and then the pacemaker takes about 1.5 to 2 hours. A prolonged period of exposure in the hospital. A couple of patients got into some pacemaker pocket infection, and so we decided that a prolonged procedure is to be avoided. So right now, if the patient is hemodynamically very stable and tolerating that complete heart block, we do the ASD first, and then give a period of 3 to 4 months for some amount of endothelialization, and then go ahead with the pacemaker implantation. We cannot do it within 1 week and all, because ASD device closure will be followed by antiplatelet therapy, and unnecessarily opening a pocket on antiplatelet is also not a great idea. So we want to give a little spaced time, stop the antiplatelets, and then open the pacemakers. So this is the logic behind spacing out initially the ASD device and then the pacemaker implantation. Now, in this particular patient, what we did was, is the fluoroscopy also live for you? The fluoroscopy also? Okay. So what you are now seeing is a right ventricular angiogram. In our usual lab, we will have only V1 electrode. This being an pathology lab, we have a provision for V1 to V6, all the electrodes. However, when we conventionally do this, the conduction system pacings, we only have a V1 electrode. So we make just a hand puff of contrast in the right ventricle to delineate the tricuspid valve annulus. For example, in this particular patient, the tricuspid annulus is overlying the V1 electrode. Unfortunately for us, there is another landmark also, the ASD device. So the anterior edge of the ASD device, a little anterior to that will be the region of his, and a little anterior to that will be the region of left bundle. The second picture that we took was, show the LAO. Show the LAO. Yeah. So the second procedure, this is delineating the whole of the inlet ventricular septum. So we are able to see the whole of the, freeze it. So we are able to see the whole of the inlet ventricular septum, and let us try to orient all the, okay. So on the left extreme of the screen, we are seeing the V1 electrode, then the V2, then the V3, V4, V5. So between the V3 and V4 leads is the interventricular septum. And the ASD device is seen just to the left, to the right of the screen. On the ASD device will be the region of the his bundle, and so that is the second sort of landmark. After this, we put in we always take a 7 French venous sheath, and okay, next picture. Then we go into the innominate vein. Next picture. Okay, we go into the innominate vein and make one hand injection contrast in that innominate vein, with just an end hole catheter, like a right coronary or a multipurpose catheter. So this is to delineate the whole of the innominate vein and find out whether there are 2-3 small territories or whether there is one big large territory. So here the catheter is already lying in the largest axillary vein. So we just exchange it into a coronary wire there to serve as a landmark, and then take out this right coronary catheter. So with the coronary wire, there will be a space around in that 7 French sheet. So then subsequently what we do is we put in the, give me the fluoroscopy screen also. We put in the temporary pacing lead. The temporary pacing lead serves as an additional landmark for identifying somewhere the region of the right ventricular apex. Now the next step is blade, please. Local anesthesia, please. So the next step is infiltration of local anesthesia. So since we have the guide wire is going to give, position the, yeah. So now I'm just keeping the needle on the top. So this is you are able to visualize my guide wire. And in this area, I'm going to be infiltrating the local anesthesia. Give 1 extra dose of ketamine, please. So I'm infiltrating. Little bit more xylocaine. Local. So I'll infiltrate a little bit of local anesthesia in the entire region. The region where the potential pocket is there, in that whole area I am infiltrating. So I wait for some time for the blade. The moment I cut, when there is a bleeding, immediately put the, so I try to take the table up, the IA up, no need to be so, okay. So here I'm just positioning my incision. So my incision will be marginally be above the level of the guide wire. So I'm making a keep on mopping. So in majority of the cases, I try to avoid electrocautery, because cautery produces some amount of coagulation necrosis of the tissue, and the coagulation necrosis of the tissue can slightly impair the healing, because there will be more of necrotic tissue in the wound. So I tend to avoid electrocautery as much as possible. Artery forceps, 2-3 mosquito forceps. Give a curved one. Give the phones off. Give another. This patient, see, they're all not catching. Okay. This patient is off aspirin, no? When was the aspirin stopped? Ishita, yesterday aspirin was given. Okay. So our team says that yesterday also aspirin was given. So basically, the logic behind this whole procedure is that it should be avoided. It should be stopped for about 5 days in advance. So the spacing out of this entire procedure probably, I mean, it shows that we need to be more coordinated and.
So this is Anindya. Hello, sir.
Anindya, I'm hearing you.
Sir, there was a question from the audience.
Yeah.
Where do you actually make the pocket? Above the pectoralis or subpectoral in a...
Subpectoral. I'm going to show it.
Okay. So
Actually,
always,
now,
do you always do it subpectoral, or do you make it above the pectoralis in adult congenital heart diseases?
In adults, always it is above the clavipectoral fascia. See, now what I'm seeing is the clavipectoral fascia. This whitish structure is the clavipectoral fascia. Always it will be above the clavipectoral fascia. Only in children, where we expect that the skin and subcutaneous tissues are not good enough to hold the these artery fossils are all not holding it on. Ideally speaking, some 4 or 5 days before, if the aspirin is stopped, quantum of this sort of oozing will be far less, and it will make the procedure far more easier. Okay, get the blade again. So now I am in the plane of clavipectoral fascia. Get me a curved scissor, sister. One Alice forceps. So right now I am lifting the subcutaneous tissue above the clavipectoral fascia and making an incision just in front of the clavipectoral fascia. Keep on mopping. Usually, this region above the clavipectoral fascia is a reasonably avascular plane. Curved scissor. Are you seeing whatever I am seeing in the camera?
Able to see it, yes.
You able to see?
Yes, we are able to see.
Okay. So now this is not the pocket. I'm actually creating an exposure of the pectoralis major muscle so that I identify the plane of the fibers in pectoralis major and then make a longitudinal incision on that area. So I am now in front of the pectoralis major. Alice forceps. Okay. Take this, Alice. Okay, sister, get me a retractor, a small retractor. A smaller than this. So this is the plane of the pectoralis major. So I am now dissecting a little bit more ketamine.
So one quick question: what kind of a
Yes.
sedation would you prefer in pediatric age group, sir?
What kind of?
A sedation for the procedure.
Okay, quite often what we do is we do it on a combination of little bit of fentanyl, little bit of ketamine, and little bit of midazolam. If there is a anesthetist around to monitor, then we sometimes go for propofol also. Midazolam and propofol produce some degree of hypotension, whereas ketamine does not produce too much of hypotension. So we tend to prefer, if possible, ketamine as a preferred anesthetic agent. Okay, now just hold it. Don't lift too much. Just a blade. Sorry, scissor. A little bit more sedation, Giri. So I'm going in the plane below the pectoralis muscle now. We normally see the plane of the pectoralis muscles and all very clearly. Here it's a little bit confused because of possibly the antiplatelet effect that the patient is continuing to have. I'm trying to cut off the clavipectoral fascia. So this is my finger is now in the subpectoral region. I'm going to be little bit enlarging the subpectoral region.
Sir,
Yeah.
Siddharth here, sir. Would it be
Yes, Siddharth.
useful to infiltrate a little bit of local anesthesia at this level so that the intravenous anesthesia would be a little less?
Can be, yeah. We'll do that. I think it's a good point. A little bit more local anesthesia. Not Anavin. You give 2% xylocaine. Don't pull. It's unfortunate that aspirin was overlooked. Don't pull so much. The muscle will get torn. Blade, the scissor. Alice forceps. Just mop it. So I'm making a blunt finger dissection below the plane of the pectoralis major. I need to create a entry opening now. So my finger is actually lifting the pectoralis major's lateral part. I'll show the structures. This is the skin and subcutaneous tissue. What I'm getting, what I'm lifting is the pectoralis major muscle. So I am putting a gauze piece under the pectoralis major muscle. I'm just putting a couple of fingers inside. It is important to avoid tension on the pocket. Like it should not be something bulging. The generator should not be bulging. There should be a little bit more space than what the generator needs, so that the muscles just passively go and support the generator, rather than trying to pack it and try to pull the two heads of the pectoralis major and try to get the suture. So now this is just adequate. I'll try to make it a little bit more larger. Towards the insertion also I'll make. So now, so this the whole place, the whole three fingers are below the pectoralis major now. So that is this is the pectoralis major. So we have, it should be okay. Now on the superior aspect also I will try to make some dissections. It looks okay to me. So if I, at the end of the procedure, if I approximate these two muscles, I should be able to get a pocket buried underneath. So this, okay, now get me initially some dry gauze piece. So the dry gauze piece should act like a trigger the coagulation pathway and create some more hemostasis. After a few minutes, I will probably change it into an antibiotic soaked gauze piece. So right now it is dry gauze piece to trigger the, we'll take the antibiotic soaked gauze piece after that. Let it be there. I'll ask you. Okay, now we are going for the puncture. So can you get me the puncture needle? I'll just wash my hands in the bowl of water. Now, in extremely small children, we will sometimes take the pediatric needle and put in the pediatric wire, the 018 wire, and through that 018 wire, we will put in a pediatric 5 French sheath, then put in the 3-5 wire and get in the regular sheath. This girl being a little bit grown up, I'll probably take a chance. Get me the retractor, the small retractor. Gently. Okay. So now I'm going to go for fluoroscopy. No need to keep it so low. Keep it like, yeah. So I'm targeting the guide wire. Okay, I will. Let me take out this gauze piece is preventing me from angulating the just once. A little bit more scissor. I'll make a little cut. There is some tension on this area. Gauze piece. Keep a pediatric puncture needle and a wire also ready. Get a new 5 French pediatric sheath also. Mop it nicely. Get me a pediatric puncture needle. Get the blade a little bit more. So I am taking a smaller needle with a smaller wire now. It's a 5 or 6 French. Sheath, 6 French pediatric sheath. Hello. Yes.
Yes, Shiva, we are hearing you, Shiva.
No. I heard some question like somebody telling hello. So
No, the discussion was, is it really necessary to demonstrate the venous anatomy, either through the venogram or
see, this
for
is going
passing?
into the pleural cavity. See here.
Yeah,
This is entering into the pleural cavity.
yeah.
Yeah. Okay. Get it. Mop it. So that previous entry was actually going more into the pleural cavity. A little bit more. Give a blade a little bit more laterally. I will go. Okay. The retractor. One more. Small. You don't have? Okay.
There is not much. Not.
Get the light a little.
So the practice was to do a puncture only first. But
Yes.
here when I came, it's pocket first. And when I have seen in international conferences also, they'll take the pocket only first. They got
So this is going in the other direction. I just need to deflect it.
I have not done it, but a lot of operators will do a cephalic cut down. Yes, sir. Yes, sir.
Show me down.
So I'll ask this to Shiv Kumar sir because I have never done a cephalic cut down. Sir, there is a question from the audience.
Yeah, long ago, and I heard it, long ago when we were all students, like 25 years before, this sheets were not freely available. So we used to do a cut down. Now, for that purpose, now currently the incisions are going a little bit more in the deltopectoral and more in the infraclavicular area. Whereas the incision, the skin incisions for that will be a little bit more superior. I see this is the region of the deltoid. So this is the anterior fibers of the deltoid. So this will be below that region and above the pectoralis major. So this place will be the region of the deltopectoral groove. And here you will be targeting the, you have to dissect and you have to get the cephalic vein. It used to be very challenging, but fortunately, many of our veteran professors and all were too good in getting this cephalic veins, and they used to. And those are the days when single chamber pacemakers are the norm. Like everybody will get only a single chamber pacemaker. Even a 6-sinus syndrome will get a single chamber pacemaker, single chamber ventricular pacemaker. So we used to have these cut downs, but it soon went away. Ullas, what do you have an experience of this? I have asked, as a postgraduate student, I have seen many delta pectoral groove incisions, cephalic cut downs, but I have not practiced it. Ullas, is there?
Sir, as you said correctly, it is okay if you have a single axis, a single lead to be put in. Cephalic cut down, cephalic vein cut down is really useful. But now when we use conduction system
what
pacing,
you save is cost of the sheath.
yes, sir.
Today they are all becoming very proportionately less expensive. The procedural expenses are far more than the cost of the sheath and all. So probably, I mean, when we started catheterizing, we did not have even a check flow in the valves. We used to have non-check flow sheets for femoral venous and arterial punctures, and we used to do CATs. I mean, then it evolved into check flow valves, hemostatic valves. Okay. So basically, I am converting the same single into two. This saves a little bit of time. Okay, now we are ready for. I'm leaving the other wire open now. I want the CS catheter, Thermo J wire, antibiotic gauze. Now we can keep it. Sister, now give me the antibiotic soaked gauze pieces. It has been a customary practice for us to keep some soaked gauze pieces with cefuroxime in the pocket till the time, say 3, I am giving 3, sister. How much this is going to increase the sterility and reduce the chances of pacemaker infection is not known. Give me, put in the guide wire.
Tyrex has
So
been
right
shown
now,
to reduce infections, but it is prohibitively costly, 75 to 80,000 per envelope. And ideally, they recommended it not during the first implant, and during a redo case or a prior infected case.
this is what the pacemakers which have the antibiotic, the antibacterial film, is it?
Yes, sir, the Tyrex envelope.
Yeah. I think a lot of
Cefuroxime here.
show the heart fully.
Yes, sir. So, sir,
I'm trying to just direct a plain guide wire into the outflow tract if possible.
yes, it went. It went.
Okay. So now I'm going to get the sheath inside. Sister, get me some gauze with saline. Hold the wire.
So he went there. Yes. Taken the dilator out. Now it's in the RVD. Only sheath is going. He has taken the dilator out, I think. Yes. Actually, sir, have you taken the dilator out, sir?
Dilator is partially out, but it's not turning. So let me see. Initially I had, now I am with the dilator. Let me try to re-advance the.
Sheet, this short sheet which they have given is actually a wall sheet. Normally we are used to pinch in the diabetic sheet, but this is called a straight sheet. So you don't need to pinch. Even if you just leave it, it will not back. This is Medtronic has acquired it. It is not their sheet. It's a third party sheet. It's called Safe Sheet.
It fails to cross this area. Okay.
We went through trabecal
manipulate.
and then so we'll
So get me the lead now. I will try to manipulate from get me the water. So we are now entering through this sheath. Show the okay. So right now I'm trying to come out. Let me see.
RAO, sir. RAO 20 or RAO 30, sir. That is the first.
RAO. The same RAO view.
So RAO is the view where you again see the entire septum and then decide to place it as proximal as possible.
So show. So now I'm coming out. It's going more inferiorly than what I want. I'll try to re-enter. The pacing lead itself.
Shiva, whenever you are manipulating the catheter, let's have the 2D picture also.
Okay. See, I'm looking at the fluoroscopic screen and manipulating.
The bigger one,
so
yes. Yeah. Occasionally during the manipulations in the anterior superior aspect, you may, without pacing, just the catheter manipulation may actually give you that
I'm giving,
pattern.
actually right now what I have done is I have given the counterclockwise torque to make it touch the sort of septum. Okay, now show that RV angiogram once. We'll just reorient ourselves. That RV angiogram. The RAO. Yeah. So if you look at here, the V1 lead was almost at the region of tricuspid annulus. Now show me my fluoroscopy. So I am just distal to that V1 lead. Now go to LAO. Tesu, come here, Tesu. Yeah. See this one. You hold this here. That's it. So it is okay. It's touching the region of the septum. I'm happy about this area. I'm now going to hold it left with your right hand. You hold there, and with your left hand hold it with the same tar. So now I am connecting the skin electrode and now I am connecting the tip to the now I'm going to allow the lead to go and touch the septum. Okay, can you get V1? See the I don't see V1. Okay. Can you just place that area? Lot of artifacts are there. Okay. You are facing now. Dr. Ullas or Anindya, you can see anatomically I reached the place where I wanted to reach. I will just show the LAO angiogram. Continue to hold it in the same place. I'm making a small amount of contrast injection through the side of the sheath in order to show
you shall be doing it both in the RAO and the LAO view.
Basically in the RAO I had already shown it on my. Go back to RAO. In LAO I give because the septum will be delineated. In RAO septum will not be delineated.
Yes.
You can see a tiny amount of air getting pocketed in the pulmonary artery. Probably in the side arm of the sheath there was a tiny amount of air that went in. Should not be of major consequence. So now, see, this is the RAO. In RAO what we were targeting was, show that RV angiogram. That original RV angiogram in the same RV angiogram in RAO view was showing the V1 electrode, which is just lying to the right side of the AST device, was the region of the tricuspid annulus, and we are able to see the apex on the right extreme. So if I anatomically put a line between the tip of the V1 electrode to the apex and divide it into 4 quadrants, I should be having a lead in the first 1/4, last 3/4. So this is now anatomically it looks like I am okay in that area. In the come back to this one, septum LAO view. So what I'm going to do is I'm just removing my glove, because in order to screw the lead, it will be nicer to have a dry this one. So currently I'm disconnecting it from make it mag.
So what LAO this is?
So this is LAO. What is the degree? 24. LAO. I'll go to the same LAO, the original LAO that you originally gave, and show that LAO picture again. LAO angiogram again. I have again connected the tip. You can look at the electrograms. You can look at the pacing and see who is here. I have connected. Who is listening to me? See, I have connected the tip. So now you start pacing and see. I have entered the LV a little bit.
So can you show the connections once? Sir,
He said,
can you show
sir,
the connections? Can you show the connections, sir, once?
see, this is the tip electrode connected to the black, and the red is IA up. The red is now connected to the skin. I will again show it. I'll open it out.
Sir, the IA is still seen, sir.
Are you able to see it now? This is the red. This is the black.
1 second.
Are you facing?
Oh, 1 second, sir.
You have to face it around 120 or so.
Can you
Can
go
you?
live screen only? Only live screen, no delay screen.
Red cable should be? It's there in good contact.
No, same screen you are using now, live and review. Show the live. Actually, zoom this.
It's not capturing? Okay. You are getting any R voltages there? Which connection? Red one is completely touching the skin.
It's now better.
Okay. 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 Now let me see the fluoroscopy.
So 2 and 3 both are positive. AVL, AVR both are negative. So it's like more outflow.
More in the outflow, is it?
Yes, sir. It's like more like outflow, sir.
Outflow. Okay. Now I will actually it is facing very superiorly. So what I will do is unscrewing and disconnecting it. Leave it, Tejasvi. Yeah. Can you give the same? See, I have. Yeah. Keep it there. Right now. I am now trying to go. It's again getting angulated. Let me make one septogram. Give me some contrast.
Before you go septogram, Shiva, I think again adjusting it in the RAO could be okay, and then come to the LAO, please.
Just 1 second. I'm just injecting. Okay. See this. Start. Paste this area. Come to RAO, but paste this area.
Yeah,
Go to RAO 30, the same view. Show the whole of the heart. Okay. See, I have to be distal to the tricuspid valve. I cannot come pretty close. So in RAO, the position looks okay to me, Dr. Less. What do you say?
Yeah, sure. But I think you have penetrated the septum of the RVOT because when you did the angio.
Come back to LAO.
If you review the
Or
LAO
else,
angio.
No, but I'm disconnecting it. I'll come a little bit more proximal. Show me in yellow. Yeah, just stay here. Leave it.
Shiva, as it climbs vertically upwards, you are going towards the outflow tract. Maybe you will have to withdraw the lead.
Just a second. Hold it. No, don't lose it. Yeah. Check here. Get me one contrast. Yeah. Why there is so much of artifact in all the lines? Okay, so this area, I am just making one septogram. Take your hands out. I am my what I'm just pushing it a little. Come to RAO once. Yeah. Okay, go back to LAO. Okay, hold it. Check the pattern here. Give the contrast. Facing on. Okay. I'll do that. I'm just injecting a small amount of contrast to see.
Now the current side is 2 positive, 3 negative, sir. AVL positive, AVR negative. There is a notch in maybe V1.
Okay.
I think the transition is also very good. Let's see.
I'm drying my hand every time.
It is always better to have that 2D screen in a higher speed, maybe about 50, 100. What is the speed now? What is the 2D screen speed?
Aparna, Dr. Ullas is asking what is the 2D screen speed? Is it 25? 50? Okay, make it 100.
Yeah, so the notches will be seen clearly. Yeah.
Everything is
So now, patience, see the contrast. Lot of artifacts only I am seeing.
Yeah.
Yeah. Yeah, I screwed in a little bit more.
So in V1, sir, there is the notch is moved rightwards. Maybe there is a small R coming up. Lead 2 and 3 are positive. AVR is negative. AVL is like
Too much of artifacts, too much of spikes here and there. What is the reason for that?
freeze it. Freeze the screen, please.
Yeah, so now,
Freeze the screen.
yeah, now freeze. And then bring that up.
Yeah, they are asking you to freeze the screen.
Frozen screen, 100 speed.
100 speed.
100 speed. Yeah.
Fix it there.
Yeah, see the V1, you have that kind of a R prime is coming up there. And you have a transition at V4. And you have a positive R in 2, negative in 3, AVR, AVL discordant. So this is like almost proximal part of the left bundle. And you could consider that it is nearer the left anterior fascicle.
Hold in the same position.
Yeah. And then you can actually do one last septogram. In the meanwhile, you could tell us about the LVAT and R-wave peak time at this stage. And you should also be telling us what is the impedance of the unipolar.
That is 79.
79. So anything less than 80 is okay. And we'll discuss what is LVAT.
And the impedance of the tip.
I just disconnected for a couple of more screws inside.
Before screwing in, the impedance could be measured.
Yeah. I'm now again connecting to the tip electrode, the septogram. Now again connected, check the impedance, check the, he says it's 1400.
Yes, okay. And Aparna, on the PSA, if you can show some injury pattern.
Aparna, they want you to show the injury pattern on the PSA.
Yeah, okay. So there's a, yeah.
Septogram, yes, sir. It's nicely inside, sir.
Yeah, it is sort of oblique. Now come to RAO. RAO and show the position. Show it for me to understand in 25 speed. When, I mean, this is electrophysiology speed, common cardiology speed. Which one?
This one.
Yeah, it looks, I mean, it looks reasonably okay to me.
No, it is not reasonably okay. It is fantastic. It's absolutely
okay. I was thinking other way will tell. Okay. See, basically, I know Dr. Anindya and Ullas will be like able to see the electric. Normally, what I look at is, I mean, a narrow QRS. And anatomically, my position should be go to 30. Go to show that RAO angiogram once again. That RAO angiogram once again. Yeah. So in this angiogram, I see this is V1 is that the first electrode. So I need to be distal to the V1, and I need to be somewhere around 1/4 distance between. Okay. See, I am in anatomical position. I am okay here. because I am just distal to that V1 electrode, and I am reasonably proximal to the septum. Now come to LAO view. Show that LAO picture once again. Yeah. So this LAO picture, go to the same LAO 45 or so. 45 or so. Okay, now freeze the RV. When the RV, okay, freeze it. Okay, okay. So that is the region. So here it is, V1 is on the left extreme of the screen. Then comes V2 in the body of the RV. Then comes V3 at the RV apex, V4 at LV apex, V5 just outside the LV apex. So these are the 5 electrodes that we are seeing. So in this position, yeah, it is probably very oblique.
Sir, you have to pull the
lead
sheet back a little bit, sir.
Which one?
Pull the sheet little back, sir. It is stressing the lead.
Yeah, I'll do that.
Okay, sir.
Yeah,
This is
yeah,
good.
you know,
Hold it. Yeah, I will do the ring capture now.
yes, and a part of the ring at least has to be there inside the septum.
Yeah. Yeah, now we are facing the ring.
If only the tip is touching the endocardium, you know, there is going to be a.
Yeah, the ring is not capturing.
So.
No, the ring is not capturing. Let me see whether it is correctly connected. Give me some water. Just I am putting to the tip only. Tip is capturing?
Tip is capturing, sir. QR, good axis, normal axis, 2 positive, 3 less positive, AVL positive, AVR negative.
Okay, now I am going to the ring.
Model transition at V3.
So ring is not in contact is a bad sign.
But it's okay, sir.
Yeah. So I was wondering, the impedance had been about 800.
What was the
what was the
like?
tip
Say, okay,
impedance?
See, now I am at the tip. I am not happy about that ring not capturing. Dr. Ullas wants to know the impedance at this point. Huh? He says it's 1250. Okay, I'm just connecting it to bipolar now.
In the bipolar, what are you going to expect, the change in the morphology here?
Not a change in the morphology, little more thin, like a sleeker.
Because only the tip is capturing. So even in the bipolar, no, the morphology is not going to be.
Okay, now it is on bipolar. Bipolar impedance is 960, it seems. Okay.
This is a good result, sir.
In a child, Shiva, in a child trying to push it inwards to get the ring capture, you know, might result in a perforation.
Okay.
As long as your goal is to get a narrow QRS.
This is at what speed? Can you make it 25?
See, it looks at 25 speed. It looks very sleek, like almost like a normal QRS.
Yeah, 2-3 AVF positive. Yeah.
It is not
Now come
clear.
to AP. Let me see the lead stability. Come to AP. Okay. Now, Dr. Ullas, what is the threshold now on this bipolar?
No,
1.5?
Yeah.
Okay, 1.3. 1.1. 1 second, 0.9, it's getting lost. Maybe after a few minutes, it will even further reduce, I suppose. Keep it at 1 or 1.1 consistently and show that it's capturing.
Okay. So the thresholds now measured in the bipolar or in the unipolar?
Bipolar.
In the bipolar.
You want it in unipolar also?
Yeah, unipolar probably it is going to be lesser than what you got it in the bipolar.
Okay. Okay. So this is now in unipolar. You are getting 1. Go to 1.
So was there a change in morphology when they did the threshold testing, sir?
Not okay. And go to 5 and come down to 1. Go to 5. 4. 3. 2. 1. Maybe it's becoming little thinner. I don't know.
So, sir, if they make it at 50 speed, we'll be able to see better because the
Okay.
resolution here is
Yeah,
not
and
so
India
good.
wants in 50 or 100 speed, make
50
it to
speed.
their level.
So you pace at Aparna, you pace at 5 and then directly go to 1.
Aparna pace at 5 and directly go to 1.
5, sir.
So keep on pacing at 5.
Keep on pacing, so that everyone has that registered in their mind what is
Mental.
5. So is this 5, sir?
Yeah, it's 5 now. Go to 1.
Yes, there's a change.
I am not appreciating in this 100 speed.
Sir, if Aparna can show it on the free screen and then show it what was the change, we are not able to appreciate here, sir.
Yeah, I am also not appreciating.
Now, sir.
Sir, at a higher output there is a QR in V1. At a lower output the R is not so much. Those kinds of differences only mostly will be seen, sir. It will not be a gross difference.
Okay. Okay, now Dr. Ullas wanted unipolar threshold. So I am giving unipolar threshold now. Okay. Now unipolar pacing threshold. Hmm. 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 1 point? 1.6. Okay. Hmm. Hmm. Okay, it is 1.3 it's capturing. Okay, threshold is 1.3 in unipolar mode and 1 in. I think this threshold I'm not worried. I think it will come down.
The bipolar threshold was actually lower than the unipolar threshold. Because the tip is actually causing the little injury. So it is the injury effect why the threshold is on the higher side. That is why the bipolar was lower, unipolar was on the higher side. As the time goes by, in another 10-15 minutes, you may get the unipolar thresholds as good as with the bipolar thresholds.
I'll show. Leave this hand. So right now I am going to be cutting out. So what I am doing now is.
Sir, we'll show them on the fluoro screen that you have given an adequate slack. So there is a good slack and the loop is being housed in the RA as we discussed yesterday, right? So there is no stress on the lead entry point into the septum. And sir is going to slit now. So he has pressed that button. He has gotten.
I need some space here.
You can disconnect that, sir. So he has pressed that button. The lead is in that groove.
Can you place it on this side? The lead on this side.
Is it possible?
Yeah. Keep it close. So now.
So he'll be fixing the right hand and only pulling the left hand. You can see on the fluoro screen also simultaneously.
Came out in between.
Sometimes it can happen, sir. So again, you take the blade into the lumen of the sheath.
There are many ways of doing it. You can actually place your right hand onto
The patient's body.
or on the floor, and then take a grip.
Left hand, sir.
I'm trying to get the.
Sometimes when this happens, it is difficult because the cut is oblique, but sir has gotten it easily. Again, he has fixed the lead in the groove. The slack is still there. So he will just pull the left hand and the right hand being steady. So someone is also there to hold the lead when the sheath has come out of the body.
So now I will reduce the lot of loop that has not created. Shall I leave this loop, Dr. Ullas?
Yeah,
Growing
so
child?
this is the typical alpha loop in a child. I think this is perfect. And another thing is, you can actually do a little bit of a fluoro and see how much is the stress, the tip versus the ring. Maybe in the LAO view you can see
LAO?
because.
So it has to be straight.
LAO, go to that 40.
So we'll see in LAO.
It's 40.
Maybe, or we didn't go inside much. There was no need because as the septum is 8 millimeters, we reached the left bundle area very early. So there is not much.
Go to
stress.
RM.
So this is LAO view. It is entering straight, right? All this loop is in RA actually.
So the stress is not on the tip or the ring electrode. The stress is mainly on that alpha loop. So this probably will maintain the integrity of the electrodes.
Can you, you are disconnected the basic? Yes. Pace at the same previous threshold value. Come to AP.
Sir, Italy double alumni, na sir? Oh, temporary lead. Okay. Oh, temporary lead. Okay.
It's spacing or?
Spacing, sir. Same morphology. What is the output? You stopped capturing.
Now, once again, he's at 1 now.
It's not spacing, sir, because you are not connected or they have not started yet. Yes.
Now, what is the output? It's 1.3 now.
Sir, this is good, sir. QR is there in V1. You can clearly see. There is loss
1.
of around 1.
What time it is losing? 1.2 it's losing. I think maybe a few minutes later it might.
Sir, if they can now pace at 5 and then go to 1, it will be, I think there is some change in morphology. There is an RSR sometimes and there is a QR sometimes. The audience
He's
here
at 5 now.
So this
He's
is
at 5 now.
This is 5. So the 5 has some RS. That is, pace faster, please. So we should be always pace faster, not page speed. Page speed can be same only, or this is. So this is at a 5.
Pacing at 5. Yeah, go to 1.3 or so.
That is a P causing.
Okay.
Okay, there is not
One
much.
I'm not seeing any major difference.
What RSR we were thinking, that is a P wave falling on the beginning of the QRS. So I'll show you one example here if it comes. So this is the one which we were thinking. So there is a P here coming. So sometimes it comes and it makes us believe that it is an RSR. See, this may not be a QR. This may not be an RSR. This beat.
So I'm opening out the sheath and trying to fix the lead now.
So this is the walled sheath, safe sheath. There is not much news in that. So all the while you please check the lead position. So the lead is still in place.
One thumb forceps.
Safe sheath, first we have to fix the left bundle lead, sir, and then only you should try the right one. Because it doesn't, that alpha loop will not, nothing will happen, sir. Even if you pull it, it's not a, that loop is not a closed loop, sir. It is an open loop. It is actually not a knot. It has never happened to us in literature also. Oh, it has happened to you, sir. Did it dislodge the other thing? Okay, okay. It has never happened to us. So we'll, whatever loop we have, the more is good. We'll keep it
Take your hands
fixed
up.
and then we'll do the atrial lead. And then you take the shield. Okay, okay. At least
Show a
access
little
you
bit
have.
more better light here.
Yes, sir. Whenever possible, we do. Otherwise, this kind of a loop is also okay. You
Keep on
coming up and
pacing.
then yes, yes.
At, say, put it at say 1.3 or 1.4 and keep on pacing. Okay. Keep on pacing.
There is no CSB, ECG was sent from the actual patient came to OPD.
Okay. Suture.
CSB was sent to ER. Didn't see that. Okay, this is the ECG. Seven is in the lab, sir. Seven we need in the lab. Tirupati, you told me about the CSB. No, you called me again. What was it? Why you called?
No.
Called
That.
CSB only.
Just can you slightly retract this area?
Estimate. No problem. If they ask LD sir, then you admit in the LD sir. LD sir will ask us and we'll see the patient. That is okay. But what you do is, if the patient is still in LD sir, you admit in the LD sir. No problem. Okay. No issue. Sure, sir. Monday only. Why today? It is not possible today. Monday, mostly Monday only. So we'll give the estimate. Don't worry. Which estimate have you given?
Get the
Trial according to the trial we have to give the estimate.
don't pull. Take it out.
That is not included in trial.
Shiva, I think you are going to be proceeding for the right atrial read, right?
Correct.
Yeah. So before you start, let me just ask the audience to give a round of applause for the, one single shot. Okay. And, it has been the great learning, I'm sure, to all of you. So Anindya is, Shiva, Anindya is going to be around.
Yeah.
Okay, for the further discussions. Okay.
Yeah.
All right. Okay.
Sister, cut me. Just a second. Again, I'm checking the fluoroscopic position. Okay. Sister, get me the Savin French later. So I dilate that track with a 7 French sheet, 7 French dilator,
7 French sheath inside. Atrial lead. There's a little bit of snoring. You can slightly reduce the sedation. Show the sheath bus. Yeah, okay. Get me the J stillet. Yeah, so somebody is asking, show the sheath. See, now I'm introducing the J stillet into the atrial lead. Come to RAO. It's going into the RVOT. Come to AP itself. Come to RAO. Okay, now you have another set of electrode. Yeah. Can you find out what is the electrogram at the tip? Electrogram. You reduce the pacing rate from 120 to 50 or 60. Yeah. Now, are you seeing P waves or? Okay, you are not getting any V, right? Okay, I'll just drill it inside and then just
Fully out. Now check the P wave. Now check the P wave. Okay. It got disconnected. Okay. So basically, I was taking out the J on Cine so that if it is getting disconnected, I'll be able to watch. So now again, I'll reintroduce the J. Which one? Give me the. Fill in. It's entering the RV. It's now hitching against the device. Check if there is a P wave. Show the come to AP. Go to RAO 30. P wave is 2. Sister, get me this. Hey, come to AP. I'm not seeing the movement of the atrial appendage. See what is the P voltage? 1.9. Come to LAO. Pace and see. Yeah. One. Okay. No, I'm not. You are able to see. I'm not seeing the. You are seeing the. No, yeah, because I am. See, the paced I'm not able to see a capture on the surface ECG. You are seeing some electrogram there? Okay. If you are seeing the electrogram, show the electrogram to the
In the
audience.
hemodynamic screen, you can see, sir.
Huh?
In the hemodynamic screen, you can see the P waves. Hemodynamic screen.
Yeah, but when he was, see, what is the rate at which you are pacing? Okay, 150.
So there are P waves, sir. Clearly see. Yes.
Okay, now, okay, what is the output? 3.2. Okay. Hmm. Now, is it the intrinsic P wave or the your paced P wave?
Intrinsic conduction सर मैं कितने पे कर 150 पे कर रहे हैं ना सर ये पी है यहाँ पे पी है यहाँ पे पी है यहाँ पे पी है यहाँ पे पी है अभी लॉस
Increase the voltage in this hemodynamic screen. Okay, I'm going to withdraw the J stillet to see the stability. Again, I'm doing this on a cine. Now I have withdrawn it. Check the okay. Again check the P waves.
Also sir we should remember that this patient this view specifically which sir is doing
Ah.
30 but it looks like an 80 because the heart is also rotated in this patient. Spine is in the center. Sir, there is a question. Is the RA lead touching the device?
Device, yeah. I see. I'm not able to separate out the device
So we have to see in
from
orthogonal
the
view. We have to see
in
in
all the.
RA
It's a
view
large
again.
device. Now go to lateral maybe. Go more and more lateral.
Sensing, there will be sensing.
Go. Keep on going lateral.
See the lateral looks like.
Keep on going lateral.
You are asking us a lateral mechanical.
Okay, enough. Just be there. Maybe there is a make a magnification of this. Make a maximum mag. That's a maximum mag. Okay. There is some minute separation. Or you are able to see the fluoroscopic screen?
Yes, sir. We can see.
Yeah, some separation. Okay, what is the P threshold? 2. Below 2, it's not capturing. Injury is there. Okay, come back to AP. Sense V pace.
Sir, if the sensed R waves are good and there is an injury, we can still leave it.
This is sense V pace. Okay, now once just last one check the threshold of the V. I'm taking out the A sheath now. Just hold it. Hold it.
Start, but this is okay.
Hold the ventricle lead also insulin. Okay, one of you. Take the hands out. Holding. Thumb forceps. Light onto the screen. Now. take this forceps out. I'm using the sleeve as the hemostat. Thumb forceps. Suture. Yeah. Mop it fully. Take the hands out. When take out the large sheath, especially in after we taken a combined puncture, quite often the bleeding will be a little bit more. We will wait for some time for hemostasis. Mop it. Keep a single gauze so that it's easy to mop. It's two or one. Okay, take the hand. Blade. Cut it. One more suture I'll take. I'm taking a second suture. Take it out, sister. One second. It's going through the other lead. Give it back. Leave it.
You have disconnected the A sense V pace now. Why? Okay. Just I'm taking out the antibiotic gauze piece. 1, 2, 3. Drying it out. Get me the generator. Essence V pace now. Okay, just I'll see the final positions. Show the whole heart.
Dedicated track, but there has been it was published, and we have also done. Even if you don't have a dedicated sheet like this, even if you have the same thing, then also where is my primary curve in that sheet? My primary curve doesn't actually start from here. It is actually a straight portion up. The primary curve comes here, and then there is a secondary.
Get a little bit of antibiotic soaked gauze.
Because the orientation is like this, it is made to bend like this. So when
So I'm connecting the A now. Screw. Muruga, screw for the screw. Yeah.
You had everything together. No, just keep it here.
Okay. So now I'm connecting the V, that antibiotic soaked gauze. So connected to A, both. Yeah. So now I am creating a loop now. Once again, I will check the positions. So I'm trying to get the light maximum here. Yeah. So I'm trying to keep all the loops behind. Needleman, suture. Okay, muscle layer. Again, antibiotic soaked gauze piece. Are you still seeing my camera? Anindya?
Hello, sir.
No, are you still able to see my camera?
Yes, sir. We are able to see it clearly, sir.
So now, so this is the clavicular head of pectoralis major.
1 second, sir. We'll make the lighting little better. It is 1 second. Sir.
Okay, show the light a little brighter.
No, sir.
Just put your finger there. Yeah, don't press too much. This suture is only for approximating the two heads and not for tightening. If it tighten, the muscle will go into necrosis. So it needs to be a little loose. So now again I am taking the clavicular head of pectoralis major and the sternal head of pectoralis major. Just show you, I don't put a tension on it, just approximating. Put your finger.
Peak, off or on? You want to see that? It's okay. Why this is required? This is not required now. This is the main screen, full screen. So he's doing, anyways, it's closed now. So as you said, whatever I say is seen, is heard there. Okay.
So now this is the pectoralis major, and the pulse generator is actually here. It's looking covered. So now I am going for the subcutaneous tissue suturing. Thumb forceps.
Same. Vital.
You can do it continuous or interrupted. Here again, I am not putting undue tension. So that the tissues don't get necrosed.
Shiv said once. To take an continuous suture will quicken the suturing time.
but sometimes it will inadvertently add to more tension on the suture lines. And more tension on the suture lines means more necrosis, and more necrosis means more chances of extrusion. So I am trying to just get an approximation. Without tension, finger. No. They can, Anindya.
Sir?
See, I am now almost completing the subcutaneous stitches.
Sir?
So I would think it is good time for you to start your implantation technique talk.
Yes, sir, yes. I'll start that, sir. I was waiting for that answer. No problem.
Yeah, please.
So we'll go off the line.
Please.
Okay, sir. Thank you, sir.
Please.
Thank you so much. It was a very nice implant. A big round of applause, sir. And we finished before time only, sir. It's like 4 minutes before time. Yes.
Thank you.
Thank you, sir. Sorry with this. Sorry. No, it will not disconnect. So it is a continuation of the yesterday's PPT only. So we were discussing how to confirm conduction system capture. We are not bothered about left bundle area pacing because we know whenever we get RBVV, we are done with left bundle area pacing. But if we think we want to get a conduction system capture, there are ways to prove it. That feed is going on. So there are ways to confirm that we are actually capturing conduction system. One way we just discussed yesterday was a change in morphology when we pace at different outputs. That means we are pacing two different kinds of tissues, and that would mean that we are capturing the conduction system. What are the other ways which will tell us that we are actually capturing the conduction system? These are left ventricular activation time. So if this is the chest wall, this is the sternum. So the heart will be in our body like this. So V1 is normally placed here, V2. We are not telling the levels, but V6 will come somewhere around here. We already discussed which is the last part of the ventricle to get activated. It is the left posterobasal ventricle. So which is the lead, which is the closest to it, is V6. So if I activate the left bundle, that will lead to activation of the posterobasal portion fastest compared to any other place. We are not talking about a lead placed in lateral wall, LV lateral wall. That would be the fastest if you place a CS lead, because if I pace from the CS lead, coronary sinus lead, there will be a immediate activation of that wall. But we are not talking about that. We are talking about pacing from the septum and getting to that area the fastest. Now what will happen is, if I pace at the left bundle, the impulse will go down and then up and then activate that area. Compare this to a situation when I am not yet close to the left bundle. So it's LV septal pacing. I have crossed the midline. LV septum, QR is there. but I am not yet touching the left bundle. What will happen is, when I pace at that side, there will be initial myocardial activation, then it will reach the left bundle, then it will follow the same path. So in this case, V6 will be something like this, and in this case, same V6 will be little up and like this. So what is left ventricular activation time? Is the R wave peak in V6. What does peak mean? So all precaudal leads are unipolar electrodes. How does a unipole define is? When an vector is coming towards it, it will become progressively positive. One second. It will be positive, and then when it goes away, it will become progressively negative. So what do we mean when we have reached the peak in V6? That means the entire activation towards it has finished. We have reached the from other sides. So what is the LV activation in V6? Is this one. The latest portion of the left ventricle to be captured by any lead, any surface lead. So if the last part of the ventricle is getting activated within 80 milliseconds, that is left bundle capture, left bundle branch capture. Now if you ask me, if I pace here versus if I pace here, if I pace here and still not capture the left bundle, this is more apical, right? If I pace here and still not capture the left bundle, LV septum only, how will the impulse travel? It will again travel through the muscle first and then conduction system, right? But this will also reach V6 very early compared to this, because it is already taken, it is already negated this path. So this path is not required to be traveled. If you place the lead more apically, you will anyways reach V6 faster. So in an apical septal location, even if you are not touching the left bundle lead, you will reach V6 in less than 80 milliseconds. Then how this 80 millisecond helps? 80 millisecond helps only when V6 has a R more than S. So in this location, what will be the V6? It will be R small, big S, like a fascicular VT. Did you get this point, or should I repeat it again? So we are talking about V6 activation from a proximal left bundle location. What is the proximal left bundle location? V5, V6 being R more than S. Here we discussed yesterday, right? So this is the V6 here, and we want to pace at this location and not at this location, because in this location it will be more apical. V5, V6 will be predominantly negative. At this location, V5, V6 will be predominantly positive. It is like a normal precaudal transition in our body. So we want this 80 milliseconds from a site here, because anyways if I pace apex, apical location, anyways it will reach V6 fast, right? And so the impulse is not going across the cavity, it has to come down Purkinje and then up. So if I pace already at the apex, it will anyways reach V6 faster. From a proximal location, if I take less time, that is because I have taken a highway here, and that is proven by what? That is proven by the smaller time. That is proven by the smaller time which I took. Apical में कहाँ से R होगा, sir? If I pace here, for example, V6 will be predominantly negative. We discussed yesterday, right? No, sir. It's like I have drawn it like that. One second, where it is gone. Yes, sir. One second. Keep. So again, I'll repeat. We use V6 left ventricular activation time only when we are pacing at a proximal location, because anyways if I pace near the apex, I'll reach V6 faster. for example, if I decide to do a coronary sinus lead, LV lead, biventricular pacing, I will place the lead here only, right? Through the coronary sinus, it will go here. And that lead will, if I pace that lead, from that lead, what will be the V6? V6 will have a small q and then R. Small q means it is already activated. In a unipole, what does negative mean? It is going away from that site. So if I pace from that very site, everything is going away. Everything is going away means predominantly negative complex. So there will be q in V6 if I pace from a LV lead. Correct? So we are not talking about just getting there fast. We are talking about getting there fast from a left bundle area location. It is a distance of 100 kilometers, fixed. That 100 kilometers is fixed. Now I have to reach that 100 kilometers in 80 minutes. That 80 minutes is from that specific location where the distance is 100 kilometers. If my distance only to begin with, if I space the apex, the distance is only 50 kilometers, then I can definitely do it from a slower road also. I can travel that 50 kilometers in 80 minutes, even if I take a slow road. But if the distance is still long and I still reach within 80 minutes, which is the 80 milliseconds, then that is the proof that I am capturing a very fast conduction tissue, and that is the left bundle. Still not, okay, I'll tell you again, sir, once again. So, V6, right? Where are we placing the lead? We are not talking about apical location. We are placing the lead in the proximal septum, right? We consider two scenarios. We are capturing the left bundle. This is the left bundle tissue, and the second scenario, we are not capturing the left bundle. Which will tell us which pacing at which site will lead to activation of V6 first. This one. Left. More fascicle is okay, but we are not talking about fascicle. We are talking about a proximal location only. If you pace here, it will directly enter the highway. It will go and activate. So 100 kilometers, for example, it took 80 minutes, right? Versus this is also at the same location only, because I cannot overlap. I have drawn it little down. If I pace from here, what will happen? It will initially myocardium and then 80 milliseconds. And if I pace at that site, if it is less than 80 milliseconds, I am capturing the conduction system. That is proven. Children also, it may be less. So this is all adult I am talking about. Now you forget about this thing. Now consider a scenario if I pace from here. What is the distance? Previously the distance was 100 kilometers, right? Till here. This was 100 kilometers. Now I'm pacing from here, so the distance is already maybe 60 kilometers. Not here, it is not touching also. So it is not touching the conduction system. The distance from this side is 60 kilometers. And if I pace from this side, there will be some slowing, which was seen here also, which was what, maybe 10 minutes, right? Like how we added 10 minutes last time. So 10 minutes it took for us to reach from here to here. But now we are traveling a smaller distance on the left bundle also. So it may be, so the time from here to here may be already 60 minutes, right? It's less, right? The distance is less, so the time also required is less. So from here, if I pace away from the conduction system also, my total time will be 60 minutes. So will you tell that this is conduction system capture? No. That is because we will reach this site V6 earlier from a more distal location, right? How will the QRS look like? It will be small s, big R. We have already seen yesterday. If you are pacing more apical, like a fascicular VT. Fascicular VT has a small r, big S in V5, V6, because there is more tissue to be activated away from the lead than distal to the lead. Compare this with the proximal location. In a proximal location, what will be the morphology? Like this, R more than S. That's why this R took less time, na, sir? We just saw this R is 70 milliseconds, correct? And this R is 80 milliseconds. But this is still conduction system capture because it has taken a long road in that less time. So when we discuss LVAT, what is LVAT? LVAT is pacing stimulus to peak of R wave in V5, V6, in V6, provided R is more than S. Otherwise, any person, they can implant the lead distal. They will say if his V6 is like this, he'll say my LVAT is maybe 40 milliseconds. It is conduction system capture. But it is really, we're not talking about that. We're talking about a proximal location, and then only 80 milliseconds is the rule. Now I'll discuss something later, something more. So so you understood V6, right? V6 LVAT, if it is more than 780, it is LV septal pacing, and if it is less than 80, you can say left bundle conduction system capture. Now what is, have you ever heard about interpeak interval? No. So we'll discuss something more. Same diagram, and all of this we are talking about measurements which you can get from the ECG itself. You don't need to have the in the hemodynamic screen, you cannot measure, right? Who will measure? But the next day ECG you can see, right? V6 you can clearly see the pacing spike, and then just one small box will be 40 milliseconds. Pacing spike to the QRS is within two small boxes. So that is one way of finding out whether you have captured the conduction system or not. Now consider another scenario. We are talking about interpeak interval. What is interpeak interval? Before we actually discuss the definition. So which lead in the heart, which lead in the chest will tell you about LV activation best? Three caudal leads. V2, V3 is septum. V4, V5 is the anterior wall. Anterior wall, how we define. And V6 is the lateral wall. What more about the lateral wall? 1 AVL, V5, V6 is lateral wall, correct? So this brings us to the question, why are we not using AVL? AVL can also be used as a surrogate, but V6 is the most closest. So if you have to take a surrogate for the latest activation in the left ventricle, V6 is an ideal lead. What about right ventricle, which is the lead which you have? So V3 is septum, V1. V3R, V4R is best, but we don't normally use it. So V1 is the lead which is most closest to RV. How do we know that? Because if in RBBB means right bundle is blocked. If right bundle is blocked, which ventricle is getting activated late? RV. If the RV is getting activated late, the R in that region will be coming late. That's why there is an RSR. In RSR, the terminal R is always the bigger one. There is a QR. So in V1, QR, RSR or a monophasic R just implies that the V1 is getting activated late. That other area, V6 was getting activated first, right? So initially, V6 is like this. But V1, it's always late. So you consider a scenario where I'm placing my lead here. What is happening? If I place my lead on the left bundle, the impulse will go down here. It will also come up, take a U-turn, and again go through the right bundle and activate the right ventricle. This is one scenario. So because this happens, before I actually see this, V1, V6, V1 is looking like this, right, in left bundle. V1 is looking like this. V6 is looking like this. So what do you think, this R and this R will come at the same time? No. This is coming late, right? So if we line up V1 and V6 in the same column, V1 will have like this, V6 will have like this. So these are separated in time. So the peak of V6 is reflective of LV activation. the peak of V1 is reflective of RV activation. When we pace the left bundle, there is an inherent delay for RV activation. So when we pace here, we immediately reach the left ventricle through the Purkinje here, while for the RV, we have to come up at the branching point of the His bundle, and then I'll activate the RV. So there is a gap between V6 and V1 peak, that is the inter-peak interval. Now, which one, whether, so we have, the discussion is whether it's left bundle branch pacing or LV septal pacing, right? So LVAT will be more in LV septal pacing, less in left bundle branch pacing. What about inter-peak interval? Whether V6 and V1 will be more separated with conduction system capture or LV septal capture? What do you think? Correct. Why? Because you consider this scenario, you consider this scenario, right? You consider another scenario where I am pacing, I have crossed the midline but not yet reached the left bundle. If I pace here, there will be activation like this. There will be simultaneous activation everywhere, right? Every side. So it will take some slow time from here to here, right? Similarly, by the time it reaches the left bundle, it has covered X distance. Similarly, it will cover X distance on the other side also, right? So it has almost reached the right bundle. While it reaches the left bundle, it will quickly try to go up. But this distance is less, right? So it will reach here faster than this turnaround route. I'll say again. So, 1 second, how can I go? No, LV septal pacing is capturing myocardium on the left side of the septum, but not touching the conduction system. LVSP doesn't mean apical, doesn't mean proximal. It is anywhere where I am not capturing the conduction system. Still, I got a QR. So, Shivkumar sir's case, he got an LVAT of 79, 78 or 79, right? 79. For an adult case, that is, but we know it's, so that may not be the case. Just saying, but it had been an adult patient, that is branch pacing. Why? We saw there is an R in V5, V6, right? So we can measure that in that. So just now, we have gotten 60, 65 also. We have seen. So what we are discussing, if we are pacing left of the septum and not yet reach the bundle, so that is by definition LVSP. This is a case where we are actually watching. It has not reached the, we are seeing it. It has not reached the left bundle. But in real body, we will not be seeing it like that, right? So what will happen? If we pace at this site, we saw what was happening with the capture of the left bundle, right? It will immediately go down both sides. But what will happen if I pace here? Initial activation is through myocardium. Myocardium is getting captured. So from here only multiple sites, multiple wavefronts will start. It will reach from here to the left bundle, say for example the shortest route, which is X, and it is myocardium, it is slow. Similarly, from this, by this time it has reached here, it would have also traveled the opposite distance, also same distance, right? X. So this X is not enough to reach the right bundle, right? Because we are on the left side of the septum. We are not in the midline. If we had been in the midline, it will go equally, it will take equal time to reach both sides and it would have gotten activated. But we are on the LV side, we reached the left bundle, covered distance X, and then fast activation has begun. Again it will try to go down, it will try to come up. On the other side, meanwhile, it has reached a point where it is very close to the right bundle. By the time it comes down through this fast route, the other wavefront, this will activate this right bundle. When this activates right bundle, this is no longer required. This will itself activate the RV. Now, as someone was saying, this is LV SP, right? So LVSP will lead to lesser separation between V6 and V1. This is LVSP. This entire thing is LVSP. Compare this with left bundle branch. In left bundle branch, it will come down, it will come up. It is a relative thing. V6 and V1 are not one after the, they are one after the other, but happening simultaneously in LVSP. So the activation is happening here also, here also. In left bundle, it has to go down and up. Clear, right? So in LVSP, more simultaneous activation of both the ventricles. More simultaneous activation of both ventricles means the R of V6 and V1 are closer together. On the other hand, left bundle, I am causing more delay of the right ventricle. When I am causing more delay of the right ventricle, V6 and V1 peaks are separated. So if there is a cutoff, 33 milliseconds. If it is 33 milliseconds, it is left bundle branch capture, conduction system capture. Normally it is simultaneous. No? If some impulse is coming down, it will activate this side, it will activate that side also. Because LV is little big in size, muscle mass is more, so it will take more time. That's why the last part of the ventricle to get activated is the LV. LV is excellent. There is a paper on that. LV septal pacing results in better synchronization, but delayed lateral wall activation compared to left bundle branch pacing. Left bundle branch pacing, what was it doing? It was leading to earlier activation of LV lateral wall compared to LV septal. But as you said, LV and RV are more synchronously activated with LV septal pacing and not left bundle branch. Typically, this is the LV we are talking about, right? So intraventricular synchrony is better taken care of by LV bundle branch pacing. So for a CRT purpose, this is better. But if you want to just for both the ventricles are better synchronized with left bundle branch pacing will cause some inherent delay in right ventricular activation. So how do you find out interpeak interval the next day on the ECG? We don't have a caliper now. We don't have V6 and V1 in the same line next day. We cannot put a line and then see what is the distance between them. Stimulus to the peak time, subtract them. So it is the distance, it is the difference in activation of, difference in peak activation between the two intervals, right sir? How do we see if there is a difference of more than one box? If it is, for example, 4 boxes here, if it is 2 boxes here, no sorry. If it is 3 boxes here, if it is 2 boxes here, 1 box is the, so it is 40, it's significant. So, 1 second. Keep. We'll just go to the implant next. So lateral wall is the last part of the ventricle to get activated. So as a surrogate of entire left LV activation, we are seeing V6. So if V6 has reached peak, that is indirectly telling me my LV has gotten activated. So we discussed if it is more, that means wherever I am pacing, it is taking a longer time to reach that point. So which site will lead to a longer time LV septal pacing? Left bundle branch pacing will quickly come, it will directly reach the highway. There is no connecting flight, it will directly come. On the other hand, we have to take a bus, for example, from the mid city to the airport, and then it comes in LV septal pacing. It's just this 80 milliseconds is just based on normal ECG parameters. So what I was just going to tell you is, so what was the criteria of conduction system capture? Is this. First is incomplete RBVV. Then there is left ventricular activation time, which is less than 80 you should consider. I'll remove this for better. And V6 V1 interpeak interval more than 33. Why I am writing more than 44 in RBVV? If there is a delay in right bundle itself, the time. So we just saw when we paged when we page the left bundle, it is coming like this, right? Activation. So if the right bundle is diseased, so it will take more time to cross this barrier, right? And that will cause some extra 10 milliseconds. So that's why if there is an intrinsic RBVV, if the patient has an RBVV to begin with, this interpeak interval will be 44 as the cutoff. Yesterday we discussed in decremental output pacing, if there is a change in morphology. How do you find out there is a change in morphology? We saw some QR to RSR. That is one way of doing it. Sometimes you will not be able to appreciate only. Then you just see at a high output, low output, what is LVAT. LVAT will be different. So, for example, at a lower output, if your lead is here, at a lower output, you will be capturing only myocardium. So your LVAT will be more than 80. At a higher output, I am capturing the bundle also, so LVAT will be around maybe 75. So not obvious change in morphology, only LVAT measurements will tell you that this is conduction system capture. It is not possible because next day this will not happen. This will happen only during the implant. I'll show you. Now we'll discuss the implant and then we'll discuss all the steps what we discussed. Huh? CHB with LV dysfunction. CHB with LV dysfunction. LV dysfunction, so it is interventricular synchrony which is LVSP, not the intraventricular one. So LV, I want both the walls of the LV to be as synchronous as possible. Now LVSP is not doing that. Septal activation has happened. Muscle has activated. Now it reaches the bundle. Now it is activating the LV. So little late, right? In left bundle, almost simultaneous. LVSP is taking care of both the ventricles being synchronous, but intraventricular conduction, synchrony is not better taken care of by LVSP. It will be better taken care of by left bundle branch block only, so left bundle branch pacing only. So it has been take synchronization. CHB interventricular dysynchrony will be always be there. Will be there if there is an LV, candidate. Both ventricles are also dysynchronous, LV also dysynchronous. But LV synchrony is more important. More important is. So how do I do the implant? We'll just go. Right. Got it. So first, we'll take a venogram. Shiv Kumar sir didn't do the venogram today. He had a guide wire. He did, huh? किया था क्या? शुरू में किया था, okay. हाँ. So what we do is we'll see. We'll make the pocket. The pocket is not shown here, and we'll make the incision outside the first rib. The first rib is seen here. Can you see? So this is the first rib. This is the vein coming in. So this is axillary. This is extrathoracic part of subclavian, and this is intrathoracic part of subclavian. Ideally, you should puncture outside the thoracic inlet. What is thoracic inlet? Thoracic inlet is defined by the inner border of the first rib. So here the puncture is at the outer border of the first rib or little outside. Whether you put the his bundle catheter or not is not required, sir. Okay. So what we do first thing is, as was Shiv Kumar sir did, just marker, but that is not required. So You see here, I have put a wire in the RVOT. Sometimes it's difficult, it will coil, so this is in RVOT, right? As soon as it is in RVOT, I have taken out the dilator here. It is free, no? Can you, I'll go back a little bit. You see here, there is, the radio opacity will decrease at the tip. So once you come to the RA, you remove the dilator. There is a dilator here, it is still, the dilator is inside. It is now pulled back. Okay, can you see? I will show it again, you will realize. So this is the dilator inside only. Now the dilator has been pulled back. Okay, now the dilator has been pulled back, the rest of the catheter is being threaded over the wire, and we will place it in the RVOT. Once you do that, you take the wire also out. Take the wire out and put the lead in. So on the focus on the right image now. So once you take the lead inside, don't take it out fully, just keep it towards the edge and position it as we discussed. Clock, if you clock, it will jump. It is jumping now. Then pull back, try to position as proximally as possible. This is the RO20. If I draw the apex here, I don't want to be in this region. This is the annulus. I know it because I have put a Hayes bundle here. Otherwise also we know this is the annulus, and we want to place it as proximal as possible. Ideally here. This may not be the true thing. So again, if this is the his is in anterior wall, right? His is in anterior wall. So this is his, this is left bundle. You should place it somewhere here. So that's where the catheter is being pulled to, and we are trying to keep the sheath there. How do we find out whether my catheter is perpendicular or not? I have to go to LO. But before going to LO, I just have to pace and see. I will pace and I will look for these 4 criteria. What we discussed was V1 notch. Okay, so this is V1. There is a notch. There is a transition. It was looking very proximal, no? But still the transition is very late. It is because that RO is not the true RO. It will almost always happen. So you do not go by the fluoroscopy picture. If you are really proximal, V4, V5, V6 all will show R more than S. What else will see? 2 positive, 3 negative. But you don't need to worry about 2 positive, 3 negative. We already discussed any of these 3 points is okay for us, depending upon the patient. Today we reached a point here, Shiv Kumar sir's case. But yesterday we saw during the simulation we reached here. But there will be many times you will not be able to reach these 2 points, and you will be stuck here. That is also okay. The most important point is inferior lead, AVL-AVR discordance. AVL should be positive, AVR should be negative. So this is the criteria. So next we go to LO. This we already discussed yesterday. What is typical LVVV, not required. So, and then we give a contrast injection. In contrast injection also it looks like I am absolutely below the valve, right? But it may not be true, because I may be like this in RO, so much like this. The valve will be here, my sheath, my catheter will be here. But in RO view you will think we are close together, but in reality we are not close together. Okay. In LAO I went, and LAO I did a septogram just to see whether I am perpendicular or not. There is no hurry to jump from one step to the other. The catheter is not going to jump out if you don't hold it. It will automatically fall on the septum only, because it has been made like that. Okay. So once you get the septogram, you again pace and see whether you are there only or not. This is a stillet driven lead, but the concept is same only. We will screw in and then check in a Medtronic lead, or we will look for PVCs. Otherwise, if you have a facility for constant pacing means, how will you do constant pacing with a stillet driven lead only? How can you do constant pacing? There is a stillet coming out, right? Here we are not, one crocodile clip is connected to the other we are not able to connect to this lead, because if we connect it here, how will we rotate? If we rotate, it will get coiled up, right? But if you have a stillet, the stillet is connected to the tip, pin to the stillet, and you can. Once you rotate the body, you can constantly see the change in morphology. So on the left side, this is V1. I'll show it. So there was a notch here, right? And as you screw in, the notch will move right, and it will become a QR like this. So if you imagine this as the septum, this is the entire interventricular septum. When you are on the RV side, the morphology is a W. As you move right, the notch will move right, and you will get a QR. So QR is telling you are here. A little bit of R developing tells you have crossed the midline, and it is all left bundle area pacing this onwards. But if you have, so can I measure LVAT here? Its R is almost equal to S, maybe a little more than S, so we can. But this is not a site very proximal. We already saw when we were going to screw, before pre-screw, we already saw that only V5, V6 was positive. So that is in line with the final location also, and we are also okay with this. Okay. Sometimes I told you, right, if this is the RV, sometimes proximal location may not be achievable. Then ultimately we may be forced to go down distal. Then also if you penetrate deeper, I can capture the conduction system. Sir? Sir?
Like right now you are telling the implantation technique.
Yes, sir, yes, sir.
This is for how long, and then the next?
Oh, sir, I'm done, sir. I will stop whenever you are again starting the next case.
Shall I?
Yes, sir, please, sir.
Okay. Just one brief thing I wanted to tell.
This board is really bad. I'll clean it, sir. 1 second. Sir, I'll use this now. This will be okay. Sir, leave it, sir. It's wet now. But this marker is good, sir. You can use it. All markers are very sharp, so good. You can use that, sir. You can use a new marker also. I have a new marker. It is going away, sir. You give it to me, sir.
No, that's fine. See the.
1 second, sir. Take it from this side, this way. Correct. No, give it to sir.
No need for that.
No, sir. Live, sir.
So basically, in that patient, I could not show you all the fibers of the muscle well because there was a lot of oozing. So it became like a reddish field. If it is a patient without much of antiplatelets, we could have seen it little bit better. But basically, I'll tell you what we try to do. This is the anterior surface of the clavicle. So from the anterior surface of the clavicle, a bunch of muscle goes off and gets attached. From the sternum as well as the costal cartilages, a bunch of muscles start up to the seventh costal cartilage. This is 3, 4, 5, 6. It's to join now together. So this is the sternum major. This is the clavicular head of pectoralis major. They two join together and they go and attach to
This is the greater tubercle, this is the lesser tubercle, this is the intertubercular sulcus, this is the lateral lip of intertubercular sulcus. This red will go and attach to this lateral lip of this intertubercular sulcus. Intertubercular. This is lesser tubercle, greater tubercle, intertubercle. So this is the pectoralis major. Posterior to this, this is the second rib, third rib, fourth rib. This 3, 4, 5 ribs in the muscle are split between the two. So in this particular patient, doing was, I was actually splitting between these two. Now if you see, the more cosmetically appealing will be to have a very small skin incision, a small wound, which will give finally a small scar. But our ability to dissect interpectorally and create a deeper pocket will be possible only when we make the skin larger, because we need to get in between this red and this red, that is clavicular head and sternal head, and create a pocket down, and I need to have a pocket which is little relaxed rather than tense. If it is tense, the muscles bulge out, the muscles are pressed between the skin and the generator, muscles get less vascularity and they will get into necrosis. So while in an adult, especially in an adult lady and all, who is well grown up with a good subcutaneous fat, we would like to keep the pocket very small, dissection very small, keep small as much as possible to make it very cosmetically achieve. But in a small child, tension should not be there. So I was actually incising between the two, and in this area and all, basically the muscle will start going into tendinous structure because this portion becomes tendon. It's soft muscle here, and slowly it will become tendinous at this point, and the generator anchored on the pectoralis minor, and then finally I got this and this suture, this and this suture, this and this suture. I don't know how good it was seen here, but it was little bloody, so it was little. Were you able to see the head and all? Not much. When I was dissecting, it was. The problem was this patient's ASD was done quite some time ago. It should have been stopped at 6 months, but somehow the parents may be between the muscle layers. Then again, it will be here. Basically, the generator will come into this area, and the muscle will be lying on the top of it, right? In the next character transformation is actually an adult, so we'll just go over the clavipectoral fascia. Please continue. I'll just go to the left. But at the time of change, what will happen is this whole pectoralis major now will become a fibrotic, one hard structure, and it will become very thinned out like a capsule. The pectoralis may not have a true muscle in any of those areas, and we will be cutting as if it is cutting the anterior capsule. What we need today is a secure, like it should not protrude through the skin. At the end of 10 years and all, sufficient skin and subcutaneous tissues will. No, there the pocket will be intracapsular. It will not excise the capsule. Will not excise the capsule. It actually difficult to excise the capsule and all, unless the capsule has got a lot of calcification in some of the patients, where when you are cutting, you will find sticky, like cracking sounds. When it is cracking like that, little bit of excision. Again, don't touch the floor. Don't touch the surrounding circumferential wall, maybe little bit on the anterior part alone. Otherwise, it's better to have the capsule. minor. Here, all the lead sutures were on the pectoralis minor.
So in case we have an extraction,
Oh.
in case we have an issue there, then we probably have to have some dissection into the pectoralis minor.
Once it comes to extraction and all, then probably we should involve the surgeon to keep cutting so that like things will be even, because when we cut, we'll take artery. Surgeons, very rare to see a surgeon not using the cautery. Since my intention is to avoid a cautery in a pocket that is prone for necrosis, because all small children, they are prone for necrosis and extrusion. So we need to be trying to take steps to avoid tension. Interpreted sutures are good because they are very fast, but you cannot control the tension on the interpreted sutures. Sometimes interpreted sutures will get tightened, whereas, continuous sutures will get tightened. Interpreted sutures, it is easy for us to titrate. Like you just get the approximation and just leave it. So that our intention is to bring the tissues together and not to actually give a tension on this. Necrosis happens due to tightening of the sutures, so that will be avoided. So Anindya will you just go ahead. I will go there and yeah, finish this so that, because it will take 2 minutes for me to go to the place. Skin was up.
Hello. I'll maximize it. This is a case of a 45-year-old male who was diagnosed to have corrected transposition of great arteries, VSDPS, at 10 years of age and underwent physiological repair. We don't have the details of the operative records. He has remained asymptomatic on follow-up. He was recently evaluated for a non-specific chest pain and was diagnosed to have LVOTO and was referred to M. At M, his echo showed it is a situs solitus mesocardia, status post surgical repair for CTGA, VSD patch was intact, There was some mild right AVVR and mild to moderate left AVVR. There was a subpulmonary membrane causing LVOTO with a peak gradient of 92 mmHg. There was mild PR and the function was adequate. This is the 4-chamber view. The VSD patch was intact. This is the transesophageal echo. His transthoracic echoes were slightly suboptimal, so we went for transesophageal. This is showing the left AVVR. This is showing the subpulmonary membrane causing LVOTO. We took him up for a cardiac cath. During the cardiac cath, he was noted to have runs of CHB. We can see that the RA pressure is elevated with tall A waves. The morphological LV to PA gradient of 95 mmHg was seen. The morphological LV systolic pressure was elevated to 118 mmHg. So a 20x6 Ty-Shack balloon was used to perform a palliative balloon dilatation of the subpulmonary membrane, after which the gradient decreased from 95 to 73 and this was accepted. This angios will be shown. This is the ECG of the patient showing complete heart block. While he was admitted, we also did a Holter which showed that the basic cardiac rhythm was CHB with a maximum heart rate of 96, minimum of 46, average of 56 and no pauses.
So actually if you see this hemodynamics, in a patient with CTGA, one hemodynamic importance is a higher LV pressure, the morphological LV pressure, that is the subpulmonary pressure, is good actually. That will prevent ballooning out of the morphological RV, which is the systemic RV, and will help in maintaining a good morphological RV function, because it will maintain its triangular shape, which is the normal shape of a morphological RV, rather than becoming globular, which is actually the shape of actual LV, but that morphology will not be good for a morphological RV. So in that way actually it's good. This patient has actually reasonably done well for these many years, maybe because of this PS. Actually whenever there is a PS, the gradient of around maybe around 50 to 60 is acceptable. It's not a problem. We better not do anything. We can leave those patients without any issue. But this patient actually was started developing symptoms. The morphological right ventricle, that is the systemic ventricular function, was good, and we can see the gradient is almost like 80. So with this high gradient, not just 80, it's even more than 80, around 85 or so. So at this stage, what we decided was, we'll do a just marginal graded balloon dilatation and not something to relieve the obstruction. We don't want to have a no PS situation actually. We just want to have some PS, which will be actually good to maintain the geometry of the morphological RV. So we just did a balloon dilatation with a 20 Ty-Shack. It was actually, the angles was something like 25. It was a very marginal dilatation just to achieve some degree of reduction in the gradient. Though a PS is good, it should not become like the RV, the morphological LV should not become suprasystemic and all. That's not good actually. So in that way, it might not be really beneficial. So this amount of a marginal dilatation was done, and we got a gradient down to something like 70. So that is something very acceptable. So we are just continuing that. That is the reason why this balloon dilatation was done. It was just a palliative balloon dilatation just to reduce some gradient and not relieve the obstruction. And probably the surgery that was done initially is a VSD closure, and it was possibly a physiological repair, as we can see by the echo we can see. And for someone who doesn't understand much of congenital heart, yeah, RA pressures were quite high. It means that actually that the patient is actually not doing well. They are not tolerating this amount of pulmonary stenosis. So we can't accept it to be allowed to, we don't want it to go like this. And actually this, actually when this cath was done, the patient was actually intermittently in sinus rhythm and intermittently he was in CHB. So the first time the CHB was diagnosed in this patient during the procedure only. There was no history of any syncope. There was no documented ECG which showed any heart block. But when we saw him in the cath lab, when we were doing the procedure, intermittently we saw this high atrial pressure, like the high grade AV blocks were noted during the procedure only. It was not known before that, and it was quite tall A waves that was seen. That was actually there when it was in sinus rhythm only, but there was some degree of PR prolongation at the time. It was not in CHP. It was not a Canon waves at the time. And this is really not an acceptable one. So the mean was 10. Mean was not too bad actually. The mean was 10, though A was 24. Today when we did a cath, actually, when already the patient is on table, when we check the pressures, the atrial pressure was, even now the RA pressure is like 11 to 12, but there is no significant prominent A or V actually. They are both are like similar, and they were like 14 or 15 now actually. Just now we did. And the morphological LV pressure is one more thing I was just telling was actually this is just for people who commonly doesn't see these kind of cases. Sorry. Yeah. Actually, this is since this is a CTJ, this is the morphological. This is the right atrium, and this is actually the morphological left ventricle. And we can see that this is the morphological right ventricle. How we differentiate is by seeing the septal displacement. Here we can see that there is apical displacement of the AV valve in the left side. That is that is one of the features which suggests that it's a morphological right ventricle. And here also you can see the same in a better way. And here we can see that the MR is not terribly bad actually. I mean the TR, the tricuspid regurgitation, is not terribly bad. And here again we can see possibly this was the patch that is actually bowing here. This is where we can see. So this will be the location of the the conduction system where we actually have to target, and we doesn't see good amount of mitral pulmonary artery continuity in this. But here you can see this is actually the mitral valve, and this is the pulmonary artery, and here we can see the turbulence over here, and we can see the mitral and pulmonary artery continuity in this image. So that also will be shown in once we go live. So I think I would ask Anindya to put his inputs on this ECG. Like thing is, like it was intermittent heart block that we noticed actually, and in a patient with the VSD, if it is isolated VSD, then definitely we will put on Holter. We'll see what is the longest pass, and then we'll see based on the standard guidelines, whatever is suggested, we will go by that actually. But in this patient, we know that he will definitely end up in complete heart block in over a period of time. That is the reason we are doing it actually. Otherwise, with whatever the guidelines, like whatever the guidelines are, we'll go by the standard guidelines and do it. We'll just monitor, do a Holter, and then see what is happening, and then decide.
Okay. Yes, yes. So we'll quickly go through the ECG, and then one diagram I'll draw to show where we actually will try to get the conduction system capture here, because here the ventricles are inverted, so that the left bundle is not left, it's on the right. So if you ask me, so what is the point of drilling into the septum? There is no point. That only we'll discuss. Before that, the ECG. So ECG of a CCTGA, you must have some idea. P waves are normally, they are normal, unless you have a left AV valve regurgitation causing dilation of the left atrium. So you see there is that Morris index, that lead V1, the terminal deflection is prominent. If I zoom here, so you can see that happening there. What else will be seen? Because the ventricles are inverted, the septal activation is also inverted. Initial activation of the septum in a normal heart is from left to right. So septal Q waves are seen in 1 AVL, V5, V6. In CCTGA, you will not see septal Q waves. So 1 AVL, V5, V6. Is there any evidence of a Q? No. That is, and that Q should be more evident because there is volume overload of the left side, right? You know LVH in a patient, in an LVH, what is the criteria of LVH? There is long R in V6, V5, V6, right? If it's a volume overload LVH, there is a Q. So in spite of a volume overload to the left side, there is no Q in lateral leads. 1 AVL, V5, V6 they show conspicuous absence of a Q wave. Where will the Q wave will be? The activation is now septal activation, initial septal activation is now from right to left. So a right lead should be showing a Q wave. So where is that right lead? V1 anyways in a normal person will be also like this only. Maybe small r will be there. But there will never be a r in V1 in a CCTG. 1 second. Lead, so what else is on the right side? Which lead is here? Here, right, down. 3. Lead 3. So heart is like this. Initial septal activation is right to left. So Q waves will appear in 3. 3 more than AVF. More than 2. 2 will not have any Q. So you see here. Q in lead 3. More than AVF. None in lead 3. Okay, sir? Okay, we'll go live.
Anindya? Now is it, am I audible? Am I audible?
Sir, you are audible.
Okay. Okay. See now, I am. Are you seeing my camera? I am looking at the monitor now. The monitor shows prolonged PR interval and intermittently sometimes there is a AV dissociation. Are you seeing the live monitor itself? From there, I am not getting the audio input to my.
Hello.
Hello, can you hear now, sir? Hello?
Yeah, I can hear you. Pramod, I can hear you.
Yes, sir, yes, sir. Yes, sir, we can see the monitor live, sir.
So, okay. So now, actually, Pramod has already done the initial angiograms. Can you show the first angiogram onwards? So, see, as it was discussed by Dr. Pramod, this is a patient who is having a corrected transposition with operated ventricular septal defect, no residual VSD. There is a significant LVOT obstruction with subsystemic LV pressures. The LVOT obstruction, we are not planning to get it relieved because as long as the LV is under high pressure, the septum will be more favorable for the right ventricle and the right ventricular pressure will be, right ventricular function will be maintained. You can see that in this fluoroscopic screen, the heart is reasonably smaller. The heart is not very unduly large. So that's actually good. That means this patient is protected from serious right ventricular dysfunction. So our intention is not to relieve this LVOT obstruction. In some of the younger patients, small patients, who are having severe LVOT obstruction at subvalvular level, the natural history is a progression. So over a period of time, it will keep on slowly progressing. And the LV from subsystemic will become systemic and then suprasystemic and then it will fail, leading to secondary mitral regurgitation and secondary right heart failure. But the patient who is already 44 years, the natural history may not be so aggressive. Amount of all the subvalvular obstruction progression is all in the childhood and adolescence. And much later in life to progression is a little less. So our, as actually right now, as I am talking to you, you can see that there is varying degrees of AV nodal block. There are times at which it's junctional rhythm. So I mean, we found the last time during the cardiac catheterization that whenever there was an AV dissociation, there was a significantly elevated right atrial pressures and all indicating that the filling pressures were to give an AV synchrony. Now in this particular view, this is epicranial. The septum is profiled in a sagittal view itself. So we probably will not be relying more on this RAO, LAO and all. It will be more like targeting on an AP view. So this is on an AP projection. We, in this particular lab, this is our routine pediatric lab. We don't have a facility for V1 to V6. So we have only one extra lead, that is V1 alone. So the markers for us, freeze it when the LV is fully filled. So the markers for us are, there are two sternal wires that you are seeing. So between the two sternal wires is the region of subvalvular obstruction. So I should be just below the subvalvular obstruction. So I'm going to be somewhere between these two sternal wires, a little bit lower than midline. And then if you look at the V1 electrode is actually overlying the mitral valve. So I have to be on the leftward side of that V1 electrode. So this is our anatomical landmark on an AP projection. Pramod also did one AP cranial. Can you show me that AP cranial? This is the AP cranial. This AP cranial primarily elongates the LVOT a little bit more. So if you see here our target should be, we are able to see at the level of the second sternal wire, the subvalvular obstruction, and below the third sternal wire is the left ventricular apex. So my conduction system lead has to be poking between the two sternal wires on an AP cranial projection. So the place is between the two sternal wires on an AP cranial projection. And go back to the AP view. So in the AP view, it is a little below the midpoint between the two sternal wires. So now what we are going to do is, and also third thing that Pramod has done is to take a venogram. Show the venogram now. So this is the venogram. So let us concentrate only on the extrathoracic part of the venogram. So that is the extrathoracic part. Show the next picture. Next. Yeah, just freeze it there. That's enough. So this is the extrathoracic part of the venogram. And now what we are going to do is, you are able to see my camera also. No need to be so close. Take it up. Okay, so I am going to be making an incision over this area, Manoj. So we are just getting to show an Alice forceps. Just keep on mopping. So I'm holding the subcutaneous tissue here. Just a curved scissor. Give me one more Alice forceps, sister. Gently. So I'm pushing my Alice forceps deeper. I'm pushing this Alice forceps also deeper. Scout scissor. So I'm reaching the pectoral muscle. I don't want to go into the clavipectoral fascia. I have breached the clavipectoral fascia at this point. So hereafter, my plane of dissection will be more above the clavipectoral fascia. So just like last time what we saw, this is the clavicular head, this is the sternal head. So now I will just briefly separate the clavicular head from the sternal head. Mop it. This is the plane between the clavicular and the sternal head. But our intention today is not for that. So I am blade sister. Manoj, come this side, Manoj. Get the light oriented. I want the light. Sister, curved sister. So now I am actually going between the plane of the pectoralis major and the subcutaneous tissue. I have got the clavipectoral fascia intact here. I will show you. The Langenberg retractor. So this is the plane of the clavipectoral fascia. Are you able to see my camera?
Shiva, I am back here.
Yeah.
I'm looking at the way you have been doing it so neatly, and such a great hemostasis. And I do not think you ever used a cautery so far.
Usually, I try to avoid.
Yes.
I was briefly telling that. Basically, cautery acts by coagulative necrosis.
Yeah,
so we try to avoid a coagulative necrosis if possible.
Yeah,
so there will be some amount of blunt dissection, but too much of blunt dissection also produces tissue laceration. So I use in a very cautious manner a cut. So I'm using basically a curved scissor, and I'm going on the clavipectoral, superficial to the clavipectoral fascia. So I'm just lift it like that. So I'm going underneath. When we put in the finger, we will find some areas where there are some fibrous strands. So then I will target them. Yes. I'm hearing Ullas. Yeah. Pramod was mentioning to me, Ullas, that you are there. So right now, I'm going to make a little bit of dissection on the superior aspect also. So this is the clavicular head that I'm seeing. So I'm going superficial to the clavicular head and creating a little bit of flap there. So now, so let me see how much. Little bit more also I can. So I'm using the cotton to produce activation of the coagulation pathway and get some more hemostasis. Sister, can you get me a scissor? Yeah, this pocket seems to be okay for me. Being an adult, I mean, it's not a major issue. Give me some 3 antibiotic soaked gauze pieces. So I'm putting 1, I'm putting 2, I'm putting 3. So there will be some seepage of that. Okay, now let us get the needle.
So this practice of keeping an antibiotic gauge piece or just putting some antibiotic inside the pocket, it's all, physician's discretion. But what is
Correct.
most important is do not forget to take them. He counted them 1, 2, 3. So make sure that you do not forget to remove them.
So right now I am going towards my needle.
Yeah. So before you start puncturing, one more time the venogram, if it is shown, people would remember which is the
Okay.
direction unit.
Show the venogram again.
Yeah. So beyond the first rib, the outer border of the first rib.
And also I have a coronary wire, Dr. Ullas, there.
Yeah.
Change the syringe is leaking. Change another syringe. Yeah, thank you. Sister, wire.
Sure, especially in an adult, and if he is tall, what happens with the sheath is if you are too lateral for an entry, the sheath may start kinking. So if you are dealing with an adult, tall, try to get the access as medial as possible at the outer border of the first rib. Otherwise, the extra length will make the sheath to kink.
I agree with you. I have had that situation where the sheath, one is kinking, second is the sheath not becoming adequate enough. This Medtronic sheath being very small. Anindya yesterday was telling what is the length of this sheath. Anindya, what is the length?
49.
Yeah, 49 sometimes in a grown up big, I want seven, seven dilator first. So I have got a thermo wire inside. So now I am pre-dilating the pathway. I will keep it. Give me the next needle. I will take one more puncture and then. This small one. Okay. Second puncture wire ready. Okay, sister, that green, orange color 7 dilator. Sister, that sheath.
Shiva, there is going to be a live chat going on, and an important question here. It is with respect to the pediatric age group. The question here is, at what age or at what body weight you can consider 2 leads?
Yeah. Okay. Okay. See, I mean, in general, 10 kilo will be a safe weight for 1 lead, and 15 kilo will be a safe lead for 2 leads. But we have gone down to 8 kilo on 1 lead, and we have gone down to 12 kilo on 2 leads. This the problem about putting in 2 leads is that very high chance of left innominate vein, left subclavian vein occlusions.
Right.
Fortunately, this lead being a little thinner, one of the lead being little thinner, it gives us that advantage. I would say 10 kilo for a single DVI pacemaker conduction system through a 4.1 French this pacing lead. And 15 kilogram for a combination of 1 6 French atrial lead and 1 4.1 French ventricular lead.
So now that these conduction system Medtronic leads are available, which are much sleeker, and if the patient is affordable, you can actually use these 2 leads for a dual chamber. So actually you can bring down
the ventricular lead has come out.
Yeah. So you might consider 2 conduction system leads of the Medtronics, and then you can bring down your ability to pass 2 leads in
Manoj,
smaller.
can you go there and sort it out and come? So basically what we identified was that the pacing lead
using the sheath. Same sheath.
The temporary pacing lead came off. Manoj, you have to allow me also to see, so that you. Pace, pacing you just check whether it is pacing up. Check whether it is pacing. It's not. Capital 100. Capturing. Okay. Okay.
Shiva, positioning the TPI quite at the RV apex might also give an idea, where do you would like to lodge ultimately the pacing lead.
Sister, in between, don't come, sister. I'm seeing the flow. I'm actually trying to get my lead.
Yeah, make it a little larger.
The difference between a tricuspid valve to pulmonary valve entry in a structurally normal heart and a mitral valve to pulmonary valve entry in a patient with a corrected transposition is, it is a, there is a complete continuity between the two, and the two chambers will be going in opposite direction. So the inflow and the outflow are almost adjacent to each other. So here we have to enter into the RV and pulmonary artery. I'm trying to it's hitting against the can you hold it like this? Here. Can you show a little bit more on the diaphragmatic surface? Yeah, it's going down. Can you go a little lateral so that I know that it is not posterior? Because can I adjust the light? One of you come here. Take it out. Yeah, it's going posterior. Okay, hold it like this, Manoj. Show a little bit more on the, go a little bit more yellow. So it's going posterior.
You notice the maneuvers of Shiv Kumar. What he is trying to do is he's not actually
show more of the ventricle.
He's not bending the sheath. It's very flimsy.
Pramod.
He's always trying to get the wire outside and then try to negotiate.
Correct. Go more. Keep the diaphragm a little down.
Never try to get the sheath to get into the ventricle. Make sure that the wire tries to get inside, but not the sheath.
Just hold it here, Manoj, the same position. Hold it like this, same torque. It enters and then flips out. Okay, come back to AP. Get me a Judkins left coronary catheter. So basically, I will try to get hold it here, this hand here. I will get a catheter to direct it towards the LVPA a little deeper, and then a wet gauze system. Yeah. The orientation between right atrium and right ventricle is right atrium is located on the right side and the right ventricle is located on the left side. In a corrected transposition, the right atrium and left ventricle are anteroposterior. So right atrium is posterior and left ventricle is anterior. So we need to direct it anteriorly. You are holding the wire, sister? Okay. Allow the wire. Okay, hold the wire. Okay, go back to that lateral, not caudal and all, just keep. So I am lifting up the sheath. Go a little bit more elevo. It's buckling in the right atrium itself. Little bit more lateral. That is the entry into the left ventricle. That's appendage. The sheath is getting turned. Okay, hold it like this. Re-entering the ventricle, I have to go. It bounces out. It straightens out the moment I touch that outflow tract. Okay, come to AP. I'll try to use without the sheath support at all because the sheath is trying to deflect. Okay.
Okay. Hello, sir.
Yep.
Can you hear me, sir? So there's a
Yeah,
question
yeah.
like, do you want to change any sheath and try to enter the mitral valve using some other catheter?
I'm trying with the Judkins left so that it will give a curve for me. Come to again lateral view.
The question was whether you want to remove this his bundle sheath itself and try
His
enter
bundle
first
sheath
and
is the his bundle sheath is now pulled completely into the innominate vein, so it is no longer giving me any trouble.
And there's also one suggestion that whether a balloon flotation catheter can be used to enter and then
Could
change.
Could be. Yeah. Now come to more NAO. Yeah. That is another option. I'm now trying out without with this itself. Now go more lateral. Yeah.
V1.
That subvalvular LVOT obstruction is also creating some amount of because the LV has become very hypertrophied. Let me see.
There's some LAO 70 now.
Yeah, almost going to lateral. See, now I'm entering the ventricle. Now when I try to push let me try to get my catheter deeper. Now I'm trying to get my guide wire face superiorly. When I push the guide wire, my push is acting on towards the inferior vena cava. So now again I am in the ventricle.
Last time when we did a cath, we entered from femoral vein and it was not really this tough actually. The angulation is a concern from the left subclavian.
Yeah. So this is the region of the left ventricular outflow tract. Here, when I am giving the push, It's getting deflected in the that subvalve are narrowing. Let me see whether I can get my coronary catheter deep inside.
I think actually we should face anterior. Actually, it's not just left. We have to go anterior, and it's the relation between the atrium, right atrium, and the left ventricle is like more of anteroposterior, and it should go anteriorly. So the catheter going from here should actually give an anterior torque. So it has been possibly, that is the reason why it is becoming a bit tougher.
Yeah. So now I'm in the ventricle. The guide wire is in the ventricle. My forward push is acting more in the direction of the
inferiorly
towards the vena cava. Let me do one thing. I'll try to advance the. Here it comes towards the atria, this direction. Yeah, try a seven French balloon flotation catheter. I'm hitting against the ventricle, but my further, okay, that is it. Come to AP view.
So we have a 7 French peel away sheath in the puncture side. So we can actually be taking this his bundle sheath out, and we'll try to enter now.
I am entering into the ventricle.
Initial days, when we started, actually we were directly taking the his bundle sheath without a peel away sheath. But the problem was bleeding was an issue that time, and maneuverably, and when we were trying to maneuver, it was kinking at that point, and nowadays it's better to use a peel away sheath. Actually, it's a bit extra cost, but it is safer actually. It will prevent bleeding because it has a check flow valve, and also it will not allow kinking at that region.
One more problem about this check flow valve is if the patient is conscious and he is breathing deeply, there will be air getting sucked in. Just wash it and keep it. So there will be air that will be sucked in through the sheath, and there will be air that will be entering into the right atrium, right ventricle, and pulmonary artery. We have seen quite often a patient who is having deep respiratory efforts, having air getting sucked in. So that is also prevented by this check flow sheath. Now I am taking a 7 French Swangans. It's not a swan. It's not a Swangans. It's actually a triple lumen catheter meant for pulmonary artery and right atrial pressures and thermodilution. Okay.
Just about the intubation, why not intubate? Why don't we do the patient, the case under intubation if you have a doubt, like just to discuss about this point. Like many people would prefer to do this kind of case under intubation, general anesthesia, that gives very good control. There will be positive pressure ventilation. There is no issue of this air aspiration, all those things which doesn't happen actually. In the previous case, actually, you could see that there was pocket of air in the air just beneath the pulmonary valve. That's because of aspiration of the air. That doesn't happen in mechanical ventilation because it's a positive airway pressure. But why we don't prefer is we would like to finish the case as early as possible, and we don't want to put the patient on ventilator for a long time. That's one thing. And we just prefer to shift the patient back to ward, and the child, and we prefer the child to be with the parents. And one more thing is, if we give too much of sedation and deep anesthesia, we don't get good thresholds when we give deep sedation, deep anesthesia. When we give deep anesthesia, sometimes we get higher thresholds when we check the lead, but once the anesthesia is waned, actually we will get very good thresholds actually. So that is one reason we avoid giving anesthesia. We very small child, sometimes we do under intubation. This is also finding it difficult to go in.
Yeah. Yeah, now it is entering.
But wire should somehow go in actually. It's more of an angulation that will be a concern rather than the distance, rather than diameter. I think it's in the wire is in the ventricle.
Yeah. Now I am going to deflate and inflate and see whether I can push it inside.
Yeah, we are entering the PA.
No, it's entering the superior vena cava. I think so.
Now we can check in other view once.
It's not in the midline, no? It's superior vena cava.
Side.
This right ventricle is little hypertrophied right ventricle. Sister, just wash this in water and give me this wire. Give me a flush.
Yeah, the initial angiogram also showed a very hypertrophied right ventricle and the cavity was quite small.
Get me some small amount of contrast, sister. It's not. Let me deflate it.
There are ectopics, it's in the ventricle, but
it's touching somewhere in that region of mitral valve, but not. So again, I will re-inflate the balloon. So now we are entering. This is contrast. Contrast. So that is the ventricle. So it is getting just underneath the pulmonary valve. So I'm giving a gentle push. It's hitting against the septum. We also have to remember that it's a post-operative septum. So some amount of irregularity also will be there in that area. Just a contrast. So that's the pulmonary artery. So let me try to advance actually if I am able to enter with let me deflate, inflate and see. If it had not been a stenotic outflow tract, sometimes it would have popped in. It's not entering. wire. I'm going slow so that it doesn't poke it out. Yeah, that is, it comes out. So because the mitral valve and the subpulmonary outflow tract are so close to each other that it pops out very quickly. It pops into the right atrium. Here this is, it just enters. Yeah, that is right. We are entering the right ventricle. So that is hitting against that outflow obstruction at that level. This was between the two sternal wires. And then it pops out.
Here. Hello, sir.
Yeah.
Arvind here.
Yeah.
May I suggest one thing? Instead of this thermo wire, can we, or maybe this thermo only, but make the first 10 centimeter, give a U-shaped curve to the thermo wire. If you do with a Teflon, it becomes really floppy. And what is happening is you are looking towards the septum and it is hitting the septum and coming out. The wire
Correct.
is coming out. So if
Correct.
you make it floppy the first 10 centimeter, maybe it will be so floppy that it will not resist the septum and just move towards the outflow tract. Maybe.
Yeah.
Maybe not, but we can try that.
Yeah, I see right now it is actually poking towards the outflow tract. I'm just seeing. Get it washed, sister. Can you flush this also? Flush it. Aspirate and flush. Yeah. 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 Get me a little softer coronary wire. Let me just see. Get me some contrast. Go a little cranial. Yeah. Table little up the other direction. Yeah, little out. are just hitting the inflow region and not entering. Yeah. It's touching the mitral valve. One more thing is, this patient's both the left ventricle as well as the mitral valve both were little smaller compared to the tricuspid valve and the systemic right ventricle. It's yeah, open it. I have to first enter the right ventricle. I'll make the balloon a little smaller and see. Get me some contrast. Yes.
Hello, sir. There was a suggestion like how we usually enter RV in a normal individual using a loop. When we just pull it slowly, it goes in. Will it not work in this case? Is one of the suggestions.
Actually, I was trying it. What was happening was it was getting directed towards the inferior vena cava. You now see that my balloon itself is not easily entering into the mitral valve orifice. I'm just trying the coronary wire inside. That is right ventricle. I'm going to deflate and see if I can there is so much of resistance to enter the that is the right ventricle. I will come out. I'll again try to re-inflate the balloon and so it's now entering. It's going towards the outflow tract. Show the AP. Now we have to see whether this is going to easily track.
The tip is in the left pulmonary artery.
Tip is in the left pulmonary artery. There's so much of resistance.
Stuff. Do you want to exchange it with some forefront JR and then put a thermo or something and go in?
Show the wire now. Tip. Okay. Show the heart better. Yeah. So now one slip cat. Okay, I'm pulling it out. Hold the wire.
Okay, he's taking this the 7 French catheter out, and over that O14 wire will be taking a 4 French vertebral catheter, or either called a slip cath, to enter into the LPA and then try to exchange with the thermo wire.
The problem is I don't have length of the my length of my catheter is longer than the coronary wire.
The length is small actually.
Yeah. I still have another 4-5 millimeter.
Yeah, the length. This is not. This is a 150 centimeter
it
coronary
out.
wire. That's the problem. Exchanging the 7 French catheter with the 4 French. So I think now
okay.
The catheter is
so
out.
Get the catheter inside.
The problem will be if we take the sheath and if it comes again, it will be again this much time we have to take to go in. That will be
Correct.
the problem.
Correct. Hold
And
it
it's
tightly.
tough to maintain within the ventricle because the pulmonary valve and the mitral valve are very are continuous.
Yes, you got it. Come here. Keep it there. Put.
This should be okay. This will go in.
Yeah. I'm trying it.
Oh, hello. Can the fluoro be changed to normal for some time till we get this, because it's very hazy?
Yeah,
Instead of
it's
medium
hazy for me
fluoro,
also.
can it be normal fluoro for some time?
There's a lot of resistance at this point. Okay, I have a doubt about whether I may be not properly through the mitral valve, so I'm taking it out. Get me that left coronary catheter again. Take this wire. Left coronary catheter with that J termo again. Another option is Cobra. Get me a 4 Cobra, 4 or 5 Cobra. In a usual corrected transposition, he is flipped to lateral view very quickly and try to get the fluoroscopic projection in lateral view. Here, because the pacemaker, we have positioned the patient with the hands down. Okay. Yeah. Come to lateral. Keep coming to lateral. It's directing it towards the appendage.
Sir, sorry to interrupt, sir.
Yeah.
Shall we go offline for 10 minutes, sir? And I will show some cases in between, so that once it is
No
once
problem, no
you are
problem.
entering, the PA will come back, will go live again.
Yeah, sure, no problem. I'm okay with that.
I'll tell someone to coordinate. Once the
come
PA
to-
entered,
come
we
to
can just
lateral fully. Yeah.
we can just say what was done, and you can explain how it was entered.
Yeah.
Yeah. I think.
Keep on going lateral. Yeah. Okay, be there. Advance the catheter a little bit inside. Enough.
No, the thing is, even I was feeling it takes some time actually. These are like quite complex cases, the challenging anatomies where it takes a very lot of time and to enter, and sometimes it goes for 3-4 hours, and I can understand that the program is supposed to get over by 5, and many people would have flights in the evening. So we'll keep the program moving, and once he's entering the PA, we'll move back to the live case. There are some 3-4 cases I will show in between. It was actually part of the talk that was there at the end, interesting cases. These are few cases that I would like to share, which are not very often done. Like this is one of the case of a conduction system pacing that was done in a patient who was around 8 kgs. This is the patient. It was a 2-year-old. When we did pacing, the patient was 2-year-old. It was a patient with a congenital complete heart block diagnosed in the fetus because of maternal SLE. The maternal anti-Rho, anti-Law antibodies were positive. The birth weight was 2.5. The child was having a heart rate of 55, and the child was relatively stable. RC prenalin is something that we start routinely for all these patients, and not every time we will get a clear increase in the heart rate, but we do prefer to give just to make just for our satisfaction. And this patient also had a restrictive PDA. It was around 3 millimeter. It was not very large. So at around 15 months, that is 6 months before this before the procedure, 3 months before this procedure, we actually did a PDA device closure using a 6-4 device. In the X-ray, we can see that there's a PDA device over here. The patient continued to have dilatation of the left ventricle and actually presented to us at 2 years with 2 episodes of syncope. Initially, it was also evaluated by an EEG, and it was confirmed that there was no epileptic activity that was happening, and the MRI also was normal. And when we redid echo, we found that the ventricular dysfunction was worsening. There was actually moderate ventricular dysfunction with the EF of 35. One more thing we should understand is whenever there is such a slower heart rate, usually the EF will be overestimated. Even with that, the EF was 35, so it was really not a good thing, and we can see that there was significant cardiomegaly on X-ray. So this patient was not having any other issue other than a very slow heart rate now with significant ventricular dysfunction. Holter showed a minimum heart rate of 32 during sleep. So since there was significant LV dysfunction, and there was 2 episodes of syncope already, we decided to do a pacing. This was the first time when we did a conduction system pacing for such a small child. This was the baseline ECG with the relatively narrow QRS complex, quite low heart rate. There is ventriculophasic sinus arrhythmia. Then this is the procedure. So before going to the procedure, we don't really, seeing those angios will not understand what is actually the patient size and what is how it is actually. But if you see, this is the PDA device over here. This is I apologize for this hand that is shown in the flora, but we can't help actually. It's needed. If you see, this is this sorry, yeah, these three fingers. This is from actually the lateral wall of the chest to the midline. It's only this much actually. So the patient chest is only this much. This is the chest diameter if you see in this patient. And if you can see one lead that is placed, it is occupying so much space in the heart. So we can understand that how small is the child actually. And the location from here to here is quite small. And you can see this is our routine thing actually. We usually put a wire from here actually, from the right femoral vein, and this patient is done under intubation. The wire was placed, which will serve as a marker. We can see here the vein is quite small. This is a 5 French JR catheter that was taken there. This is just bigger than a 5 French, so it is something like maybe some 8 French maybe is the size of the vein that we are actually targeting. And now the puncture, as I was showing, we will have a wire, so we will that will guide us. And the puncture was done using the standard pediatric puncture needle, which is a O2-1 compatible wire that we use for femoral punctures in all these children. It's not the one that comes with the pacemaker. So this is a puncture that was done, and we can see O2-1 wire is being advanced into the IVC. Here we can see here that it's in the IVC. This is one more reason why we actually don't go with the conventional EP system. Like if you see, this is one lead that is occupying here. We need 6 more leads like this. There will be almost no space actually. There is a lot of crowding, and the pocket will be somewhere here. This region will be exposed. This whole region will be exposed to us for manipulating, for doing a pocket, all these things. If we try to keep so much ECG leads over there, it's very common that we will actually make the region unsterile. That is also one more reason why we don't go for conventional system in children. So this was the puncture that was done, and after the puncture, we actually had advanced that wire over there. Then a JR catheter was advanced deep inside, and we had taken a thermo wire. This is a thermo wire which is deep in the LPA, and then we are taking a conduction system, the CSP sheath, which is the conventional sheath that was shown by Anindya yesterday. Here we can see that we are taking it over here. This was planned for a single chamber pacing. It's not for a dual chamber pacing. It was a single chamber conduction system pacing. So here we can see once we are actually inside, we are in the, this is in the LPA, and we have taken the lead. The thing is, when I realized that it's very difficult to say how tough it was during the procedure, because we don't save too much actually because angios fluoros we don't save often, and there is nothing like the electrocardiograms that will be saved how they save in EP. So we really don't have, other than the pre and post ECG, we will not have anything in between that will be documented. So there's nothing much to show actually, but when we do it, will be quite challenging, these kind of cases. You can see here that it's being slowly dragged down, and we are bringing it closer. And once we come closer and we identify that when you are touching the septum, and we identify that we are getting a reasonable QR in lead V1, then we will try to then we screwed it. And this is partially screwed in, and this is completely in, and we can see a septogram that is done here, which shows that this much amount of lead is actually inside. As Anindya was mentioning, it's not always perpendicular to the septum, so it will usually be oblique, so it's not an issue. If at all this tip enters the LV, we will get a drop in impedance. There was no drop in impedance. The impedance was fine. It means that it has entered obliquely, and it is within the septum. And here we can see that there is a loop that is left, so that as the child grows, there will be no stretching of the lead, and this lead can work forever for this patient. This is the final position that we can see. This is in RAO, and this is in LAO. We can see the lead being screwed into the septum, and it was the thresholds were good. It was like 0.7 within resistance of 7 or 2. So it was good. This is a post pacing ECG. Here we can see here that we can see there is a pacing followed by a delta. We can see here in this it is seen very well. A pacing spike followed by a delta, and then that is like an RS kind of capture over here, which all suggests like a septal pacing, more of a septal pacing, like Anindya was showing yesterday. Like it is a LBB area pacing, but it is not actual conduction pacing. But the overall QRS is good, so this was acceptable, and the patient is good now. Like compared to the pre and post, if you see the QRS duration, it's not really bad. It's really good compared to whatever the baseline QRS of the patient was. So this is at one year follow up now. The LV function was better. LV function was like 47% in. The LV is still dilated. We can see here, but it's 1 year follow up. Maybe over time it should regress, and the EF is around 47. The child is doing well. So some basic from this case, what we learn is the congenital CHB with significant bradycardia may need pacing very early in life. Often the norm was epicardial initially, and people have started doing endocardial nowadays by placing the pocket in the rectus sheath, by drilling it from the subclavian region up to the like subcutaneously, and then placing the pocket in the rectus sheath was one of the things that was followed in some patients. Sometimes surgeons prefer to place the pacemaker, the pulse generator in the in the pleural cavity. Actually, I meant in the around outside the parietal pleura. But all these things are somewhat cumbersome ones, and second time when they have to go, it will be an issue. And as the child grows, again, when it is so far, they will have problems. However, we can it's not very well commonly followed, but we can see that we can do this kind of cases. It's better to go subpectoral in these cases, as sir was showing in the morning. And subclavian vein occlusion is a concern we should be aware of, because we want to put one more lead later for this patient in an atria once the child grows in the as a second procedure, and we have to convert this into dual chamber pacing over time. So we should be aware that a subclavian vein occlusion is a problem in these cases, and it will be of major concern. So one benefit is having a 4 French lead in conduction system may be good, that it may not actually cause subclavian vein occlusion, because larger the lead diameter, the higher risk of vein occlusion is there. And it's always better to give a generous loop so that it allows for somatic growth. And the cons are actually there are some reports of lead fractures in these thin leads that we should be aware of. And even if we give a general loop, we don't know what will be the final length of this patient, and whether that will be sufficient, we don't know. If it stretches and if the pacemaker, the lead becomes damaged, then we have to go again with the another conduction system lead. I don't know like how well feasible it is. And also whether there is a risk of progression of this bundle branch degeneration. We are not aware. That only time should tell us. This is one case that showing. Let me see what is the status of the case. If anything someone want to ask, actually I'll be happy to answer about the pertaining case. I think yeah, everyone waits actually. Like even we wait. But I was telling this case actually was a 2-year. Unfortunately, child presented with syncope. No, if the patient, even now actually, we don't jump and do any case actually. We'll wait till the patient develops an indication for doing it. We don't jump and do it actually. We just monitor. We just wait till the patient is at least reasonably grown. Whenever there is a need, there is a definite need for a pacing only, we will go and do. But otherwise, we don't really electively go and do at an earlier age. Not, yeah, I was telling initially itself, like, I don't, yeah. It's more of a psychological benefit, like, We don't really, yeah, the amount of benefit is really not something that we are clearly sure. But instead of giving nothing, it's if you are giving something that is not harmful, I think it's better to give rather than not giving. Yes. Ah, okay, sir. Some one or two patients probably we have given Derifilin, but not regularly. Any other opinions? Ah, sir. Yeah, I agreed, sir. Actually, like the septal diameter, the septic thickness was actually around 6 mm only in this patient. But as we were discussing, it usually goes oblique, and it should not be of concern. If we get the whole thickness into the septum, then it should be sufficient. We are really more bothered about the stability rather than trying to put it too basal actually. If it goes a bit more to one third also, like one third, two third junction also, we are very happy only. We really don't want to try to get a very like proper like ECG showing that this is clearly a LBB. It's okay, like as we are showing actually, this has a delta with this one, so it is a bit lower actually, but that's sufficient for us. There are some rare reports of fracture. There are rare reports of fracture, but unfortunately, we have not noticed anything at present. We have to see and follow up and decide. So, I think the case is still actually in the same stage. Still not entered the, yeah, right? Still not entered, right? Still not entered. Okay, yeah. No, it's there's nothing like, no, the number of turns is nothing related to the, like it's not always directly proportional. So many times when we thread a lot also, it will still be there. Sometimes when we thread even 3-4 turns, it goes inside well. So it all depends whether it is forming a pit. Sometimes what happens is when we are rotating slowly, it forms a small pit over there and will just keep rotating there rather than going in actually. So we can't say the turns are not of any concern. The how much it is going in on the fluoroscopy compared to the septum is what matters. Actually, we can't control the number of turns, and the number of turns are not really helpful. It's not like, because it is not like that. It's always the coil will be there before itself. Actually, it's not like how in a routine screwing lead where we actually bring it out. It's always out actually. Yeah, the penetrating into if it is known that can enter into the LV cavity. Precautions means if you are whenever we are doing like we regularly periodically check and see where exactly it is. There's actually one instance of our patient only who actually in which the lead just crossed and went into the LV, but we really didn't notice it that time. The patient still has the lead within the left. It's actually the patient has the lead in the LV cavity actually even now, but it crossed the LV cavity and went into the adjacent wall, and it is buried inside the LV free wall actually. That can definitely happen actually. It's quite difficult, and we are giving anticoagulation because of that. We didn't that was noticed the next day, not that day, and we didn't want to come back. But if it goes out, if we take it out and go in, it's not a problem. You can actually go few times, go in and come out also. That's not a problem. But we should be aware. We should check in between to check the impedance to see whether there is a loss of impedance or not. And also the we should be keeping an eye on the ECG changes that's happening. Whether the pattern of ECG has changed, the axis has changed. That will give an idea whether it has gone beyond and gone into the left ventricular wall also. And angiograms will be really helpful. That will delineate the septum and will tell us how much has gone in. We don't really, actually, India was again pointing the tested actually. Like it really doesn't matter actually. Only thing is, it always goes, it's very rare that we go perpendicular. It usually goes oblique, so it's not of major concern. We want a good amount of lead within the septum so that we are stable. really we worry more about stability rather than getting a cosmetic location. No, we are not. We don't do angiogram or anything on the LV actually. Only arterial access will be taken only for monitoring. It's just a cannula for pressure monitoring. We don't go and do an LV angiogram per se. One or two cases initially when we started we have done, but often we don't do it. And echocardiographic understanding of anatomy will give an idea, and then we go and do it. Sometimes some patients do have a CT done for some other indication, and that will give a, we will analyze the CT and get an idea actually whenever we have a CT. But for the purpose of pacing, we don't do CT or we don't do a angiogram in the LV. Many patients will have some LV angiograms because like these are some, like I'm not talking about complete heart, congenital heart blocks. Other than that, some post-surgical patients, usually they would have had a pre-procedural cath or a pre-procedural CT, and that will also add up to the information, and we will use that as a marker actually to identify where we have to go and where we have to place the lead. And often what happens is, though we think so many times, like finally what happens is where we end up, and if we get a good threshold and reasonably acceptable QRS duration, we will just accept, and rather than trying to place where we initially thought also. That's a minor modifications that do happen during the procedure. I think we can go live for some time, and we'll speak to sir and see what his thoughts are. We go live. No definite number actually. If you ask me, I'm not sure about any specific number. Yeah, they. Yeah. Understood. Yeah, if you ask exactly what exactly at what point you will accept, I would say 120 should be good. More than that may not be good. Hello, hello, sir.
Yeah.
Can you hear us?
Yeah. No, Pramod. The same problem that I'm continuing to have.
Okay, sir.
Basically, the moment the catheter enters the left ventricle, it is hitting against the intraventricular septum, and it is bouncing back into the so the guide wire now enters, but it hits against the intraventricular septum. It fails to turn superiorly.
Okay, sir.
You continue with your maybe one more case, and I'm thinking about fluorostoring if at all there is some substantial change that I make.
There's one more suggestion, sir, from the audience. Like, is it mandatory to enter the PA? If the catheter can be pushed up to the apex, is it not sufficient? And then can we start like that? There is a question.
See, for example, right now I am entering into the pulmonary artery. Show the PA. So now we are entering into the pulmonary artery, but the support given by this catheter, this wire. Manoj, can you just advance the? Yeah, maybe give one more wire.
Sir, if we don't enter pulmonary artery and just go into the ventricle apex and then pull up to the septum and see if we can get decent thresholds and decent ECG, will that not be sufficient?
Possible, Siddharth. I mean, basically, we need to come to. There is some amount of difficulty that I am facing in entry into that mitral valve itself. Go back to the LV angiogram in AP view. Once again, show that LV angiogram. Yeah. Okay. Now, you see something like that. As soon as I enter the left ventricle, this is in an AP cranial. I enter the left ventricle, it hits against the intraventricular septum and bounces back. So, show the AP view, plain AP. If you look at the mitral valve orifice, it also looks little smallish. So let me see. I am one of the problem is I cannot exchange this coronary wire. This is not exchange length. Dock and all will not work. I'm pulling. It's okay, Sister Flashman. It's not like the length of this swan is too long. So it's it comes out. You got it? Yes, sir. Now get me the guide, that soft vertebral catheter, the black color one.
Problem last time was the catheter could have gone, but it was, if it is not going freely, the suspicion was whether it is going through the cordage. That is the only reason he didn't want to advance that catheter, and he took it out. Like now we don't know like how we have entered. We'll see how it has entered. But if it is like the problem is we go through the cordage, there is a we are going into the ventricular chamber and again entering the PA. So there's a chance that 2 times we can go through the cordage actually when we are going with the wire. So
okay. Just put it
that's
there.
The problem actually.
Hold the wire. And as I'm advancing, keep on coming closer and closer. Give attention on the wire. You are watching the wire, no? See, the wire is going towards the inferior vena cava. I'll show you. Slightly give the. Okay. Okay. Leave it.
Okay, the catheter is entering the atrium.
See now, the push on this catheter show the hard. Yeah. See, that is a place where we are having the resistance. It's come out. Actually, one more thing, Dr. Villas, we can take one of your deflectable, one quadripolar or some of the deflectable catheter. Get me the, is there a 5 French deflectable catheter? No, okay, no, okay. Now, the thing is, if I have to take this, yeah. I'll give a pigtail. The problem that I am facing is it enters the ventricle and bounces back rather than staying. Let me pigtail and the standard J standard J Teflon wire. Yeah, give me. There was just now I saw one wire which went into the field. Yeah, coronary wire is entering, but it is not giving a support for pushing any catheters. Coronary wire. Yeah. Manoj, get this J wire inside. Ah. Ah. Okay. Little bit out. Yeah, go inside.
I think we'll break for lunch actually. Like lunch is ready in third floor, the same place
Okay,
where it
take
was
it out.
arranged yesterday. Like
Take it inside.
let the case be going on. Like whatever happens, we'll keep you posted. Yeah, you can have and come back.
Go inside. It's directing towards the inferior vena cava. Come to lateral view. in the ventricle.
Push the lead there.
See, at this point, it bounces back somewhere into. So this is all the atria. Okay, leave it. Don't tilt. Okay, take care. It just.
Yeah, yeah. So once you start to do it,
The dilator, when I push it in, no, it. The PA, it is not. It's not in a very stable manner entering the right. See, now the tip of the wire is just engaging and then it's bouncing back because the distance between the mitral valve to
the mid cavity is short.
yeah. It is not. No, if I put in a 6 French sheath,
Okay, now at this stage, how about getting the dilator?
No, see, it has now at this point itself, it has come from the mitral valve into the right atrium now. It's not in the. It's okay. Let me come to AP view. So, hold it. This is actually we get this problem in entering from mitral valve to pulmonary valve often in in corrective transposition because of that. Like mitral valve goes like this, pulmonary valve goes like that. Apex will not be. See, if I go steep into the apex also, that will be fine. Now, I'm not able to get the knee catheter deeper into the. Just get me a right coronary artery catheter. Yeah, 5 French right coronary artery Terumo catheter. Sister Flashman.
Sir, SIMS?
Yes.
SIMS would
Just
work,
have me.
sir? SIMS or an EBU with that
I'm trying with a right coronary catheter. Let me see.
Yes, sir.
Basically, Dr. Ullas was here telling me if I go deep into the right ventricular apex, left ventricular apex, and then keep trying to pull back, I need a stable position.
Yes, sir.
Let me see with this right. Get me, sister, put it on a J Termo wire and give me. Go to this.
Because of that high pressure jet there, just in that subpulmonary area, everything is getting deflected back.
Yeah, it's not staying there at all. Yeah. Get me, sister. Yeah, get the wire. Yeah, one second. Let me make a loop. Come to a lateral view. Let me see whether I can come anteriorly. Yeah, I'm anterior. See, it has gone into the hepatic vein. This is go to epicranial now. See, let me try to go towards the apex. Yeah. No, this wire is so okay. This length is enough, but I am not entering. Sister, konja contrast kudunga. I am not entering into the. Yeah, if I go into the very apical portion, I will then see. So this is more in the inflow region. Let me try to torque. No, right. I need to get in towards the apex. Let me see. This is going more towards the lateral mitral annulus. Just trying to manipulate if this catheter turns. It's in the LV. So that is the LV. I need to go wire. Sister, get me the Teflon wire. Let me see whether I can. Yeah. So now I am taking this out. No, I am taking the. Actually, the wire beyond this, it will bounce out, Dr. Villas. I think I will try with this itself. Now that is lodged in the apex. Can you hold it? Yes. Hold it tightly.
By the way, as you enter, let the diameter be out. Okay, dilator.
It's bouncing back. Let me.
This curve is not really meant for this particular anatomy.
Let me see where we are. Yeah, still maybe inside. Let me, sister, wire contrast.
Finally, what we did, we tried with only
Corrected transposition. Corrected transposition, or that's what. Correct? Is it corrected transposition?
no.
It's touching the wall. Sister, this is contrast, Amma. No, it's coronary sinus. CS. It was CS. Yeah, sister, that give me that J termo wire once again. Sorry, J Teflon. What is it?
Rotary guys for that patient. The patient is here.
No. I think it was long ago. I did some procedure like a ASD closure or some Shankari Shivakumar. They told. Is any of our team member? No, just Shankari Shivakumar is the name. Just we can. I think it was simple ASD closure. I think it was done already. But yeah. Is there any one of? Can you Shankari Shivakumar? SHAN GARI Shivakumar. Find out what is the diagnosis. That's coronary sinus. Hmm. No.
You may actually make the curve, manually a curve, larger. Maybe even if this is acute, manually you can make
I was thinking, if I take a 6 French short sheath, break the hub, use your deflectable catheter, try to deflect anteriorly, push the sheath inside.
there are many things, but you could do this.
Sister, அந்த ஷீட் எழுதுறீங்களா? டைலேட்டர் போட்டுக்கிடுங்க. This is outside now. Did
as acute as small and
I come towards lateral view. I have to face anteriorly. Did Karthi find out what is that patient's detail? Shankari Shivakumar? See, Manoj, can you understand that we have to face anteriorly? Just slightly push it inside. Yeah, maintain there.
sure. So you try your best and think.
This is it bounces into the right atrial appendage. I have to go a little deeper. It's not staying at all.
The option is going to be not your Agilis. Maybe.
Then after
Gets inside. That's all for the last option.
Agilis, no?
Yeah.
I want to give. See, this is being a 7 French sheet. What is that Shankari Shivakumar having? Did Karthi find out? Name itself is not able to find out. SHANGARI. Okay, sister, Prabhu inga cut 6 French or Malin sheet, cut it and give me.
Tell, so good luck to you.
Like basically, ஒரு 6 French இல்லைன்னா இது கொடுக்குறீங்களா என்ன நம்ம பால்கின் கான்ட்ரோலர் மாதிரி குட்டியா இருக்கிறது, so that the decopolar will be even longer than that. 6 French decopolar will go through a 6 French sheet. So open the 6 French. No, if suppose if I get my 6 French sheet a little inside, from there then I will try to see. I will park this on a 6 French decapolar, 6 French sheet. But the only thing is whether the 6 French sheet will go through the 7 French. I am on that you don't pass a sheet. 7 of sheets, 7 of internal, 6 of sheets. The பார்க்குறேன் ஒரு 6 French ஒரு ஃப்ளெக்ஸர் மாதிரி ஏதாவது ஒரு ஆன்சல் அந்த மாதிரி கர்வ்டு 7 6.
You try your best.
Yeah.
Ultimately, what we'll have to do the RV apical missing.
LV apical. LV apical, no. First, yeah. The problem is it's everything is finding it difficult to enter, right? என்ன பஸ் ஏறுறீங்க? எது 7 na, then I have to take this out. Okay, come to AP. Yeah, I hope sister அந்த டெர்மோ வயர் கொடுங்கம்மா. டெர்மோ சரி, அந்த 7 French அந்த 6 French அதை ஓபன் பண்ணுங்க. That is 7, sorry 7. Yeah.
Ultimately, the amplas, the Achilles going all the way, and on the amplas you'll have to pass in that.
Okay. Amplat super stiff. Yeah. That means if I enter into the PA now. Yeah. Hold it. What is the length of that, Prabhu? Sir, கொடுங்க. எனக்கு ஷார்ட் ஷீட் இல்லை, இதுலயே எடுக்கிறேன் இப்போ. Get that, that's a answer or some curve. நீங்க அதை ஓபன் பண்ணி கொடுத்துருங்க. பயப்படாதீங்க சார். இப்ப லேட்டரல் வியூக்கு வாங்க. Glension with a informed doctor. வயரை கண்ட்ரோல் பண்ணுங்க. ஓகே, இப்போ அந்த டெக்காபோலர் Come to AP. Just hold it. Sister, get me some contrast. It's touching the sister wire. இன்னும் கொஞ்சம் contrast ma. Just at the entry point, not okay. ஒரு சிஸ்டர் இன்னும் கொஞ்சம் கான்ட்ராஸ்ட் கொடுங்க. lateral view. We are just somewhere in the inflow region. We have to go. ஐயே close கொண்டு வராதீங்க. Take your hands out. Show the AP view again. See, we have to get it towards the apex if possible. Sister, and the decapolar catheter thirumba. Because this is not going to somewhere here. Yeah. So let me see how I can direct it. AP cranial கொடுங்க. என்னங்க? பார்க்கிறேன் ஒரு நிமிஷம். See now, if I am able to get it towards the apex, show the previous picture. Sister, get me some more contrast. இல்ல அங்கேயே இருக்கட்டும். See, instead of it facing laterally, now it has to now enter the apex. It's a simple lead, conventional lead. Almost it gets into our way. This is somewhere. No, correct. But I see. Yeah, this is now inside. I am trying to convert it. You need to take amplars and amplars distance square and change it to the other sheet. Yeah, இன்னும் கொஞ்சம் apex-க்கு போணும். See, I am now at the region of mitral valve. Sister, இங்க பாருங்கம்மா. டெகாபோலர் கேத்தீட்டர் திரும்ப கொடுங்க. Hold it. Little, leave it. No, pushing illa. Now I'm, see now the. Yeah, that's better. Remove the sheet there, sir. Remove this catheter. That's good. Almost close to that. Yes, that's right. But I don't know where. Sister Saline, is a contrast. Show me that LV, RV, LV angiogram previous. Epic range. Take your hands. Just hold it now. Now, konja contrast.
Hello, sir.
Yeah.
Sir, can we know what is the status, sir?
See, I just got some catheter inside the LV, but decapolar catheter again. Come to lateral view and show me where we are. See, basically what I did was I switched over to a 6 French short Ansel sheath and trying the decapolar catheter to deflect it so that I will be directing it towards the apex. The sheath was poking against the mitral inflow region. I very little. Just move out. So now trying to get, see that is actually poking against the LV anterior wall.
Yes, sir.
I want to make the let me see what sister contrast. Let it back blade. Now only we are getting back blade. We are still facing the LV anterior wall. We now need to get it towards the apex and then try to pull out. Sister, decapolar catheter.
Okay, sir. We'll continue with some presentations and we'll join you shortly, sir.
Yeah, sure. So in this view, I have to go down like this. Okay.
Done few months ago. This actually is a patient, it's a 31-year-old lady. At 20 years of age, she had presented with dyspnea to some institute. That was the first time she was diagnosed to have a DORV large VSD. It's like a VSD physiology with severe pulmonary artery hypertension. So it was Eisenmenger syndrome. She was having desaturation. So the line of management is only medical. There is no definitive option after that. So she was put on sildenafil, and unfortunately she presented with sudden worsening of symptom to us. When we saw, she was having a very low heart rate, it was 42 per minute, saturating 76%. She was having central cyanosis and clubbing, and blood pressure was okay. This is an X-ray which shows multiple end-on vessels suggestive of severe pulmonary hypertension and also dilated heart. This was presentation. She was having complete heart block. The escape rhythm was relatively broader. We can see almost 120 plus is the QRS duration, and also the rate is quite slow. It was around 35 per minute. She was quite symptomatic and was in heart failure when she came. She came to emergency in the night and was started on isoprene infusion by the ER doctor. And with that isoprene infusion, somehow the heart rate was getting better. It was like 70, and we just wanted to wait and see what's happening, because this is a patient who can't undergo any surgery. This is an unoperated Eisenmenger syndrome with a large VSD. The echo was also showing similar features. But problem was, in hospital, she started developing torsades. Here we can see that bradycardia-induced torsades is happening. Like you can see the first ECG, the one on the left, we can see there are VPCs occurring in between, and there's R on T, and the patient goes into frank VT with classical torsades and developed syncope. This happened almost 2 times. And fortunately, we had actually put the patient on Holter that time, so we could record this torsades that developed for the patient. So definitely this patient needed a pacing now. So what will be the approach? So what are your thought process? This is an Eisenmenger who can't be operated, will be left with a large VSD, which is shunting right to left, and has a complete heart block. So what are your thoughts? Okay, anticoagulation. So you would go for a epicardial pacing. So how many would go for epicardial pacing? How many would go for a endocardial pacing? Endocardial, okay. Leadless is, there's no difference between leadless and a transvenous, it will be same. So the issue here we are bothering about is risk of thromboembolism. So either leadless or endocardial, both are same actually. Unnecessary leadless is a very costly affair. I don't think that's of any use. Maybe like here the discussion is about epicardial or endocardial. So yeah, the patient is like quite desaturated. It's a heart failure. So surgery epicardial again will have a lot of dysynchrony. It's likely to end up in having further worsening in future. As such, in Eisenmenger VSD, she has lived 30 years. She may live 10-15 years further without very major issues. So after discussing with relatives, we decided that we will go for endocardial pacing in this patient, and we will treat the patient with the anticoagulation. That was the strategy. So I agree. Eisenmenger is like contraindication. Yeah, that's what see, the classic teaching is correct only. There's no doubt about it. But what the pros and cons, if we see, there is this patient is always at a risk of paradoxical embolism. and we will definitely, we may increase the risk of it by placing a lead. That is one thing. But we really don't know how much percentage we will cause that increase. Because this patient is always at a risk of paradoxical embolism. We can never say that this patient has no risk. Definitely there is a risk. And how much percentage we increase, no one has a data. So sometimes in this kind of cases, it's all depends on the joint discussion with the relatives, how compliant the patient will be with anticoagulation. All these things really matters. We should not do just upfront like this, but what I suggest is at least in centers where actually there can be a good follow-up, and if you're sure that you will get a good result by doing a procedure, it's not harm doing it. Only thing is you should have a very good follow-up. That is meticulous follow-up, meticulous documentation of what is done is very important. So otherwise, never in sinus stenosis transcatheter closure would have been done till now. Never a triple vessel, never a left main stenting would have been done till now. If it say classical thinking, probably nothing would have happened. Something should be started at some point of time because we don't know data. We don't have data. At some point, we should generate data. Like AV sequential pacing should be fine. Dual chamber AV sequential pacing should be okay. But already this patient has some moderate ventricular dysfunction. So preference is for doing a physiological pacing, either a CRT or better is a conduction system pacing. Nowadays data is coming up well that a conduction system pacing is equal or better than a conventional CRT in many cases. Actually, data is coming up. So it's definitely like if you see the Madurai study, the LBBB pacing has been shown to be equally or even better than a conventional CRT in all those papers that they have written actually by Shanmuga Sundaram. If you see those data, it's really good actually, so it's really promising. So conduction system for a DCM has become very well. Even Sir was showing few cases that he has done actually, where actually if you see them, you'll realize like definitely those with severe LV dysfunction do well with a conduction system pacing and not a CRT. It at least saves 4 lakhs from patient's pocket. So we'll go next. Before going 1 second, I just will get switched off. I just want to charge. That the patient had thromboembolism, and to rule out a CT, pulmonary thromboembolism, they had done a CT. This was the CT that was done for that patient. So here we can see this is actually something like a sagittal cut. This is the dilated pulmonary artery. This is the right ventricle. This is the left ventricle, and this is the VSD that we can see over here. Again here, if you see, this is the aorta. This is the this is the conus because this is a DORV, and this is the axial cut where we can see that the RV is hypertrophied. This is the large VSD. The LV is relatively large only in size. RV is significantly hypertrophied, and this is the VSD. So in this patient, by anatomical understanding, this is the location where the conduction system has to be. This is the postero-inferior margin of the VSD where the conduction system has to be. So if you see this, it's something like this is actually just sagittal cuts actually. It's an AP, it's a coronal cut, sagittal cut, and an axial cut. So we have to basically identify the VSD location and just go beyond this VSD and place the lead somewhere in this location. That would, this is actually lateral. This is lateral AP and axial. It was not any, there was no major cuts, like it was not a reconstructed one. It was not a MPR one. It was just plain cuts that we got. So this is where we will anticipate the conduction system, conduction bundle basically. So and by understanding the anatomy, then this patient was taken for the cath. As I was mentioning, a similar protocol was followed. We entered the pulmonary artery. The anatomically, the pulmonary artery was like more or less in the similar way. It was not very tough actually. So I entered with the pulmonary artery, gradually dragged it, and here actually we are facing the septum, and here we do an angiogram as we can see here. Here the septum is, and this is the PA, that is the contrast that is entering into the pulmonary artery. Now it's being driven inside. This septum was quite thick. This was almost like 20 millimeter. It's a Eisenmenger, so it was a hypertrophied RV and hypertrophied septum. So we can see like it was quite thick. So whole this length, which will come to around 17 millimeter, as he was explaining yesterday, the whole thing was actually drilled inside, and we can see a septogram here which shows that this is the line of the septum and whole lead is actually inside. So this was mainly again by anatomical understanding that it was entered, and this is the lead position. Here we can, in RAO actually this is the region where the VSD will be, and this is that beyond the VSD. And this is iliocranial, this is LAO, where we can see that the VSD actually comes somewhere here, and this is the lead that is entered here, and almost from here to here, whole length is in the septum. So post procedure, if we see, fairly good result, very good amount, very good QRS. You can see here the overall QRS duration is actually narrower than whatever we saw in an escape rate. This was the escape one, whereas this is the paced one. The QRS is quite narrow. It's a QR, small q with a prominent R, QR pattern in B1. And this is, the R is quite prominent because also because of the associated RV hypertrophy. So we can see here it was a pretty decent result. And as we mentioned earlier, this patient was started on anticoagulation with heparin after 6 hours of procedure, and we continued giving anticoagulation with the oral rivaroxaban for next 1.5 years now. Like the patient has completed 1.5 years of follow-up. She had some recovery of AV node function in between. So like she is dependent on pacing like 70%. Like A sense, V sense is happening around 25 to 30% of time, but almost almost 60 to 70% of the time she is needing a pacing actually. And this QRS morphology is really spectacular actually, as such. So sometimes we might have to go away from the routine thing, and it may work in some cases, and it's not like something that we should always do, but we should be aware that sometimes whenever there is a case like this, it should be individualized. The decision should be individualized rather than sticking to one single thought process. I think actually they have entered the RV. Can we go live? Yeah, they have entered. Hello sir, can you hear me sir? Is the mic on? Hello sir? I want to hear what they are speaking. No, I should hear whatever they are speaking.
Pramod, can you hear me?
Yeah, yes, sir. Now we can hear you, sir. Yes, yes, sir.
Okay.
You can continue, sir.
So basically, what happened was we could not get into the LV at all. So then now can you get the tip electrode? See whether we are capturing ventricle. I'll just tell you once again, Pramod. See whether V is there. Huh?
But it might not be in contact. It might just be scraping the.
Okay. Okay. So I'll show the couple of 5-6 angios back. Pramod, you are still hearing me?
Yes, sir. We are hearing you.
Okay. Not this much plus. Just next. See, basically we are trying this Van Gens. It was not entering. Next. Then I was thinking whether the pacing catheter is disturbing me, so I took out the pacing catheter. Next, we reached this previous. We reached this outflow tract position, but then it bounces out when we advance any catheter, any guide wire. It was not able to enter beyond this point. Next. So we were trying to get into the apical region. Next. So at the next. So then what we did was, this was an attempt with the right coronary catheter. Again, we entered with the right coronary, but it was not entering into a stable position. Next. So this was the right coronary catheter. It was going towards the lateral wall. Next. The coronary wire also did not help. I think you are watching these things. Next. So what we did was we advanced the decapolar catheter. Okay, this was a thermo wire entering into the left ventricular apex. Next, this was a 6 French Ansel sheet with the decapolar catheter deflectable, and the decapolar catheter deflectable we just pushed it into the apex, but this was going towards the LV anterior wall. Next. So this was in the LV anterior wall and not going towards the apex. Then we kept manipulating. Next. So this was in the LV anterior wall. Next. We tried for the little deeper position. Next. So we were next. It was not easily entering. Next. So then the amplat superstrip guide wire was parked with 7 centimeter floppy end. The hard end was anchored in the LV apex. Next. Then with that we took this Medtronic CS sheet. Next. But the Medtronic CS sheet was not able to enter beyond the mitral valve. Then we pushed it. Next. So the mitral, it was pushed deeper. Next. So this was the it flipped out entirely into the right atrium. Next. So then again we manipulated and we got it now into this area. We are just below the subvalvular area. So now we are somewhere in the region of the patch also. Next. So this was an angiogram just in the subvalvular area. Next. So this is the place where we are now trying to, this is the epicranial projection, trying to get it, okay, but then this particular position, it's not anchoring well.
Okay,
so I am now taking it out.
So what is the rotation that is given to the his sheet, sir? You are giving a counterclockwise like how you routinely we do, or anything else?
A little bit counterclockwise, but then RAO, LAO will not help at all because the septum is totally sagittal. No, I am trying to get it. Leave the sheet, Manoj. Leave the sheet to me. Okay, just hold it here. I am now trying to. I'm just getting it inside so that I'm securing it.
The ectopics have a QR morphology in V1.
Okay. Now I am getting the.
In this actually the first three are 1, 2, 3 and the fourth is lead V1 actually in this.
So now I am connecting it to the.
Or no, the last is V1, sorry.
Get me some contrast, man. Okay, I'm having the contrast.
The first 6 are limb leads and the last one is V1.
See the. Okay. Okay. See, this is the septogram now. I'm going obliquely. This is the pacing characteristics. So that is this is the pacing area. At what threshold you are losing it? Okay. 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 Now I will do one thing. I will just keep drilling inside, and okay. Don't push it. I'm giving a septogram. I'm not making a substantial progress beyond this point. I am connecting to ventricle. Maybe if I take it out from this position and directly go into the septum, it see the pacing here. Now, in these corrected transposition and all, I don't know what exactly V1 should show, what V should show. So primarily, I'm looking only at narrow QRS. Obviously, this is now very minimally penetrated in the left ventricular side of the septum. What is the threshold?
0.8 loss of capture, 0.9.
Okay. So, I mean, threshold wise, we are okay. We are just less than 1. But
okay, sir.
It seems very superficial. So I will withdraw it and then repoke because it's going in one direction. I don't know whether it is directed
towards the patch.
I don't know because it is. I see whatever I do, it's going superiorly.
Okay, sir.
It's now already. Let me see. Can you magnify it and show whether there is any rotation? Full mag.
No. Doesn't seem to be rotating.
Yeah,
It looks static there.
yeah. Yeah, I understand. I agree. So this is the septogram. It's not making a substantial progress. So one of the options for, I mean, in terms of threshold, it is low. See, this is the native QRS. How I have connected. Start facing. Okay. 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 Aparna says that 0.7 it's lost, but then the amount of saline.
No, not really. Actually, sometimes what happens is when we check with the tip, but we just make sure to check with the ring just to see that it is actually touching the septum, because we want good amount of depth inside so that it is stable. Otherwise, the stability is the main thing. Actually, we really worry about first. Actually, that's the first most important thing is stability. That is one thing. Sometimes sometimes it happens that sometimes unipolar will
I am
give
not
unipolar
making
facing
progress.
with unipolar facing with.
So one option is I pull it out and then repenetrate. So hold it here. Okay. So now fluoro store this. Get me some more contrast. So I'll just check. So this is a little bit more lower, but if you remember, our position was in the epicranial view, a little below the midpoint between these two sternal wires only.
Yes, sir.
So I am trying to drill it now in this location. It's very tight. Okay, I'll just see whether. Okay, see now I'm trying to clean the lead out. Sister, can you give me? Just hold it. I need again. So I am trying to take out this tissue. Gauze piece. Saline. Contrast. Now, show a little bit more of the apex also. Move the table. Not, no, you come towards me. Yeah. Little towards me. Yeah. So that is the place where we are. Saline. I'm drying my hands. Yeah. So I'm now trying to enter. So now, at this point, actually I took it on Cine because you will not be able to see the, check the ventricle, sister, contrast. Okay. Whatever you are talking also is audible to them. Okay, she says that the R wave was 8.3 volt. Okay.
Impedance is 1200.
Okay, sir.
Impedance is
We are able to
1200.
hear.
Aparna also you are able to hear.
A bit faintly.
Okay, okay. So she showed us, okay. Now, she's pacing at 5, 4, 3, 2,
1.5.
1.5,
1 volt.
1. Okay.
0.9.
Okay. Now in the okay. Now I am planning to get one septogram. This hand. Okay. She says it's losing capture at 0.3. In terms of threshold, it is good. Pinch it. Yeah. In terms of threshold, it's okay. In terms of penetration also, it looks okay.
Okay, sir.
Yeah. So now I am swapping the black to the ring, and I am peeling the sheet a little out. It's capturing the ring electrode also. Ring electrode, okay. Okay. She says that she's pacing at 4. Now on the LV side of the septum, the patch will also be there. Yeah. So some edges of the patch, some sutures, because the surgery was done through the VSD closure through the left ventricle. Okay. So that is not a great sign. But let us see, by bipolar, what is the threshold? So I am getting bipolar on the ventricle and seeing the QRS thickness, like QRS duration.
Bipolar R waves are 9.
Bipolar R wave 9.
Facing on
Impedance
impedance 850.
850.
This is at 5.
It's at 5.
4.
4.
3.
3.
2.
2.
1.5.
1.5.
1 volt.
1.
0.9.
0.9.
0.8.
0.8.
0.7.
0.7. This is 50 speed, bus. Here it is 50 speed. 25 speed. Okay. 0.5.
0.5.
0.4.
0.3.
Okay.
Losing.
Okay. Okay. Same 0.3 we are losing. So what I'm going to do is now just repeat one more septogram. I think in this position already I did the septogram.
Just now you did, sir.
Yeah. So I will try a little
To
bit
go
more
further
inside. So I have disconnected. So I'm getting the sheath to approximate. Again, I'm going on a cine. Yes. Some rotation I am seeing, Aparna tells me to stop. Okay, so I am getting directly bipolar. Then I will check the ring also. Okay, bipolar. R wave 9.2, good injury. Yeah. Impedance 970. 5. 4.
4, there's a transition, sir.
Okay.
I can go back to 5. So there's a small R and a deep S in B1. I come back to 4. There's an RS pattern.
Okay. But I don't know how much all these things are trustable in a corrective transposition. Anyhow, the QRS to me looks narrow. Okay. Next. 3. 2.
Facing, sir, 1.5.
1.5.
1 volt.
1.
0.9.
0.9.
0.8.
Okay. So now I am giving the ring electrode alone now. Just to know whether I have gone in a little deeper. I'm giving ring alone. Okay. Okay, I'll expose.
Facing on, sir.
Ring R wave.
In R waves are 6.7.
Okay, okay.
Facing on,
Facing on ring electrode.
this is at
5.
4.
4.
3.
3. 2.
1.5.
1.5. So actually, I think the RB has gone a little deeper, and I mean, yeah, the ring has gone a little deep. Okay, one it is getting lost, but I think I suppose it will get better. So now we'll peel it out. Get me the slitter.
So okay, the position. You are accepting the position, no, sir? Yes.
Accepting the position. See, I will. You want another septogram?
No, sir. No, it's fine,
show
sir.
the
I
last
just asked you. I just asked for confirmation.
Yeah, position. I feel I will show the last septogram. See this one.
Yes, sir.
See, in this epicranial projection, between the two sternal wires, we are little below the middle. Show the original epicranial projection. Slitter. Yeah. Yeah, D-bag. So I'm temporarily going off. Sister. Schlitter. One sec. So now, okay, come to AP view. Okay, so now I am taking out the, just once we will connect bipolar to the ventricle and check again. I'm giving you ring to red and tip to black. R wave.
Bipolar R wave 9.6.
Okay. Okay.
Impedance 900.
Impedance 900.
Set 5.
Okay.
4.
Yeah.
3.
Yeah.
2.
Yeah.
1.
1 now. Yeah.
0.9.
0.9.
0.8.
0.8.
0.7.
0.7.
0.6.
0.6 loss. Okay. 0.7. Injury is good. Okay. So keep it at around 1. I'm taking out, or let me slightly withdraw. Okay. Now I'm taking out the peel away sheet. The loop. Yeah. Yeah. Now I have, can you check again the threshold sister for thumb forceps?
Set 1.
Okay. Pacing at 1 now.
0.9.
0.9, 0.8.
0.7.
Now you have to open it. 0.6,
0.5.
0.5, 0.5 losing. Okay. Sister, suture, keep it at 0.6 or 0.7. I'm suturing the ventricular lead. Give me 4 seconds. Just remove the tissue. Sister. One second. Give it to me. Come this side, Manoj. Can you- So now I am suturing both the ears. Katma. Yeah. 7 French dilator. Come this side. So let it be connected to pacing. Keep pacing. Okay. 7 French dilator. Ma. Give 1 dose of Targocid also. Sister, give some fentanyl 1 dose. Bye, brother. Bye, brother. What did you put? What did you Okay. Over.
You mute, this is mute or this is not mute? Are we muted to them? I don't understand. Mute to them. We are mute to them. Angi mute la. Okay. Now I think we can just now it will be a standard RA lead followed by the pulse generator implantation. So if you want to continue, we can continue seeing this, whatever you say. If you want to continue seeing this, we keep continuing this, or Dr. India will be there in a while and he will continue with his lectures. Whichever is fine, you can we can do, whatever you say. Okay. Just mic on. Hello, sir. Hello, sir. Can you hear me, sir?
Yeah, please.
Sir, like since it is a conventional thing from now on, we are continuing with some lectures here.
I think so.
Okay, sir.
I think you should do.
Okay, sir. Okay, sir. Thank you, sir.
Yeah, thank you. Thank you. Okay, let me connect the.
So actually, this is like till he comes, I'll just show one case. Actually, these are some. This is one of the case. This was done even before we started doing the conduction system, conventional conduction system pacing. Actually, for CTGS. This was a patient who was 41-year-old. She presented. She was a newly diagnosed case of, it was a case of CTGA without PS and no VSDs, intact septum and no PS. Was having significant tricuspid valve regurgitation because of 59 malformation. So the patient underwent a bioprosthetic valve replacement when she was somewhere like 30 years of age. The post-op she developed complete heart block. So post-op, then she initially underwent a dual chamber pulmonary, PPI. Where it was a classical morphological LV apical pacing and right atrial pacing. We can see the lead over here actually. The lead tip is here. And the patient ended up in few months with permanent atrial fibrillation, and after that, over a period of time, she had progressive worsening of the morphological RV function, that is the systemic RV function, progressively worsened. She went into NMHA class 3 status and was having very high BNPs, was almost like 10,000. So this is she was pacing dependent. She was completely pacing dependent. This is the paced rhythm that we can see. This is a QS pattern in V1 to V6. Almost everything is like more or less similar. Quite a broad QRS complex, almost like 140 to 140 plus. And this is the ventriculogram. We can this is the echocardiogram. We can see. You can see how pathetic the RV function is. As I was mentioning earlier, this is the septum. This is a patient who has no pulmonary stenosis. So the RV, the morphological LV is having a normal pressures, and the RV, the systemic RV is having a very poor function, and we can see during the systolic contraction of the free wall, the septum actually bulges bulges into the morphological LV, the subpulmonary LV. If you take, when we took this patient for the cath, it was even terrible. I will come to that. Yeah, let me go to the, where is it? Don't have it. One second. Sorry, I don't have that image actually. I'll just come back. Okay, so in this case, if we see the problem, sir, this is actually a patient who has significant systemic ventricular dysfunction. The cause will be multifactorial in these kind of cases. One is the RV geometry itself. As we all know, it's not suitable for sustaining systemic pressures. The myocardial arrangements are different, so that is a problem. RCA is the vessel that will be supplying the systemic RV, and it is not as big as, is not as large as a left coronary artery which supplies the actual functional LV. And also the right bundle branch is thin, which are all the reasons that causes a RV dysfunction in this patient. And that time actually still we were not started doing the conduction system pacing regularly. So this patient was planned for a conventional CRT. So if you see the anatomy, this is how it will be usually, like the current anatomy, similar anatomy. The RA over here, the morphological LV will be mostly anterior and will have some degree of mesocardia, and the PA will be bang arising just adjacent to the mitral valve, and this is the LV with aorta. If you see the coronary artery anatomy will be like similar to the morphological ventricles. So this ventricle, which is the morphological left ventricle, will be supplied by the left coronary artery. So this is the this is morphological left coronary artery which arises from the right coronary sinus, and this is the left anterior descending artery, and this is the left circumflex artery, and this is the right coronary artery which supplies the morphological right ventricle, and this actually is the usual RV branches that we see in a right coronary artery, which are actually supplying the main ventricular musculature over here, and this is a posteriorly going PDA, and this is the actual PLV in conventional cases. So the problems would, but this is a coronary artery anatomy which is fairly constant. There is no major variation in coronary artery anatomy, whereas a coronary venous anatomy is more complex. coronary artery anatomy, like if you see one of the studies like which had, if you see like though 90% of them have normal anatomy, many have abnormal anatomies. Like epicardial veins can drain directly into the right ventricle, either into the proximal, mid or distal third in the following percentage of patients. They have multiple Thebacean veins which actually drain directly into the right atrium. And there is also an entity called dual coronary sinus which can actually be there in some patients where the actual coronary sinus will be draining part of the ventricle and rest can be drained by one more anterior coronary sinus. So this is the right coronary artery angiogram. This is a AP view, the PA view, and this is a yellow cranial view. We don't see very well the coronaries. Coronary veins in levo phase are not very well seen. So what I have done is I have actually frozen here and I have actually enlarged. Here we can see some coronary veins that are actually coming over here, and then coming and draining here. And here also we can see faintly one vessel that is coming here, the coronary vein that is coming over here. Again in an RCA, again in lateral view and in RAO view, if you see, this is the conventional right coronary artery angiogram, and here actually in the levo phase, I will just increase the bright contrast and all to see how it appears here. This is the coronary sinus which is actually going posteriorly, and this is the same vessel which is actually seen rightward and posterior. And this is the left coronary artery. This is the left anterior descending, and this is the left circumflex in a conventional in a conventional person. This actually again in PA view and elevocranial view. Here we can see that there are multiple coronary veins that are coming here, and it is coming here. You can see this one. This is one of the coronary veins which is actually coming and draining into the right atrial appendage site where actually the RA lead has been fixed. And the similar thing in a elevocranial view, we can see here, I was showing one of the coronary sinus which is going posterior till here, but here we can see it is coming into the appendage. This is one more coronary sinus. So this is the anterior coronary sinus. So again here, if we see in two different views, here we can see that this is the better seen. So here actually we can see again, this is the vessel that I am actually concentrating here. This is the anterior coronary sinus because that comes here and drains into the RA appendage. So anatomically, if we schematically draw this, what was there was some Thebacean veins which were directly draining into the right atrium. Whatever is darker is anterior. So this is these are the main vessels that are actually coming from anteriorly, and they crosses the septum, and crossing the RVOT, crossing the LVOT, they will reach the RA appendage. This can be termed as the anterior coronary sinus. And here posteriorly what we see is a thinner one that I was showing in the images. They were quite thin vessels and they were draining into the actual coronary sinus location. The anterior coronary sinus, posterior coronary sinus. This is the routine anatomy, and this is the other vessel which is actually called, we can call it as an anterior coronary sinus, which was actually coming into the RA appendage. So we decided that we can target this one because we enter through the, it would be easier to enter the RA appendage and from there enter into this vessel, which would actually pace the morphological right ventricle, and the lead that was actually there already before, which was in the morphological LV apex, will pace the will pace the left ventricle, and thus we can achieve a biventricular pacing. So here is a conventional puncture, and then here we can see we had actually entered that vein from the femoral axis itself. From the femoral axis we had entered into the appendage, and then we had actually advanced the wire into that anterior coronary sinus that I was discussing, so that it will serve as a marker where we have to enter. So this is the vessel that I was talking about, and this is from the femoral vein. We have entered deep inside and we have done an angiogram. This wire is just placed there so that this will act as a landmark for us to cannulate from the subclavian vein. So this is a the puncture from the subclavian vein. We went here. We did multiple maneuvers. We took we exchanged multiple catheters. It was not engaging. We were trying to, we were getting a wire a bit inside, but we were not able to go in. Finally, after multiple attempts, almost more than 1 hour of trying, actually we went with the strategy that sir tried today. This is, we took a decopolar catheter with a CS sheath, which as we can see here, the decopolar catheter was deflected and we could enter into that vein that we were actually targeting. Here we can see the decopolar catheter is going in, and once we were in, we advanced the sheath marginally inside and we could put a wire, but after that the wire, the sheath, the CS sheath was not going in. So we took a 014, we took a 2 into 4.5 coronary balloon, we advanced it, we just dilated the proximal tract, kept it there, and then with the help of that we exchanged it again with the decopolar catheter, advanced deep inside, and then we could push this CS sheath into the anterior vein that we were targeting. This is the angiogram. Now we can see that this is the vein that we were targeting, and we wanted to go into one of these veins and pace it. Now this is the wire going in, and then this is the CS lead that we have taken inside. So this is the this is the final position where we have finally landed that other lead in the location. If you see, like these two are quite wide apart, so they will be generating. Okay. Yeah. So this was the final location. It was good, and this is the post-procedural ECG. Compared to whatever the previous ECG was, the ECG had a relatively narrower complex compared to the previous pacing, and the patient is hemodynamically better now. This is a 2-year, this is almost a 4-year follow-up now. The patient is doing well. So I think Anindya is here. He will continue with some presentations, and then we will get ready with the third case by then.
This is the live thing going on. This is closing of the previous case. So we'll discuss this CTG anatomy a little bit more, and we'll finish the implant techniques, right? had seen the anatomy of the so in CCTGA. Hello. So in CCTGA, the left bundle is on the right side. The problem in CCTGA, if I draw it in RAO view, is that the mitral annulus, which is on the right side, is continuous with the pulmonary outflow. But the sinoatrial node and the anterior his is on the RA side, means on the tricuspid annulus. So if it has to come to a more anterior location to divide, it has to cross the pulmonary annulus, and then only it comes and divides into anterior fascicle, posterior fascicle and septal fascicle. And also the right bundle. Right bundle is actually not seen here. We are seeing RAO. So it is the RV endocardial aspect. Okay. So where do I go? I'll just remove it. Put it.
Keep on mopping.
Hello, sir.
Yes.
Sir, you are live.
So, yeah, okay. See, basically, what we did subsequently was, fixed the pulse generator. Right now, I am doing the subcuticular. So we use a 30 vicryl. It's a semi-absorbable suture, and we come out through the dermis. Is my camera seen?
Yes, sir, it is seen.
I think there were two technical difficulties in the way we were entering. One thing is we know that there was a large perimembranous ventricular septal defect that was closed at some point of time in him. So what was happening was, it's likely that whenever my catheter was going and hitting against the left ventricular septal wall, somewhere in the region of the patch, the rigidity of those areas, it was deflecting the catheter, and it was not allowing it to enter inside. And moreover, I feel marginally the mitral valve is a little smaller than the tricuspid. So that also was playing a role because the balloon flotation catheter was not going inside so easily at all. So finally, after all the attempts failed, we took a deflectable decapolar catheter, directed it anteriorly on a lateral view, and once the decapolar catheter entered the left ventricle, we pushed in a 6 French answer sheet, which is a flexor sheet that we had already mounted the decapolar catheter on. Actually, I took out that 7 French shot, the safe originally that was taken, and then I changed it into a 6 French answer, and then from that 6 French answer, this decapolar catheter was placed, and then this decapolar catheter was, once it entered, the sheath was pushed, and once the sheath entered, subsequently we put in an amplitude super stiff guide wire to anchor the sheath and the guide wire into the apex. Now I am coming through the apex of this subcuticular stitch. It's going to be the last stitch. So for the last stitch, I take it far out and come out of this. So then I tighten this. Once I have tightened, I take a tiny bite. So now we have created a loop. Holding the loop, tightening the loop, and tightening the knot. Yeah, Sister Scissor, I'm cutting it a bit close. Similarly, there was one edge that comes out here. So now when I am removing the IO-band, that is the sticking plaster, I ensure that it's in the same line. Just as some antibiotic soap gone. So we are removing this IO-band plaster. And when I am removing in the line of the stitch, not perpendicular to it. One second. Can you get me another antibiotic soap gauze, please? So now this is the what is that? I didn't hear. Targocid given. Okay. Since the procedure was prolonged, I told them to give 1 dose of teicoplanin 400 milligram also. So that has been done. Okay, the wound looks okay. Sister, now, yeah. Dry gauze. Sorry for making it very boring for you. I mean, entry into the left ventricular outflow tract and pulmonary artery, even during diagnostic catheterization, can sometimes be very challenging because of the sharp bend between the pulmonary outflow tract and the mitral inflow tract. So we don't put in pressure bandages. Because when we put very tight pressure bandages, the sweat that accumulates there, I feel can create infection. So normally I don't give any pressure bandage. Just leave it like this with this primopore now. So is there any other question? Ravikumar, what is your chin?
Sir, Arvind here.
Yeah,
so
yeah.
In the last case also you did the same way of, or did you give a pressure bandage? Because in the last case there was a bit of bleeding.
No, I didn't give. Normally, is it Aravind?
Yes, sir. I'm.
Yeah, Aravind, I don't give at all, Aravind. The problem is, whenever, during my residency days and in my early days and all, whenever we gave a pressure bandage, the next day morning go and remove that pressure bandage, there will be too much of sweat in that area because of the warmth and the tightness, and the whole area it will be smelling. Second is it will be very wet sometimes because of the sweat accumulation, and I feel that is a more easy way of getting a wound infected, and so I don't practice this pressure bandage at all. If at all there is, your point is correct, because we have get one 12 lead ECG quickly on this patient. Your point is correct, because you have a chance of oozing, but I never practice pressure bandage. So as I see you,
I remember that from my fellowship days. Also. From my fellowship days also, I remember that we never used to put that.
Yeah. Okay. Now let me try to get 12 lead ECG soon, within the next few minutes, and try to see. I will also try to pass on the previous patient's 12 lead ECG to the. Okay. Now, is my camera still on for you?
Kind of.
Kind of means not. You are not seeing.
We are seeing the ECG leads. We are seeing some things, but
not so clear, right? I mean, Dr. Anselin, one of our senior persons, will come and show you this ECG. It looks sleek to me. Okay, can you go take it to the hall and show them? In another few minutes, we will send you this patient's 12 lead ECG also. Okay. I think Anindya can continue the talks, and we are now proceeding for the third corrected TGA with native IVS. And there is no operation that has been done. And this patient had intermittent high-grade AV block with one episode of syncope few days before and dropped in an auto rickshaw. Yes. We doing a patient in him. So I will just get scrubbed. I hope Anindya will give some more talks, and I'll try to join you as soon as possible.
Thank you so much, sir. Such a difficult case and such a nice result. Sir, we'll go offline.
Yeah, thank you. I have time.
So we'll quickly see. By now we know how to do the implant, but we'll just see how our CCTGA thing works. So in CCTGA, left bundle is actually on the right side, and right bundle is on the left side. So which is the bigger structure? Obviously left bundle. Left bundle stays left bundle. It doesn't morph into a right bundle. So right bundle stays as a single branch. So if you see this is a left lateral view. So the left side of the septum, which previously in a normal heart, we were seeing like this. Now left side of the septum is by a right bundle, which is a thin cord-like structure. It will give a moderator band and Purkinje. While on the right side, which is the left ventricle, which sir was accessing, that has the left bundle on its subendocardial aspect. So it is full of conduction system tissue. So there have been 2 series of patients of CCTGA with pacing. The largest one with 15 to 16 patients actually tried left bundle pacing. So because the target is big, easier to reach from the right side itself. We don't have to penetrate deeper. So what they found, that you don't have to penetrate deeper, and there is a large area where you can just screw in little bit. You don't have to go deep, and you will still get a narrow QRS. But what will be the morphology of this QRS? No, it will not be RBBB. In that LV septal diagram, it will be LBBB only. LBBB or a normal looking QRS, incomplete LBBB. So the morphology here will be narrow, but still an LBBB. Again, target will be as proximal as possible. The best thing is to do a his bundle. Why? Because, oh, yes sir. So that's what sir, for left bundle area pacing, we have the Medtronic system which uses a special thin lead which we saw. But there are other vendors also. There are Boston, Biotronic and Abbott. With that also we are doing left bundle area pacing with their conventional lead only. There is nothing different about that. Even a conventional lead which I was showing you, which was not isodiametric, which has a helix which is not in line with the body, that is also that will also be able to take you across the septum. There is no problem at all. So what is the use of that special lead? Yes. So the thing is, in CCTGA, the most common problem is left-sided ventricle dysfunction, morphological right ventricle dysfunction. So the ideal side to pace would be the side of the systemic ventricle. So if you can do a left septal pacing, left ventricular septal pacing, left-sided ventricle septal pacing, morphological RVL. Oh no, what no problem. It's okay, so 5% is there. So, so that will give you earlier activation of the left-sided ventricle. That is okay for us. Or if you can catch this thin right bundle, that is also okay. What? And the stability also will be good. No, नहीं आएगा. Sir, कोई problem नहीं, जल्दी खत्म, ये हो जाएगा खत्म. But our main aim is to attain a stability, and we don't want to spend a long time during the implant. And for that, we don't have to spend much also. If you just target any area which is little distal, which will give you an LBBB morphology, which is actually not good for the morphology systemic ventricle. What will be good is if you can capture the his bundle. His bundle, where is the his bundle? You don't need to map. Below the LVOT, below the PA. So below the LVOT, so the his bundle, the AV node is normally located at the junction of mitral annulus and the pulmonary valve annuli. From there his bundle starts, and his bundle will wrap around the pulmonary annuli, and then it will come down, dip down and divide into all these fascicles. So it is this part which gets stretched over a period of 30 to 40 years. So in the 4th decade, these fibrotic, dysplastic, stretched his bundles will give way. So there will be complete heart block. But there is a portion of the his bundle which is below it, which is still healthy. If you can pace your lead there, it is like a his bundle pacing only. This his bundle is not like a classical his bundle. Classical his bundle is where? Here, correct? And here it's an annular structure, fibrous structure, lead stability is not good, sensing parameters are not good, pacing parameters are not good because it is surrounded by fibrous structure. There is no muscle around. On the contrary, here if you go just little bit only, you will get a narrow QRS, good threshold, everything okay. I have not done an implant in a CCTGA, but I am telling you from the paper only. So in CCTG would be an ideal, should be an ideal patient where I can do a conduction system pacing without any effort, because it is made, the conduction system is handed to me in a platter on the right side. You don't have to penetrate deeper. But there have been studies in, yesterday Dr. Sai Kiran was telling, in their center in Chitra. What they did is they mapped this, all patients were with systemic ventricular dysfunction, they mapped this. They found the root of this right bundle, and they placed the lead under 3D mapping in that specific position. So that is another way of doing it. But in a non-research setting, it is very improbable that we will be able to do it. But you should keep in mind, conduction system pacing should be easy in a CCTG, because the left bundle is on the right side. So with this, we'll just go to the implant again. So we had seen till what point? Keep. So we were here. We had seen that when we screw in, the morphology changes from a W. The morphology changes from a, this is V1, the morphology changes from a W to a QR. So you can take this square as the septum itself. This is the thickness of the septum. As my lead goes inside at different places, it will give a morphology conducive to that. When I am in the RV side, there will be a QS with a notch in the nadir. As I go right in the mid septum, the notch will be moving right, and as I cross it, there will be a small R coming up. Yes, that will happen. So that's why we saw already a QR we saw, right? I don't know, I have not seen the result because we have gone deeper. It's a septal pacing only, but it's a left ventricular septal pacing. Which ventricle is on the left side? RV. It's left-sided ventricular septal pacing. It's not an LV septal pacing. So how, and we discussed when we pace, so in the septum, if my ring is also inside and the tip is also inside, my ring will also capture, right? So when I place the black crocodile clip on the ring, it will give a morphology of what? Of the exactly where we started with. W in V1, 2 positive, 3 negative, and a transition at V4, V5, whatever we saw. So that tells you that you are deep inside the septum even without a septogram. And these things. So when to stop advancing the lead? When you see a QR, stop. Your tech will tell you what your tech has to continuously tell. Sometimes it happens is if there is some septal disease, if you go inside, there will be slow development of a QR. The moment you reach QR, you may think I'll go deeper and get a small Q, big R or an RSR. That is the logical progression of RBBB. But sometimes what will happen is if you reach a small QR itself, after that immediately it will give way because the septum is not that thick. So the degree of QR is not related to the point where the left bundle is. Sometimes we may miss the left bundle, we may perforate. Before that there was a small R only. So you have to depend on the tech also. He will tell you what is the impedance. The impedance will start with somewhat 900. If you go back, 1 second, it's not there. He will say here the impedance somewhere is 900, 840, 760, 720. You will have to just look for a drop of more than 200. If there is a drop of more than 200 or if the absolute value is less than 500, stop. Because less than 450 is defined as perforation. Okay. So you should stop when the drop in impedance is more than 200 or absolute value drops more than 450 or 500. If you get a narrow QRS QR, is that you can stop anytime. If you lose capture, you should stop and see. Loss of capture may not always mean that you have perforated, because your knife is hitting new tissues, there will be injury throughout and there will be edema. There will be increased threshold of whatever tissue you have captured just now. So immediate thresholds will be high only. But in time, as we discussed, the injury you should see, should ask the tech to see local ST elevation. If there is a big ST elevation, that means if you wait, it will get better. And then we can do a septogram at the end. Slitting, as I told you, will first involve giving a slack. You feed the lead in, you take the sheath back, and the slack should not be here in the ventricle. The slack should be in the atrium. So after you do that, we had discussed this yesterday. This should not be the slack. The slack should be what is on the right side. It will be made okay. 1 second. So this is the correct one. And this is the final result. The case which Shiv Kumar sir did is an anomaly. We will not normally do pacemakers in such cases, even in pediatrics also. So you should not be discouraged that what will happen if I am not able to penetrate deeper, or if I don't get a LV septal pacing in such cases. Because when in majority of the cases, the septum will be conducive for deep septal penetration. You will not have so much difficulty. And it will not be as easy also as the simulator yesterday, but you know how to maneuver in the RV, because you people have done cath every time, and RV is like a easy playground for you. So just go inside, position across the septum, try to go anywhere. In 1 or 2 cases you will have difficulty because you will inadvertently push the lead too much. It will get, so you have seen with Shiv Kumar sir also in the first case, it was taking a bend like this. It was because you will always have to have the support of the sheath. But in trying to rotate, you may not keep in mind that they are co-aligned. Sometimes you will try to push. If you push, the sheath will kick back. If the sheath kicks back, the support will be gone. And you saw the lead yesterday. Everyone of you felt it. It gives no support because there is no stellate inside. So you just have to make sure the sheath is always abutting the septum, and you just rotate. Don't push the lead at any time. The screw will directly take you inside the septum. It will draw you inside the septum. So this is another case. On the LV side, on the RV septal side, it's difficult to see a notch because the speed is around 50. So this is also important. The notch which we are seeing there was at 100 speed, 75 speed. But the hemodynamic monitor ECG which you see there in your lab will be 50 speed at max, or 25 speed. So you should, and we discussed, right, even if you get a W, you may not capture you are exactly opposite to conduction system, all right, but that is provided you go perpendicular. But are we going perpendicular? No. So if you start without a notch also, you may go obliquely to a site where there was a conduction system. So you don't need to actually harden. There is no hard and fast rule that you need to have a W. You just need to follow the criteria that you are at a proximal location, a good enough axis. So at this location, when you go, you can get a QR. This is okay, done. This is not required. Sometimes you will get potentials also. That is also not. So we were discussing template beats, right? So how will the template beat look like? So this, so imagine you are screwing in and you have only one lead on the hemodynamic screen you are looking at. So V1. So where do you think the lead is now? It's on the RV aspect. You are going inside. This is not a pacing morphology. This is just a PVC coming from that side. And when will you stop if you see like this? What does it basically indicate? If your lead is on the RV side, it will give a PVC like this. If your lead leaves the left bundle, it will give a QR PVC. So that's it.
So we should always enter all the black part.
Sir?
Till the black part of the lead.
No, sir, it is not hard and fast rule. If you are actually going perpendicular, you should not go to the black part. If you go till if the septal thickness is 10 millimeters, and if you are going perpendicular, if you reach the ring, it will perforate. Because 1.8 plus 10 distance, 9 distance, 10.8 already has passed, right? So you should go in. The criteria is when do you stop? We should not stop when you get the ring inside. We should see whether there is a QR or not. If there is a QR, you wait. Axis is good, narrow QRS, you should be happy. Then you should confirm conduction system capture. How do you confirm conduction system capture? Check threshold that time itself. And LVAT you can check that time also or later. But for all practical purposes, left bundle area pacing is equal to RBBB. You have to achieve some RBBB. Sometimes what will happen is you will perforate. You will perforate and hit the lateral wall of LV. You will get broad RBBB. That anyways you will see on the LO view also. It will perforate and it will jump across to the lateral wall, LV lateral wall.
So if the thickness is adequate, we should
Yes sir, we have gone inside some 20 millimeters also. In HCM patients we have gone inside that much also. What to tell? There is nothing else. This we already discussed. Interpeak interval. There is no doubts about interpeak interval, right? So this is little advanced concept only, but we'll discuss. You will implant ICDs also, right? So in a dual chamber, for example, if a patient has a LV dysfunction, you want to do left bundle pacing because that can achieve also narrow QRS, right? LBBB wide QRS. We already discussed his bundle can also correct left bundle branch block, and left bundle pacing can definitely correct LBBB. But that patient already also has had a history of VT. Now the patient needs an ICD also. Now the patient needs a resynchronization also. How will you do a dual chamber ICD in that case with a left bundle area pacing? How will you do? How many leads do you want?
first तो इसी से पता चला दो ही में हो जाएगा.
नहीं तो कुछ ये दूसरा ऐसा डुअल चेंबर पेसमेकर है.
3 होना चाहिए नहीं.
3 मतलब first lead will be in
Left bundle.
first one lead is in left bundle, then ICD RV apex, then third RA. So we checked with the PSA, unipolar we checked, QR very narrow QRS, but then you are asking the tech person to give you a device. What device you will ask for? Why? We planned dual chamber ICD. Now we told the patient also, I'll give you a dual chamber ICD only. I'll not ask more for you. You can pay only 5 lakhs. I'll give you a dual chamber ICD. Then what will you do? Yes sir. Tell me sir.
You have the pacing part of the ICD lead.
So what kind of an ICD lead it has to be? So current ICD leads are single coil. So there will be a single coil. This is a single coil ICD. The ICD lead will come out and there will be one pin. Why? Which one will have two? Current ICD leads, when you do a single chamber ICD, for example, any single chamber ICD when you do, you connect only one pin to the PG, right? Where is the other pin? Normally we would have all done a single chamber ICD, right? So only one pin comes out and we connect it to the PG. SVC anyways is always capped. There is all are single coil PGs only. So how do we, and this is the single chamber ICD lead. The other lead is atrial lead, okay? So I have a PG dual chamber ICD I told, no sir. Only 2 ports I have. I'll connect one to the atrium and I need defibrillator anyways. So I'll connect it to this. What about the left bundle? There is left bundle also you have placed, no sir. You have 3 leads. So have you ever heard about DF1, DF4? DF4 has, this is DF4 sir. This is DF4. You cannot use DF4. You can, I'll tell you later. So if it is a DF4, if it is a DF4 lead and there is a left bundle lead also and there is an atrial lead also, what kind of device you will use? Someone was saying in the beginning. CRT. What kind of CRT it will be? No sir, device. Normally CRTD devices they will give you, right? CRTD devices they will give you, right? What do? You put a quadrupole lead at the CS. You put a RV apex and atrial lead, correct? What happened? So one in the atrial lead. So 3 leads come out. One, this is coil lead. My PG has 3 ports, done. But this is a quadrupole lead, right, sir? So quadrupole lead port kaisa dikhta hai, sir? It will be having 4 slots. So your left bundle lead will not go inside this. But you said for this patient you will take a generator. What generator? CRDD generator. How will this left bundle go inside this? My left bundle is bipole only, na, sir? A tip and ring. It is not quadrupole. So how will it go inside this port? It will not go. So you will have to specifically ask for a bipolar CRDD. So bipolar CRDD is one way where you can use a DF4 lead and still get 3 leads. But you have promised the patient, I will give you a dual chamber ICD. For that, there is a different lead. Normally, previously, we used to use, what is the function of a defibrillator lead? Is to treat a VT. How will it treat a VT? It will have to first sense the VT. Then it will try an ATP. And then if it is unsuccessful, it will give a shock. So what are the functions of a defibrillator lead? It has a shocking function. It has a pacing and sensing function. So previous leads used to have both components separate, and what used to come out at the other end was 2 different parts. One shock, one pace sense. And this was called DF1. The previous lead which we saw was a DF4. So you can see the example here in this picture itself. So this lead, which is the defibrillator lead, has 2 outlets. One is the pace sense, one is the shock. The shock has gone to the shock. The PG is also DF1 PG. DF1 PG means it will have sockets separate for pace sense and shocking function of the defibrillator lead. The generator will think I am getting both components from the same lead, but you have to fool it. You will cap the pace sense of the defibrillator lead and you will direct the left bundle lead to the pace sense. You can see RV sense pace. And this is a dual chamber ICD. This is how you use the ICD lead with conduction system pacing. Little complex concept, but the tech will help you with that. Sir, any other doubts? You tell me. First patient ECG. The first patient ECG, right? Okay. How should I'll pass it on or what? There was a QR, right, in the first patient ECG? Okay. So this is the first patient's ECG. So the first patient, whenever you see an ECG, you should think whether there is an intrinsic contribution or not. How will you know whether there is an intrinsic contribution or not? The pre-ECG was CHB, right, sir? So there is there cannot be a component of intrinsic conduction. So this is all pure paced beats. Sir? हाँ, that is also true. सही बोला. मैं अभी क्या करूँ? No problem. 1% है, पर हो जाएगा. हो जाएगा सर. नया है ये इसलिए. So, someone may say this is not pacing. Patient का अपना conduction है, P, QRS. We are just incidentally pacing at the same time. Correct? But we know from pre-procedure ECG that the patient did not have intrinsic AV conduction at all. It was CHB. So this is all pacing. Now, what is the morphology? There is a small QR. It will not come. So there is a small Q and R is coming up, but it is not there fully. What is the axis? Precaudal transition kahan pe ho raha hai? It is at V3. And what is the location on the septum? It is mid septum. It is anterior, mid or inferior. It's like mid. Because 2 is positive, 3 is negative. Correct? You remember the diagram which we made. If it is more anterior, 2 and 3 both will be positive. This is 3 is negative. 2 positive, 3 negative, AVL positive, AVR negative. Okay, so this is a good enough location. Maybe if we had gone a little more inside, we would have got more R. But it is not always possible, particularly in structurally abnormal hearts. So this is, and how will you calculate LVAT? From the pacing spike to the peak of R. Can we calculate LVAT in this case? Definitely, because R is more. We are at a proximal location. What is the LVAT? It is around 60, 70. Okay. That 60, 70 can be because the patient was very small. We actually measured the LVAT on table also, right? We measured 78. Okay, sir. So that was a more accurate measurement. And what is the interpeak interval? We may not be able to calculate because the R is not so prominent. But if you were to consider this as the R, the thing which is coming up as R, what is the spike to that interval? 40, 80, maybe 100, 110, right? Not 120 also. 110 minus 78. Don't, that is an unrealistic thing, 60, 70, 78. So 110 minus 78 is like 32, 32, 33. We can, so from that criteria it comes left bundle location only. And did we see a change in morphology there at that time? It was there. We had seen there was, or may not be there, but it is a left bundle area pacing by which criteria? By shorter LVAT criteria. Now, whatever those criteria, those numbers less than 80 we were seeing, that was for an adult patient. This is a pediatric patient, may not apply. So if there were to be smaller cutoffs for younger patients, pediatric patients, so this may still fall into LV septal pacing, because overall does not look as narrow as mine or yours ECG, right? But there is still some delta in lead 2, 3, but it's still a narrow ECG only, if you consider. So for all practical purposes, this is a left bundle branch area pacing, may or may not be conduction system capture. But if it's an adult patient, you will say it's conduction system capture, because LVAT is less than 80 and interpeak interval is definitely more than 30. If we actually take our measurement, 60 to 70 we told, it will be more than 40 only, correct? So that is how we see. The other ECG is there. Only one ECG has been done. Okay, okay.
So left bundle branch area and LV septal are two similar terms?
Left bundle area pacing includes any structure after we cross the mid of the septum. If we reach anywhere in this area, it's left bundle area pacing, provided it is proximal also. Distal also we can go. I have a diagram also. I'll show whether it's there or not. Keep. It's not in this. This is all this is left bundle area pacing. So left bundle branch pacing, left fascicular pacing and LV septal pacing, because everything is on the left side of the septum. We saw also this, right? This is left bundle area pacing, left bundle branch pacing, left fascicular pacing and LV septal pacing. So what is left bundle area pacing? Only QR, sir. Only left bundle branch block in complete right bundle branch block. So that is left bundle branch area pacing. And may not always be conduction system pacing. It is outside the CSP cloud. So this is little.
start. Case 3. This is a Mr. Sampath Kumar, 55-year-old male. Just tell him he started presenting. This is case 3. Sampath Kumar, 55-year-old male, working as an engineering college professor. He was recently diagnosed to have corrected transposition of great arteries with intact interventricular septum and moderate tricuspid valve regurgitation, left AV valve regurgitation with intermediate AV nodal block. He had one episode of pre-syncope and one episode of frank syncope associated with fall. On examination, patient is well built, weight is 80 kgs, pulse rate is 50 beats per minute, no specific character, blood pressure is 120/70. Systemic examination, there is a pansystolic murmur at the apex. This one. This is a chest X-ray. The cardiothoracic ratio is around 55% and there is a L post aorta. This is an ECG, it's 12 lead ECG of the patient. You can see there is a high degree AV block with a very prolonged PR interval. So PR interval is around 400 milliseconds. We did the 24-hour Holter ECG. The average heart rate was 51 beats per minute. The minimum heart rate was 36. There was baseline sinus tachycardia with first degree AV block with a PR interval of 340 milliseconds and bradycardia of 65%. And there are few intermittent episodes of second degree AV block and few episodes of 2:1 AV block. And there are few episodes of AV dissociation and complete heart block. There are few PACs and VPCs noted and the longest RR interval is 1.8 seconds. This is a 2D echocardiogram showing typical CTGA. The ventricular function looks preserved here and there is moderate left AV valve regurgitation. So, is blood investigations. HB is 13.2, urea is 27, creatinine is 0.74, NT-proBNP is 132, indicating again preserved ventricular function. LFTs and lipid profile is normal. So, plan will be permanent pacemaker implantation or conduction system pacing.
Hello, sir. Pramod, sir. It is Pramod, sir, only, no? Hello.
Aditya, can you hear me?
I can hear you.
Okay. So
Sir,
basically, this gentleman with corrected transposition, like a few days before, had a syncopal episode and dropped down on the streets. He has high-grade AV block. So he is being planned for a pacemaker implantation. You are seeing the ECG and hemodynamic. Are you able to see it? Anindya?
One second.
A little up.
So we are able to see the hemodynamic screen. We are also able to see the 12 lead on the 2D system.
Okay, Pramod has already done some preliminary work. The LV systolic pressure is around 40 millimeters of mercury. Show that LV angiogram. It's an intact ventricular septum, not operated so far. This is the venogram. So this is the LV projection, LV angiogram. We can appreciate that in LV projection, the pulmonary valve is seen. If I put a horizontal line from the level of the highest chest electrode, I need to be above that. So the highest chest electrode on LAO view. Show the RAO view. So this is in an RAO view. The left-sided electrode is abutting the mitral annulus. So I should be anterior to that. And then AP view. In AP view, we are seeing V1 and V2 and maybe V3 also. So we are somewhere overlying V2 should be V2 or in and around that area. V2 or little above that V2 should be our. So now what we are doing is my camera also on?
Yes, sir, it's on. But you are not focused on the incision site. 1 second, sir.
It's focused or no?
1 second, sir. It is focused, sir.
Okay. So I am just keeping it and I am looking at my fluoroscopy. So there is a coronary wire there. So I'm getting.
He became too loud now. So we decrease. Nothing is going. Restart.
So now I'm get the maximum illumination here, Dhananjay.
Just light.
Maximum light. Temporarily we can keep the patient. Okay, yeah, that's good. For Alice forceps. Get me a couple of artery forceps. Is it the first time for you? You are a routine pacemaker person? Okay, thank you. Curved forceps. Okay. Alice forceps I asked. Alice forceps and a curved scissor.
The right side.
Yeah, and a curved scissor. So now I am getting the. Yeah, no problem.
Give another one. Keep it.
So as I am cutting, I am making the Alice forceps go deeper and deeper. I'm come closer to the clavipectoral fascia. So I'll clean that area better. Pramod, can I come? Light a little bit more so that I'm going just above the plane of the pectoralis major. Get me one Langenberg retractor, small Langenberg retractor. Small.
Smaller one.
Okay. Yeah, it's okay, both are same. Okay, now, so I'm lifting the Langenberg and I'm going in the plane Are you able to see what I am able to see in the inside? Anindya? Anindya?
Hand is coming in between.
My hand is coming in between.
Yes, yes.
Yeah, sorry. Okay, now I will lift it and show you.
One
Can you
second,
see
sir.
now?
I will zoom it up a little bit, sir. One second. What is happening? Enable zoom.
So I will show you.
We are
Yeah.
we are able to see, sir. No, you
So
just
now I have created a pocket here. Again,
a little to the left, sir. Zoom out. Huh?
I'll try. I'll make you feel it with my finger movement. So this is the pocket on the superior aspect. I will now make a little, I mean on the inferior aspect. Now I'll make it little bit on the superior aspect also. So it looks okay to me. To avoid the tissue tension and all, I'll cut some of these areas.
We can see it now, sir, clearly.
So not much of bleeding. Actually, this was not a patient on any pharmacological antiplatelet agents. So it's a clean plane. So now this pectoral muscle, pectoralis major muscle, and I have a reasonable. So now what we are going to do is derma. Yeah, we are now going for the subclavian vein puncture. So it's going in the other direction. Okay. So one artery forceps. Get me one more puncture needle.
Wire, please.
So I'm going for the second puncture.
Yeah, it is. And the seat change with the select. Change with select.
Track. Okay. 7 dilator. 7 dilator. Give me 7 dilator. Not this bus. Ask for orange dilator. So I'm just dilating. Get me a 7 dilator. Okay, just get the dilator alone out and give me. We try to dilate the track so that the sheath will go easily. Wet gauze.
Wet gauze, please.
Is there another wire that is here? Show the heart. See this, the CS catheter has already taken a loop into the CS wire has taken a loop into the left ventricle. Can you appreciate that? Arindya, you are around?
That's it. It has taken a loop in ventricle and again come out.
Yeah. So I will. It's come out.
Come out, come out.
Not yet, sir.
So we'll take it without the dilator. Directly try to. Can you? I am now trying to take the wire out from the left ventricle
Yes, it came
and
back,
see
sir.
if
Yes.
and see if I can advance it towards the outflow tract. Unlike the previous patient, this is a unobstructed outflow tract.
So can you show the participants what movements you are doing at the hand to free it for the septum? Maybe a clockwise
Okay.
turn.
See, basically, I'm trying to see the interventricular septum. We are facing the interventricular septum. I am trying to get the J termo just to flip superiorly. Can we get a catheter, a right coronary catheter?
Sir, you can try turning the catheter clockwise so that it will disengage and then the wire may go up to the RVOT. Little clock, sir, and then it will disengage from the septum. The mouth will look up, sir. Then, yes. Now you push the wire. Yes, it will go, sir. You pull the wire in the sheath, sir, again, and then you try. Okay, it's not going. Yes.
When I push a little bit more out,
sir,
the catheter tries to, see now, it has to go straight up in the outflow tract.
Yes, sir. Sir, you maintain the clock of the catheter, sir. Then it will look up only.
I'm actually giving a lot of clockwise.
Okay, sir.
I'll try with a catheter across.
Okay, sir.
That's it. Ishita, can you give a small flush of that catheter? Just keep it closer, otherwise it'll bounce around. Flush. Yeah. It's okay. Keep flushing. Yeah. Yeah. Has it come out? Now. Not at come. Tell me when you got it. Now?
It's here. Actually, the catheter is here.
You don't still have.
I have, sir. I have.
Just hold it, keep it straight. So now the here.
In the PA. It's already it's in the PA.
We'll try to pull out the loop and see whether the length is the problem. I'm trying to reduce the loop. Restore this.
So it reached the
So now-
RVOT, sir?
Yeah, it has reached the LVOT.
Oh, sorry, LVOT, yes.
So show me the syringe with contrast. A syringe with contrast.
This is not required now, no?
Yeah, put a finger.
This pen over one.
So now it is in an AP projection. This is where we are now. So now we will try to get the lead out, lead inside, and then keep working on it. That's contrast. Flush. Okay. Get the lead.
Sir, we are at a subpulmonary location, right, sir? The,
Yeah.
this.
Yeah, we are just below the pulmonary artery.
Yes, sir.
I just need to come to. Hold it.
Sir, the healthy his bundle and left bundle will be at the anterior margin of the pulmonary valve annulus, right, sir?
Correct.
Not,
correct.
So this is posterior. So it may be that AV node there is.
We are we have to now the target will be towards the leftward side of the pulmonary outflow tract.
Yes, sir.
So red fluoro, not low fluoro and all.
What should I do? How can I start pointer?
Okay. So now I'm trying to make some manipulation. Okay. I'm giving a clockwise rotation and slowly trying to come out because I want to touch the.
This area.
Okay. Okay. So now, can we again see all the pictures now? Show the AP projection. So this is the AP angiogram. In the AP angiogram, there is a V1, there is a V2. Our target is on the V2, right?
Yes, sir.
Run that picture. Run the picture. Yeah, our target is on the V2.
Yes.
Now, so now I am on A. So it's just above. I will, as I push the lead, I will try to come out a little bit.
Yes, sir. You are coming there.
Yeah. So now come to RAO view. RAO view there. You can also go to RAO. Show the RAO view.
Biggest pictorial angiogram.
Pictorial angiogram RAO. Show that RAO. So in the RAO angiogram, so now we are in RAO 30.
Yes, sir.
RAO 30. So in RAO 30, the first, okay, that first electrode that we are seeing is on the mitral annulus. So I am anterior to the mitral annulus. Show that RAO 30 again. See this RAO 30, I have
This side.
that electrode is actually mitral. Now my current position is a little anterior, so that position is okay.
Correct, sir.
Now come to LAO. LAO. Show the LAO angiogram. So in LAO angiogram, this electrode, I have to have it on the left side of that electrode. So now I am a little above. I'm a little above. Show that LAO angiogram once again. Are you in the same LAO projection? Okay. So show that LAO angiogram once again. Yeah. Okay. Get a similar orientation. I want to see that 1, 2, 3, 4, that similar picture. Correct. Super. Super. Okay. Now, like store the picture of that. Store the picture. Okay. Transfer. Okay. Now I am a little above, almost at the level of pulmonary annulus. As I am coming out in the same LAO, I will come out. Okay. Now, Prabodh, can you hold it? I'm just removing one glove to make it dry. I will give a couple of screws and then try to. It's facing the other direction. Okay. I'll try to.
There are some PVCs in LVV morphology, 2 positive, 3 less positive.
Fix it, Prabodh.
Yeah. Transition is at V4 meter. And there is an apical PVC also that is from 338 that you should not look at. The other one.
Okay. Can we check the electrogram? There is. So now I am connecting the black to the ring. Are you up? Red to indifferent. Are you getting R wave? Okay. Okay. Lot of VPCs are coming. Okay, now you are pacing, right? Okay, pacing.
So we have 2 positive, 3 negative, AVL positive, AVR negative. There is a notched QS in V1 and the transition is at V3, V4 only. This is a good location, sir.
Appropriate? It's sensing. Okay. Now we are seeing stable ECG. Injury is good.
Yes, sir.
Lot of ectopics are coming, right?
Yes, sir.
So that is from the RV apex, LV apex ectopy. So maybe the TPI is there. This is good, sir.
Can you go that side? So the TPI lead now. Ishita, can you slightly pull out the TPI lead? Okay, come to AP. Let's see the orientation of this. He says that H2 are negative. Slightly pull. Your hands. Slightly pull. Yeah. Series of
Yes.
Can you show me your models? Is this itself like PC? Show the AP angiogram once again.
So the current position you are in, the page morphology is actually like a parahesian.
Take the filter out. It's not it's not of it looks like it's scraping the. So what I will do is I will withdraw it now. I will hope to do that.
Sure.
It like some basic so taking it out. Like this.
This is the morphology of the page.
Get me a spectrogram. Now I'm connecting you to VP. Keep again. Looks okay to me. What the level? Now keep checking, bus. Yeah, keep checking and keep telling. 11, 30. Audio 30.
Fluoro? Okay. Sir,
Tell me what
hello sir.
in terms of chasing, racing and okay. This is Russia. Okay. So let's just see this here also. It looks like what is the pacing at 5? Pacing at 5. Keep reducing.
He's not able to listen.
It's pacing at 4. Pacing at 3. Pacing at 2. Pacing at 1.5.
So this is total branch area.
Pacing at 1.3.
Where he has gone, he has just grazed the surface of
Pacing
the
at 1.2.
LV morphology LV septum. Still the QRS is narrow. Can you see? This is 75 speed. If I make it 25, it will be like RECG only. And he didn't have to go at all inside. It was not intentional. Whatever he tried, it went, and it is actually grazing the surface of the RV septum. RV septum means LV.
This is the ring electrode. We have already exposed the ring electrode. Ring electrode 680 impedance. Slowly come. No, it's not basic.
Please.
Go to Go itself.
It's a middle.
Because it is oblique, the ring is also capturing the same area only. Sometimes it's capturing, see, same axis only, mostly the same axis, but it is little down. So that's why R is coming up late in precaudal leads. The tip was good. This is a ring. Why is it not coming?
My mic, my audio, I'm not hearing anything.
By mistake, we disconnected it now. That is the problem.
A2.
Visor is not here. He told.
E2 voltage capturing.
Ring capturing. Okay. Keep coming down slowly from 8. Slowly come down. Slowly come down, not like so fast. Okay.
Disconnect.
Give 3 beats for each.
He's calling me. Sir, can you hear me? Huh? Sir, can you hear me?
Yeah, now I can hear you.
Sir, it's like our lead has grazed the right side of the septum, and that's where the left bundle is, sir. So that's why the QRS is so narrow. We have done a left bundle pacing only, and because the left bundle is on the right side, so the morphology will be like a normal morphology, like a LBBB, incomplete LBBB morphology.
Okay. So what is your suggestion?
This is perfect, sir. That is perfect.
No.
Sir, if you show the tip morphology pacing, and if you see it in 25 speed.
Okay. So tip I will show you.
Yes, sir. It's not required.
I'm showing the tip now. Tip, check the impedance. 1080 impedance tip.
And if they can make it 25 speed?
25 speed.
So that is the QRS. It's absolutely narrow as the previous two cases. It will not give you a QR, sir, incomplete RBBB, because the left bundle is on the right side. Still the target is...
Yeah, keep checking the ring electrode unipolar threshold, then I will give you bipolar.
Okay, sir.
Yeah. 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 Now at 1.4. 1.2 now. Okay, I'm going bipolar. Huh? Okay, I'm giving bipolar now.
Yes, sir.
Yeah, bipolar.
Bipolar is even narrower, sir. It's very good. Gokul, can you make it full screen, the live screen? Yes, make it full screen.
What output now? Okay. Okay. Saturation is not okay. Now at 1.6 bipolar. .2 getting lost. Okay. Now check injury is quite good. We have sedated the patient deeply. Huh? Good injury. Okay, go back to about 1.5 and show that it's consistently pacing. I'll do one septogram here. Go to epicranial. Keep another contrast syringe ready. Okay, come to AP plane. It's obliquely, it has traversed the septum. Okay, keep RAO. RAO 30. LAO, you are still pacing at 1.5. Okay. So the place where we are entering is adjacent to the electrode. So the ring electrode is closer to the place where we want it to puncture, but the lead is going sort of oblique. So somewhere in a oblique plane it's going. But yeah, here again, for me the ECG looks reasonably narrow. So
Sir,
now come down from one
sir,
point.
that the point where you wanted to enter is probably location of the left bundle, sir. So
Okay.
the ring is at the left bundle, but the tip
But it's
may
not capturing.
So
The ring is not capturing decently.
so it doesn't matter, sir. But the tip has gone up. Maybe it is near the his bundle. And
Okay.
that's why it is still narrow, sir.
What is the output? 1.4 now. 1.2 now. 1 now. Okay, 0.9 it's getting lost. Okay, go back to 1 or 1.1. Slitter. I'll give it. What output you are facing now? 1.2. Lot of ectopics are coming. Okay. Okay, Prabha. Space. Let this the problem.
Update the live screen. Sir, sir, can I interrupt you?
Yep. Yeah.
Sir, we told that we will not show you the EGMs, but there is a local potential at your the site where you are.
Okay.
A conduction system potential we just saw. So
Okay.
Go off pacing, please. Hello, sir. Gain up CSP. Gain up CSP. Gain up CS unfiltered. Can you see in the unfiltered, sir, there is a sharp potential before the, and there is a sharp potential before the local EGM also.
Okay. No. Again. I came out. Okay. Let me see. Too big a loop. Too big a loop, right? Yeah, okay. there was a problem with I came out in the middle of the slitter and then adjusted it.
Some other view.
I got a more of a, let me see. Anindya,
Sir. Hello, sir.
I'm going to accept this loop. This loop, what is happening is, it is going into the LV apex and turning back and gaining into that place where pacing. Maybe this loop in the apex will probably help it retain there rather than getting pulled out.
Right, sir. Right, sir. It's okay.
You see the corresponding. I don't know whether you are seeing the next image, the same corresponding LAO. Are you seeing the same picture?
Sir, I am seeing the RAO view, sir. This is the RAO view we are watching. RAO or AP. Actually,
No,
this
no,
is an AP view.
This is AP now. Okay, now I'm showing you RAO. See what I'm, okay.
I got your
See,
point.
this is RAO. The lead is getting anchored in the LV apex and then turning up and entering.
Got it, sir. That is providing stability, yes. Sir.
Yeah, maybe giving stability. Okay, what is the output now? 1.2. Okay.
So LAO once.
LAO once. So this is LAO. It's basically getting anchored in the LV apex. When I'm trying to pull out, it's not getting unentangled. But looking at the good thresholds and looking at reasonably narrow KRS, I feel it's fine. So we will take out this peel away sheath. Come to AP. Show the light here. Light here, please. Sometimes what will happen is when you are pulling out the pacing lead, temporary pacing lead, it might flip out. See,
Now it's you can see that.
can you, Ishita, can you go and take out the temporary pacing lead? Give me a thumb forceps.
One retractor.
Get a suture. Yeah. Now. Yeah. Can you pull out? Yeah.
Okay.
Yeah. Keep on pulling out. Yeah. Keep on pulling out. Yeah. Okay, Flora, store this. Okay, Pramod. So it's going in that direction, towards that. Okay, suture. Which is not okay?
Right.
Can be, if possible, better.
Yeah.
Take that out.
It's above the lid.
leave it to Pramod.
Give an force estimate. Articles. Sorry, sir.
Or else I will come this way.
Are you still facing?
Check the output now.
Facing to 0.9, 0.8, 0.7, 0.6, 0.5, 0.3.
Okay, Aparna says it is fine. 3 loss of capture. It looks okay. Okay. 7 dilator. Yeah. Let us see some muscle injury. Atrial lead.
J.
J bus.
J.
RAO bus. Okay, I'll screw it and then you can check it. Come, get me the. Out. Back down. So without mag, is there a P wave? P wave? Ah. Pacing P wave at 100. Ah. Two atria. No, I'm telling them. 1.9 atria. Yeah, and the lead 3 I'm seeing P. Lead 2 also. 1.8 P wave. P output. 1.7. 1.6. 1.5. 1.4. 1.3. 1.2. 1 volt. Okay, 1.2, go back. Okay, 1.2, I'm seeing P wave. Let me see the lead stability. I'm withdrawing the J. Yeah, looks okay. Okay, now can hold it a little bit. Thumb forceps. Come to AP, this is AP. Okay, no? Table up, there is IA up. Suture. Okay. Tejasvi, did you see the? Okay, okay. Anindya, that the previous patient's pacing, did you see it or 12 lead ECG? Anindya?
Sir, hello, sir.
No, the previous patient's 12 lead ECG.
Sir, it is absolutely great. Sir, it is deeply penetrated and it has reached the RV, right, morphologic RV aspect of the septum.
It was looking narrow?
Absolutely narrow. If you are telling the QRS duration, it's less than 1, it is 1, 2, it is 110 milliseconds, sir.
Okay, okay. Because I had scrubbed in by the time that was taken, so I didn't see.
So I'll get it sent to you, sir. You can see it
No,
now.
no, I'll come there. Actually, see what we are going to do now is.
You ask me.
Is there any gauze piece that we have kept inside? Okay, they do give a gauze piece, antibiotic soaked gauze piece. We'll just clean that area. Open the generator. Put it on DDD pacing now. I'm not seeing P waves. What output of? I'm not seeing A. There may not be a proper P wave at all here because this man is deeply sedated. Let's check whether the lead. Oh, atrial lead has gone off. Okay, get me the atrial J stilet is still there. I'll do that. Blade. Show light to Pramod. Just one single stitch. Screw bus. Please. Pace the ventricle and it's connected. It's come out. Huh? See whether the atrial lead has gone inside. Fully in.
It is fallen again, no?
Yeah, atrial lead fell out. I am reintroducing the J. Antibiotic cost is going to screw man. Zoom. Out. Anindya, that atrial lead got displaced.
Yes, sir, I saw, sir.
So we have rescrewed in another position. So again, we are back to rechecking.
Yes, sir. Now there is a good injury, sir. ST elevation is there. You can see a blue line on your screen, the blue channel, the second channel. It is fixed really good.
on the
RA unfiltered.
atrial, right?
Yes. Okay. This is ST elevation.
Yeah.
Yes.
Atrial impedance 650.
Capturing, sir.
Is it looking? Okay. Okay. The atrial appendage movement looks good, but I don't know why it went up. Okay. 1.6. 1.4. 1.2.
Capturing. Loss.
1 volt I'm not seeing.
Loss.
Okay, go to 1.2 again.
Capturing.
1 point, definitely capturing, no?
Now it's now it's loss. Now capturing again.
Leave it at 1.5. I'll pull out the stillet and see.
Sir, it will be
1.5?
okay, sir. There is there is local injury, sir, so there will not be an issue. It is okay.
Sort of same. Huh? More? What is that?
No, I think we'll pull it a bit more. Like probably that J was giving the partial J was giving some problem. I think it was making it angulate.
Okay. Now you are capturing the atria?
Yes, sir. It is capturing, sir.
Yeah. Yeah. Okay. Okay, that's fine. We'll accept it. They put on it's now DDD, right? Ventricular output is like 1. How much is the ventricular output? 1. So it's capturing at 1. Okay.
Artiforceps and suture. You repack them to me.
Catch it. Continue. Generator bus? There is one antibiotic soaked. Atrial lead I have disconnected. Okay.
One take on. Yes. Okay.
A ventricle I am disconnecting. There is no temporary pacing also. What is your lower rate? It's A pace, V pace? What are those in between 1-1 spikes that are coming? No, the temporary, just to switch it off. I don't know whether the temporary is pulled out. Now there is no. It would not have been sensing, so it was giving a spike. Okay. Show me one. So, Anindya,
Yes, sir.
what components now you have to discuss? I will, since actually Pramod scrubbed with me, Pramod will do the remaining. I will come there to the hall because I couldn't. Pramod, can you take it? Yeah. So, just one fluoroscopy of EAP. IA down. We can take one cine from this end to.
Please show it from the apex.
Apex onwards. Sure. Yeah. Apex onwards, keep seeing. Keep going up.
Nice, sir.
Yeah. Okay. Ishita, can you slowly take out that PTCA like wire there? Probably I'll
Sir,
just go.
sir, Aparna will show you something and then we can show it to the audience also.
Aparna will show something, he says.
So this was the potential. This was the potential for
Okay. That is from the tip electrode or ring electrode?
tip electrode.
Okay.
So this is the near field electrogram.
Okay.
This is the Higgs-bound potential and this is the line.
You want to, you can push it up and then show so that because it's in the lower end of the screen. You'll take care, Pramod. Thanks, Pramod. Boss, thanks. Okay. Anindya, our Aparna is showing.
Yes, sir, that potential is there.
Yeah.
So it could be a fascicular bundle potential only at that site.
Okay,
Sir, we expected
okay.
this because you don't need to go deep in the septum for a CCTG, sir, to get a left bundle signal or a capture. So
Thanks, Anindya. I'm coming there. I'm,
yes, sir,
I'm
yes,
just
sir,
reaching there.
Yes, yes. What should I do? Zoom in, no? Okay, sir. So zoom Pramod sir will go offline.
Anindya sir is asking if they can go offline. No, please. Yes, sir, we can go offline.
Okay.
in some of the other patients, we have done a sort of CRT. I'll tell you why I am talking as a sort of CRT. Originally, when a corrected transposition presents to us, few years before, we used to put in an LV apical pacing. So there will be an LV apical pacing lead and there will be progressive right ventricular dysfunction. So when we want to convert them into a CRT, conventionally, we will go through the coronary sinus, get into the right ventricular obtuse margin, and somewhere have to park it. The incidence of absence of a proper coronary sinus in corrected transposition is like 20% or so. The reason is, we all know that there is something like a dual node. The posterior node, which is in relation to the triangle of Koch and all, is often dormant, whereas there will be an anterior node at the base of the right atrial appendage, which will course anterior to the left ventricular outflow tract and descend down in the septum. Exactly corresponding to that same area, on the base of the right atrial appendage, there will be a large Thebesian vein in many patients with corrected transposition. That Thebesian vein will directly drain the anterior intraventricular vein. I'll just show in a normal person, the anterior intraventricular vein will course. The moment it reaches the LV to LV outflow region, it will make a turn and it will turn into the great cardiac vein. And the great cardiac vein then continues as the coronary sinus. So the anterior intraventricular vein, great cardiac vein, coronary sinus. Whereas in corrected transposition, in a good number of patients, this anterior intraventricular vein will directly drain into the base of the right atrial appendage as a large Thebesian vein. And in those patients, there will be something like a diagonal, imagine like a diagonal, something like a diagonal vein, which will course along the left AV groove for a substantial distance, and it will give multiple branches to the RV free wall. So this anterior, an equivalent of anterior coronary sinus. In such patients, when, this is coronary artery, this is coronary artery. Okay, so there will be some patients in which you will find there is an anterior, there you see, sort of. So it will be like this. So in such patients, you may have to put in the CS lead through such a way. So like that in that cartoon, see now that picture is good. See, basically it will be difficult for us because coronary sinus means we know where it is. It is very posterior. So you put in a catheter in the right atrium, deflect it counterclockwise so that it faces very posteriorly, and try to get it into the coronary sinus. In fact, today a couple of times our catheter, when we were trying to poke from RA to LB, was entering into the coronary sinus. But this anterior Thebesian vein is difficult because you don't have a landmark, you don't have a target, you don't know where. It's at the base of the right atrial appendage. So very often in such cases, what we do is we position one catheter as a guide. So this is a right coronary artery catheter that goes deep inside and serves as a guide for us. And then you advance. See now, so this is the whole of the pathway. The whole of the pathway. Then using that, then you try to come down. So use that guide. So that's an ambulance AL2 catheter that pokes in that area. Then advance a coronary guide wire and then get it. See, this was also a deflectable, some sort of decapolar catheter, and then try to push in a sheath. Yeah, you see, lot of. So this is getting the sheath inside. In fact, this has been described by Boston Children's Hospital also, by this Edward Walsh group and all. They have described that in about 15 to 20% of their coronary sinus CRTs, This coronary sinus is not the posterior coronary sinus, but the anterior coronary sinus. So there are some technical challenges in this. One more thing about corrected transposition is, corrected transposition is not like simple cardiomyopathy. Actually, Anindya was mentioning a left bundle branch block is not a simple left bundle branch block. See, he was mentioning some 44-46% will be proximal, and then there will be quite a good number of them which are distal disease, which are like myocardial disease, and so in such patients nothing is going to work. Similarly, cardiac resynchronization as a therapy in corrected transposition is only a belief that only electrical dysynchrony is the cause of RV dysfunction. There are 100 causes of RV dysfunction. RV morphologically is different. RV geometrically is different. RV coronary supply is different. Everything is different for that RV, that RV cannot become an LV. So putting electrical dysynchrony as one reason for entire right ventricular dysfunction in corrected transposition is like very underestimating and like putting a lot of money onto one basket. So there are plenty of reasons. Very often it's a combination of altered geometry which leads to tricuspid valve regurgitation, and the tricuspid valve regurgitation with the volume overload adds to the insult. Right coronary artery, all said and done, a single coronary artery is not all that efficient in supplying an adequate coronary perfusion. So there is coronary flow reserve of the right ventricle, RCA is going to be poor. So multitudes of reasons. Etymologically, RV was not supposed to be a systemic ventricle. So the myoform fibers and the myofibril orientation of a right ventricle is not meant for a systemic circulation. So in every way, RV has to fail. But electrical, addressing the electrical aspects is one aspect of it. So this is about corrected transposition. Incidentally, we had 2 corrected transpositions, so we were trying to get them together. So to conclude, I thank whoever are remaining. Actually, all of you are like my own friends only. So it's a pleasure to see you all, and hope you did not get discouraged by the long time that I took on the second case and feel that this is a waste procedure. I think it is useful, possibly. Long term will tell whether keeping the QRS narrow is going to be providing a more number of patients without any ventricular dysfunction in future. Only time will tell. We have to wait and watch. And I probably thank Anindya and Ullas for they were more enthusiastic in pushing this program than us, because we felt it is like, for example, when a child is young at home, when the child starts to walk for the first time at say 1 year of age, the grandfather, grandmother, the father and mother will be very happy to see the child walking with like that different steps. But for a person who is somewhere else, it's all what is there, every child will walk like this only. So when we are doing without any electrophysiological electrograms, we are purely basing only on anatomical inputs. In fact, probably today was the first day I had V5, V6 and all. I never had all these things. I will do only with one V1. And also when it is structurally abnormal heart, I don't bother about V1 also. It totally becomes anatomy. So, I mean, but when intelligent people are around, it is good to like pick their brain and get more inputs. So that way. Otherwise, the way in which we approach is completely anatomy driven approach. It's not at all electrical driven approach. It's not electrophysiological approach. Whereas truly such spacing should be done by people like them who are very, very highly knowledgeable about electrophysiology. Just this is an attempt to demystify, because some of the hardcore electrophysiologists may not be interested in complex congenitals. They'll be feeling bored about it because it's too much of unnecessary winding around the heart. So some of them may not be interested also. So probably you will find a group of electrophysiologists who will be concentrating more on AF ablations, myocardial infarction, VT ablations, and less interested in this funny, useless stuff like Fontan ablations, or because these are all very time consuming. They will be very of course, Anindya and Ullas are exceptions. They are interested in everything that is electrophysiology. But I'm talking about general crowd. It's like some of the general cardiologists may not be interested in structural intervention. They'll be very much passionate towards coronary, not very much interested about doing structural. So like that, electrophysiologists also, some of them will not be interested. Fortunate that we have a group of people who are extremely motivated and highly interested, but we just wanted to go by an anatomy-driven approach in our department. So to show the utility of such a program. Probably this would not have been possible without their support. In fact, they were proactively telling us, demonstrate this anatomy-driven approach. So it was a good attempt. Upgraded to a left bundle pacing, no? Yeah, I think we should try to attempt to upgrade it. If you are having that vein patent and that vein can accommodate one additional lead, it is a good idea. Having said that, let me be honest with you. We have not had an occasion where in a small child we have done that. We have done that on some 3 corrected previous congenital heart disease who are having pacing, who are adults. And one hypertrophic cardiomyopathy who was having a ICD, classical ICD. When he was developing a pacing induced electrical dysfunction, we put in an additional conduction system like a left bundle lead. But not in a small child where we ourselves have put in a conventional RV apical lead, developing cardiomyopathy and then upgrading it. The practical challenge will be whether that left vein, the subclavian vein will be patent. If for some reason the subclavian vein is not patent, and if you are have to upgrade, as well if there is a need for a dual chamber, then probably switch over to the other side and start pacing and cap this out. That we have done in a grown-up tetralogy. There was a tetralogy with a complete heart block, 10 years down the lane, developed this vein occluded, but that patient needed an upgrade, so we could not get it recanalized. Actually, we tried to recanalize also. In such cases, what we do is we put in a little harder Cordis-like right coronary artery catheter into the left subclavian vein, and then drill wires through the subclavian vein and get it across. Once we get it across, then pass some hydrophilic balloons like Boston Scientific Mustang balloons or very slippery balloons. So do with some 4 millimeter or 5 millimeter balloons, take it across and try to dilate the pathway. Once we get a pathway, park a wire across, then use that wire to puncture here and then drill along this way. In one particular patient, we got a puncture in the vein, but because of the like dilatation and the irregularities that we have created, this wire won't cross this way. So we opened out a snare, got it, dragged it down, got it up to the RA, and then left it, and then used that to create like that. Sometimes we try to recanalize. Recanalize means around the sheath. Try to go. Not thrombus, fibrosis, total fibrosis. Yeah, it will be totally like a thermowire. This particular patient where we were having a completely occluded, it was like a Conquest Pro wire. We kept on drilling. After getting it, then some 1.5 millimeter balloon, then 2 or 3 millimeter balloon, coronary balloons, and then tracked that coronary balloon with a 5 French RCA guide deep inside. Then through that put in a catheter, and we got a guide wire now, and when we inject through the guide catheter, good flow was there. But when we come from here, it won't enter. It will go and hit against all the places, it will not enter. So then through that guide catheter, we opened out a small 10 mm snare at this point, and then got this wire inside, dragged it in like that. So actually once I did with St. Jude, I think Anindya and Ullas has tremendous experience on that. Once I did with a St. Jude, extremely hard to use. The patient whom we did, it was an adult patient who was some post-operative, so it was not a major problem. But it was such a rigid system. It was so rigid. The fortunate thing is, the lead is here. If you screw the Medtronic lead, it's so flimsy that sometimes it doesn't have the ability to penetrate if that ventricular septum is not very soft, very like maybe post-operative and all. Sometimes they are very. But these leads, these St. Jude-like leads, they are very hard, no? So you have a stillet, and then they give you an adapter. That adapter fixes it. Then you are now actually rotating that whole adapter. That whole adapter walks in much more faster than the Medtronic lead. Even though Anindya was mentioning, there is a step, like the screw is smaller in diameter, and the lead is 6 French, so it's a little larger. In spite of that, by the sheer strength of that lead, it penetrates much more faster. Whereas Medtronic lead is very soft, so it is sometimes it penetrates with very, like in scarred septum, it is tough to penetrate. Advantage is that it is so small that it does not I feel that the chances of losing the vein patency, the chances of creating secondary tricuspid regurgitation by plastering the leaflets are all little less. Feel so. Yeah, I was yesterday mentioning to someone, there was a patient who had an ASD and BSD surgical closure when the child was small, when had some tricuspid suture annuloplasty. Then at a particular time, the tricuspid leak became so severe that there was a separate tricuspid ring annuloplasty. Then the patient grew up and finally had to be put in. No, I think it was originally ASD, BSD or DORB, something like that. So then tricuspid valve was replaced. So a bioprosthetic tricuspid valve is a notorious thing to produce heart block. You are actually suturing it against the anteroseptal commissure. No? So heart block is very common in tricuspid valve replacement. So this patient developed a post-operative tricuspid valve, like a post-operative heart block. Epicardial thresholds are all very bad because previously already 3 times operated. So every time, if you look at the post-operative patients, how they do the sternotomy and all, heart itself will not be seen. Some whitish membrane, leather-like membrane will be seen on the surface of the heart. Like, literally, you will not see good muscles and all. So the entire area, whatever they are visualizing, is completely useless. Wherever you poke, the thresholds are high. So finally, the only way to pace will be endocardial. Now endocardial through a tricuspid new bioprosthetic valve, which actually can create like dysfunction of the tricuspid valve. But fortunately, since this lead was so slender, we decided to take it up. We put in a conduction system basic, so we were quite proximal. So we were able to get reasonably narrow QRS, and we had a 4.1 French lead going through that bioprosthetic fresh valve. Maybe now 2 years down the lane, not much of tricuspid regurgitation at all. This would not have been possible at all with a 6 French lead. With a 6 French rigid lead, totally leaflet will be plastered. One leaflet will go into one corner. So it's to some extent it is very friendly on the tricuspid valve and very friendly on the vein. The scary moments are, some say that ring fractures, rarely somebody is reporting. So such things are very worrisome. If it happens to our patient, then we will actually redoing a pacemaker within a short period is something very, very bad, very, very depressing thing to do. So I mean, but such ring electrode fractures are very, very rarely described, and that is one of the reasons they say is against a Medtronic type of lead and more better to use a regular 6 French leads or fillet driven leads. I mean, there is a thought process. What is the incidence of that? Yeah. Something like that. But for an individual practitioner, even one case should be very irritating thing to happen. Maybe the incidence truly, it's like ambulance device erosion. 1 in 1,000. To hear it, it is very rare. But if it happens to you, it is very depressing. Something like that. So we will probably conclude the day, and thank you all. It's a pleasure to have all of you here.